This is like the sharpest brains in the country are talking like this. I can imagine what the others are. The others are devoid of deception, self-deception.
I do only 3 days a week. Or already 4 minutes late. So yeah, people have flights to catch. The house, madam, shall we start or wait?
Dr. Sharad, please start.
Good morning, all. Today is the second day of CRC 2024. We have a overwhelming response yesterday. The hall was full, and you notice that when we try to take a photograph, photographer couldn't, put everyone into the picture, so we had to take another picture again. Again, welcome you all for the second day of the session. The first session is on vasculitis and autoinflammatory diseases and inborn errors of immunity. Now I call upon the chairperson, Dr. Rajeshwari, panelists, Dr. Shankar Naidu, Dr. Ramesh Joyce, and Rapporteur Praksha Dwivedi. Over to you, madam. So, Mike. Madam, we have to score by the end of the session. We should be able to mark it and give it to the scientific chair.
So it will come like this. 10 marks for each. 10 for each. 70 marks. 60. Okay. Last column is good. What is score with it? Where is my pen?
Now I call Dr. Sandeep Balakrishnan to present his case.
Good morning, dear friends. I thank the organizers, especially Dr. Sarath and Molly, my dear friend, for this wonderful conference and making me participate here in this going to be the following session, which is going to be very fiery and full of contradictions. And I must admit, I'm not aware of quite some of the new information here. Let us learn more from this session, and it's open to all for their interactions, and all the best to the presenters, and I'll say hi to my colleagues here, Ramesh, Shankar, and Preksha. All the best to all four of us first, and then only to the presenters today. So let's start.
Yes, sir.
Off we go. It's over to you, Dr. Sandeep.
Yes, we can start. Good morning, all. Respected panelists, my dear seniors and my colleagues. Today I will be presenting a case of a 15-year-old boy who is born out of a non-consanguineous marriage. His symptom starts at the age of 13 years. At that time, he had an acute abdomen with right testicular pain. He was diagnosed as a case of testicular torsion, and he underwent an urgent orchidopexy. On post-operative day 4, he developed high-grade fever without any localizing features. After 1 week, that is the second week of his admission, he developed cutaneous infarcts and multiple peripheral gangrenous areas, including the right toe and both the pinnaes. Yeah, so the picture shows the gangrene of his right third toe. But there was no history of any headache, focal deficits, numbness, or paresthesia. There was no history of any arthritis, oral or genital ulcers, photosensitivity, alopecia, Raynaud's phenomenon, or there was no history of any facial puffiness, hypertension, or frothyuria. On investigation, he had a HB drop from 11 to 6 gram per deciliter without any bleeding manifestations. And it was a normocytic normochromic anemia without histiocytes and a reticulocyte count of 2% with an elevated LDH. So since he had severe anemia, he received 1 unit of blood transfusion. But post-transfusion, he had a severe breathlessness. It was thought to be post-transfusion reaction, and he was shifted to the intensive care unit. At the time of his ICU admission, he had mainly 4 issues. One is the worsening of his breathlessness with bilateral chest infiltrates requiring non-invasive ventilation. Second, he had a progression of his gangrene to involve the pinnace, bilateral upper limbs and lower limbs. Third issue was the further fall in hemoglobin to 2 gram per deciliter. And the fourth issue is a new onset of thrombocytopenia with the lowest platelet count of 25,000. So the pictures, we can see the pictures of the peripheral cutaneous infarct in the lower limb and both the upper limb, in the upper limb showing gangrenous areas. And since he had extensive gangrenous areas, he underwent an lower limb and both upper limb and lower limb Doppler and a 2D echo, which was normal. Since he had severe cytopenias of anemia and thrombocytopenia, an autoimmune workup has been done, and his ANA was showing 4+ homogeneous pattern, anti-dsDNA of 54, and his ENA blot was showing 1+ positivity of Smith RNP, PMSCL, and ribosomal P. His antiphospholipid and his lupus anticoagulants were negative, but his blood cultures grew Staphylococcus hemolyticus. So in the background of this multiple gangrenous areas and cytopenias and multi-system involvement, it was thought that he had an infection related, that sepsis related gangrene, and he was treated with broad spectrum antibiotics, PRBC transfusions, intravenous immunoglobulin and steroids at 2 mg per kg. With the above treatment, he had an excellent response. He improved after 1 week. There was no further progression of his gangrene. His cytopenias improved and dyspnea also improved. Over the next 2 months, his steroids were tapered, and for the next 2 years, he was completely on remission without any treatment, and the necrotic areas underwent autoamputation. At the age of 16, he came to us. So with a relapse of his disease in the form of a new onset cutaneous infarct in his left thigh. So this picture shows the new onset cutaneous infarct in his left thigh. His family history is notable. His elder sister is a biopsy-proven class 4 lupus nephritis who received cyclophosphamide induction followed by MMF. He was diagnosed at the age of 12 years, and currently she is in remission under nephrology follow-up. On reevaluation, his inflammatory markers, that's ESR and C-reactive proteins, were elevated, and his hemogram, liver, renal functions, and urine routine examinations were normal. And his ANA was 4+ homogeneous pattern, but his ENA blot, antiphospholipid antibodies, ANGA were negative. His complements were within normal limits. So the differential diagnosis, if we see the whole course of his disease, first possibility we thought of ADA2 deficiency. The points favoring ADA2 was he's a young male who had a polyarteritis nodosa-like presentation with an acute abdomen, testicular torsion, digital ischemia, cutaneous infarct with hematological manifestations, and a sibling with an autoimmune disease like SLE. The oddities for ADA2 were, he didn't have the absence of a livedoid rash, hypertension, headache, CNS manifestations like ischemic stroke, seizures, then mononeuritis multiplex, fever, the specific cytopenias like pure red cell aplasia or lymphopenia or neutropenia. There was no immunodeficiency, and an ANA positivity, which can also occur in ADA2, but it can place down, the points can be placed down. And he was absolutely on remission for the next 2 years without any treatment. And one more thing, actually we sent the ADA2 levels. It was actually, the result came a little bit later. It was normal, so that can also keep as one of the points among the oddities. Second possibility is a catastrophic APS. The points favoring the CAPS were, the patient is a okay, younger age group with this ischemic symptoms, digital cutaneous infarcts, which can have autoimmune hemolysis with severe thrombocytopenia, and he had an acute worsening with a multi-organ involvement, which is precipitated by a surgery, which usually we see in a CAPS. And the ODT, he was seronegative for APS, and the improvement without an anticoagulation or pulse steroids, that's also ODT for CAPS. Third possibility is lupus. Lupus, he's a young male, younger age group with a hematological involvement with a sibling with a autoimmune disease, that is itself lupus, and a 4+ homogeneous ANA. But ODTs, clinically, there was no mucocutaneous, no musculoskeletal, and no renal involvement. And ENA repeat was at our center was negative. So we actually treated for his, currently he had a minor organ flare, so we treated with methotrexate and low-dose glucocorticoid, and he had an excellent response over the next 6 months. His infarcts, everything improved, the skin infarct. It was just in the posterior thigh, it improved. So since he's a young male with an autoimmune feature with a strong family history, we went ahead with the genetic testing. We expected it could be ADA2, but it came to a SOX1 mutation. It's a heterogeneous mutation it's a deletion mutation in the SOX1 gene. It's the location of the exon 2 and chromosome number 16 with an autosomal dominant inheritance. Few points about the SOX1 protein. It's a protein which downregulates the cytokine signaling pathway. It inhibits the JAK-STAT pathway, and we just refer the literature. So the SOX1 protein mutation can have a typical features like autoimmune cytopenia, hemolytic anemia, thrombocytopenia, and lymphadenopathy, and variable features. Our patient have the 3 out of the 4 typical manifestations. And this is a case series which shows the features like IT can have ITP, can have Evans-like presentation, SLE-like presentation, skin lesions like psoriasis, and rarely it can have lymphadenopathy, hepatosplenomegaly, and lymphomas. So the questions to the experts, which I would like to discuss, what are the differential diagnoses in this case if you don't have a genetic diagnosis, and when to suspect ADA2 deficiency, and is there any correlation between his genotype and phenotype?
Thank you, Dr. Sandeep. It was a beautiful presentation. I think Dr. Shankar will take up this case first, and then after him, Ramesh also will discuss.
Thank you, Dr. Sandeep, for bringing this patient, discussing this patient here, because actually I had to read a lot about this mutation. I have to admit that I did not know about this mutation, this particular entity before that. So I have few comments and questions regarding the clinical presentation of this patient. Regarding the first presentation when he had this testicular torsion and followed by the worsening of cytopenias and hemolysis happening. What was the coglogram like at that time? Was it normal, or was there any evidence of...
There was mild prolongation of his APTT, sir, at that time.
Okay.
But repeated investigations were normal.
Normal.
INR and there was no evidence of any disseminated intravascular coagulation at that time.
Okay. So I think that at that moment it could be a drug-induced or infection-induced TMA, because DADA2 to present with hemolytic anemia and severe thrombocytopenia would be very odd, especially in patients who are having a vasculitic phenotype of presentation. There may be overlap of vasculitic and hematological involvement, but usually those patients who are having a vasculitic phenotype will less likely to have a hematological manifestation. So, and also testicular torsion is not what we expect in medium vessel vasculitis. It is usually in testicular infarction happening because of the medium vessel involvement. So that is one oddity to think for medium vessel vasculitis from presentation. And what about the APLA workup during the second presentation when he had
cutaneous infarct, relapse of the disease? APLA was negative.
Negative even the
APLA and LAC was negative.
So I think SOX1 can explain the clinical presentation. Retrospectively thinking, SOX1 would explain the clinical presentation, because the case series that you have shown has actually said that around 2 to 3 patients out of those 10 patients had lupus or lupus-like phenotype. So coming to your second question, when to suspect ADA2 deficiency, especially in patients who are younger with CNS involvement, either ischemic or hemorrhagic stroke, with peripheral neuropathy and who are usually not responding to usual dose of corticosteroids and immunosuppression like cyclophosphamide. So that is when we suspect, and we have published one series from PJ, including various cases from different centers in India. What we have seen is it is more common in Jain and Agrawal community predominantly, especially in most of the patients from north of India were from this community. So whether this patient also belongs to that community?
No, sir, he is
no.
not from.
So that is one point against ADA2. And regarding the correlation between this phenotype and genotype, I think as for the case series that has been given, we can safely say that this mutation can be the driving factor in this patient.
Ramesh?
Did you screen the sister for the SOX1?
No, sir, we have to.
Okay. Because when you have a mutation and you have a family story that is so similar, to me this appears like a monogenic lupus. We've discussed it so much yesterday and I learnt a lot because being an adult rheumatologist, I don't see pediatric patients, but I learnt a lot yesterday. And a lot of it with a very strong positive ANA, nothing else. And you can expect normal complements. That's what we were told yesterday in monogenic lupus. If you have the option of doing a CH50, that is, something that is suggestive of an immune activation. To me, the first episode looks more like an infection. When you have grown an infection in cultures, I don't think we will think of sending DADA2 and all that in the very first instance. We have to think about common things first. Though we are all excited about DADA2 today, still infection is more common than DADA2 in our community. So I would treat the first episode because the first episode was treated only symptomatically. There was very little or no immunosuppression and the patient made remarkable recovery. So putting all this together, to me the first episode looks purely infection. The second episode to me appears, even though it's a small manifestation, it's a definite vasculitic manifestation. Given the strong positive ANA and a sister who has lupus, to me this appears like monogenic lupus. Treatment-wise, whatever is required you've already done because it's a minor manifestation. But maybe I'm sure you would have added hydroxychloroquine also, though it was not written there. But to me this appears more like a monogenic lupus rather than DADA2 or any other cause.
What about the gangrene and the vasculitis component? That is not minor, no? That's not a minor manifestation.
No. The first time when the gangrene happened, everything got better only with treatment of infection.
And IVIG and
yeah,
2 milligram
IVIG is not
IVIG.
a great treatment. I mean, if you had a gangrene of that magnitude in vasculitis, it is not going to respond only to IVIG. You would need a drug like cyclophosphamide, otherwise the whole limb will drop off. It is not only the dry areas. So, and the gangrene would have been progressive had you not. Because how long will IVIG work? It's going to work only for 2 weeks. Beyond 2 weeks, IVIG is not going to do anything for you. So, given the fact that it gave you some time to think, to tide over the crisis period because you were not sure whether it was infection, whether it was autoimmune, till you got some of the investigations at least. So, in that way, I think IVIG helped you temporarily. But I think it's mainly the treatment of infection and the natural course of the problem.
Was a biopsy done for the ulcer?
No, ma'am. No.
The cutaneous ulcer?
No.
You showed the infarcted area?
Yes, ma'am. Biopsy was not done, actually.
That is another point, no? That's kept pending.
If it is.
Okay. And then you said there was no we ruled out pure red cell aplasia. Was a marrow done? Bone marrow done?
Bone marrow was
He had
not.
a persistent thrombocytopenia.
No,
and
because
his hemoglobin dipped down, so
bone marrow was
low,
not done.
no?
Not done.
And why so many transfusions?
But
I mean,
HB
once
was,
we give steroids, if it's going to be an autoimmune hemolytic anemia or anything like that, of course, his hemoglobin had dropped down to
2 grams.
You had written multiple blood transfusions.
But 10
isn't
units
it?
he received. 10 units over this ICU stay.
And one of the causes for transfusion reactions is lupus again. Because the blood groups are very contradictory in lupus. They can have AB positive, A1, A2, B positive, and unless the grouping is done properly, they can develop transfusion reactions. That is another way of looking at it as far as the treatment part of it went on. And then, DADA2, by what method did you all do it? This I looked up and I read, to be honest, because we are not very good at the methods of doing ADA2.
This was
You
done
did by exome sequencing?
Ma'am, for this ADA2 level was done by ELISA. For in our research
They
lab.
say enzyme assay is the best because hidden levels also can be missed by the regular exome sequencing and other methods. Okay. Why methotrexate afterwards? Why? I mean, there are so many options for you to choose. It is your choice.
Because no other cytopenias at that time, no renal involvement. So.
What about TTP? Shankar raised the point of TTP also.
Well, for the first presentation, I think I feel that it is more of a TMA or TTP kind of presentation because this patient had underwent a surgery. And there are multiple drugs which can precipitate TMA. And I think the muscle relaxants are very notorious to cause TMA. So all his initial hemoglobin at presentation was 11 and subsequently fell down to 2. So all these things have started 2 days after the surgery. So the time course is fitting well into some drug exposure during the surgery and also antibiotics, probably penicillins might have been given thinking that it is an infective etiology for the testicular pain as well. So there are multiple risk factors to precipitate a TMA. And also SLE, also we know that it can precipitate TMA in some patients. So he already had this SLE-like phenotype. So probably there are multiple factors which has led to TMA at that moment. And with IVIG, these things have resolved. So I think the response had come to IVIG. So, and if it was a vasculitic manifestation, especially if it is DADA2, what we have seen is that they usually don't respond to even high-dose steroids or cyclophosphamide, and anti-TNFs are the drugs which will help in majority of the patients, which was not given in this patient. Despite that, this patient had relatively normal course for 2 years. So that is again another point against DADA2.
But you mentioned in your slide, there are no schistocytes.
No schistiocytes actually.
There are no schistocytes.
No schistiocytes.
And tell the answer, isn't it?
Yes, ma'am. LDH was mildly elevated. Mildly, ma'am. It was 1,500 LDH.
1,500.
And one peripheral smear report only we have.
And the pickup rate of sensitivity of cystocytes is about 95 to 96%. So there are still 5 to 6% of patients where cystocytes might be normal but still having behavior.
Would it still have been CAPS? You said the coagulation profile was negative. What happens in CAPS?
Extensive thrombosis and multisystem involvement can happen.
It can
Requires
be negative,
some improvement
during
without
a catastrophic episode, it can be negative, no? Because everything is consumed.
Yes. But once we...
So what is your final diagnosis now from your side?
The phenotype can explain by his genotype, so we kept as SOX1.
You want to blame the gene only now. What is your clinical diagnosis?
Clinical can think of a monogenic.
So many DDs, no? Would you like to put a single diagnosis here?
Monogenic lupus.
You want to go back to monogenic lupus? Yes, to the audience. Yes, Amita ma'am.
No, I just wanted to share with Naidu that it's not always you need anti-TNF. We have 11 patients with ADA2 deficiency and we have given anti-TNF only to one patient, and that also for a short while. You can manage with other drugs. It's not that they do not respond. If they do not respond, you need to give anti-TNF, because in our country, anti-TNF is an expensive therapy. Like if you talk to Dan Kastner, he says even if you find it in a normal sibling, you start anti-TNF. It's a way of looking at things. Our patients do very well with cyclophosphamide, methotrexate, azathioprine, even the cytopenias. Like we were amazed, we have 2 patients who are presented with hematological manifestation where people say you should go for transplant. And we have treated them with azathioprine, their cytopenias have recovered. So it's a very varied phenotype and varied response.
Anybody else from the audience? Nobody? Kaushik?
Question is going back to the sibling. So the sibling has been treated as lupus, and here you're finding a lupus-like phenotype where you're blaming a genetic mutation. So should we go back and look at the sisters for you to be able to actually isolate and say, is this really a SOX2, or have you just found something and we are trying to put everything into one basket?
I think we should screen the sister as well, because in the 10 case series that they have shown, one of the patient had glomerular nephritis, which was biopsy proven, immune complex mediated. So, and apart from this, there was also another case report, I guess, SOX with SLE, like SLE patient diagnosed as SLE, later on diagnosed with SOX1 mutation. So even the sister presentation is very well fitting into this case. That is why, sir, I think it is a SLE phenotype with SOX1 mutation. That would explain the entire course of this patient.
Thank you.
Data to deficiency, how long we continue the TNF? One veterinary student one veterinary student came with
That's a very good question.
recurrent stroke even. He was a second year or third year PVSC student in our. How long we continue the TNF blocker? Amita ma'am.
So I don't think we have an exact answer for that question, but as long as the patient is affordable, I think we should continue.
The
Because
recommendation is lifelong.
Lifelong.
And recommendation, actually, that's what I said. When Dan Kasnat came this February, we were asking him that if we find in the, we are not testing the family members because we can't offer anything. Because once you test, it becomes very difficult to say, and patients cannot afford. So he said, no, you should test for all of them, because those
Yes.
12 patients have siblings. And he says, if you find in them, you start anti-TNF without even having any manifestation to prevent strokes. So that's a different way of looking at things.
we have a couple of patients who were having recurrent strokes before giving anti-TNF. They haven't responded to high-dose steroid cyclophosphamide for multiple years. And once they were started on anti-TNF, they have almost like 3-4 years, they haven't had any recurrence of strokes. So this has been documented well from other centers as well. So if the patient is affordable with anti-TNFs, you have to continue lifelong, because this is genetic mutation and that is leading on to deficiency in the enzyme. So until we have an option like something like the gene replacement therapy where the enzyme levels may be replenished, till that time I think we have to continue anti-TNFs.
Thank you, sir. Thank
Just
you.
about,
Thank
between, even I have patients on methotrexate, MMF. What I tend to do is, if somebody's got a major organ involvement, if it is a stroke, the recurrence of stroke is going to be high, and stroke is going to be devastating. There I would pursue the patient to go for anti-TNF. But if it's a minor manifestation, if it's a minor cytopenia that responds to azathioprine, MMF, I don't mind. I mean, because that's not going to be life-threatening for you, at least for now, till you have a arterial event. And I mean, obviously, I'll screen for aneurysms and all those things. If I don't find any vascular abnormality, then I would just go for, like Madam said, azathioprine, methotrexate, MMF, any of those drugs. But if you find a stroke, if the presentation is a stroke, I definitely anti-TNF.
Yes, all of us. There are certain indications where anti-TNF drugs are indicated. But then, even for other diseases, we never follow the guidelines, no? Because of the economic status. So we do it according to our convenience and the patient's convenience. We can space it out, 6 months, yearly once, etc., etc. If there are no more further questions, so what does the audience feel? Is it DADA 2 or lupus? Amita says lupus. Monogenic lupus. Anybody else? Lupus. Okay.
Thank you, sir.
Thank you. Great effort put into the workup of the case and the presentation. Now we move on to the next presentation by. You can introduce yourself.
Yes.
The next presentation is
Good morning, respected dignitaries and
GP.
my colleagues.
Yes.
I'm Dr. Rekha, resident in KIMS. Today I'm going to discuss an interesting case of GPA presented as aortic valvulitis and pulmonary renal syndrome. So 60-year-old male patient presented to the cardiology department with exertional dyspnea and bilateral lower limb edema over a month. And he was diagnosed as a decompensated heart failure with severe aortic regurgitation. Treated with diuretics, beta blockers, and underwent aortic valve replacement. During the surgery, CT surgeon has noticed abnormal morphology of the native aortic valve, that is thickened valve leaflets. So he sent the sample for histopathology. And he was discharged with oral anticoagulant and antihypertensive medication, and the patient was lost to follow-up after that. So 1.5 years later, he again presented to the cardiology department with hemoptysis, exertional dyspnea, and bilateral lower limb edema for 10 days. And dyspnea worsened over 2 days, which is associated with orthopnea. And there was no history of constitutional symptoms or other CTD symptoms. And on evaluation, hemoglobin was low, 5.5 gram per deciliter, and raised inflammatory markers, CRP20, and routine urine examination showed 2+ proteinuria with microscopic hematuria of 20 RBC per high power field, and a serum creatinine of 10 milligram per deciliter. So chest X-ray was done, which showed diffuse consolidation with reticulonodular opacities in both the lungs. And ABG suggestive of type 1 respiratory failure. So the provisional diagnosis was pulmonary renal syndrome. At this point, rheumatology referral is given in view of pulmonary renal syndrome. So general physical examination, he had pallor and bilateral pitting pedal edema. He is tachypneic, tachycardiac, and a saturation of 96% with 3 liters of oxygen. And respiratory system examination showed bilateral diffuse crackles, and the rest of the general and systemic examination was unremarkable. So upon further investigating, ANA-IF was negative, 24-hour urine protein was 2 grams, and both the complements C3 and C4 were low. P-ANCA was positive, C-ANCA is negative, and MPO antibody show high titer positivity. So we have retrieved the histopathology of the aortic valve, which was done 1.5 years back, and it revealed the dense perivascular lymphoplasmacytic infiltrates with fibrinoid necrosis within the stroma with scattered vague granulomas, as shown with the arrows in the picture. So it is suggestive of vasculitis. So renal biopsy done, which showed crescentic glomerulonephritis with focal global glomerulosclerosis, mild interstitial fibrosis with tubular necrosis. So he was diagnosed as GPA with pulmonary renal syndrome with aortic valvulitis in the past, status post aortic valve replacement. And he was treated with pulse steroid methylprednisolone 1 gram for 5 days, followed by oral prednisolone of 0.5 mg per kg per day. And he underwent 4 cycles of plasmapheresis and 6 sessions of hemodialysis and induction with cyclophosphamide 500 mg once in 2 weeks. And maintenance with azathioprine, and on follow-up he is doing well with a serum creatinine of around 5 to 6 milligram and on maintenance hemodialysis twice a week. So coming to the discussion, GPA is a multisystemic necrotizing vasculitis, most common involvement in upper and lower respiratory tract and kidneys. The cardiac involvement can be seen in the form of conduction abnormalities, pericarditis, myocarditis, valvulitis, coronary vasculitis, and MI. So the valvular involvement in the form of valvulitis leads predominantly to the regurgitant lesions and sometimes to the stenotic lesions. So majority of patient with aortic regurgitation based on GPA necessitates the surgical repair. So the recent review of a case report of 36 cases in which the 41% of cases have isolated lesion of the aortic valve. Among them, 66 patients underwent aortic valve replacement. So my question to the panelists were, management of isolated aortic valvulitis, whether surgical alone or along with immunomodulation, and the choice of immunomodulation, when to suspect vasculitis in patient with isolated organ involvement.
Ramesh, it's yours.
Okay. Before we start, I just have a couple of questions. This patient presented with an anti-GBM disease, an renopulmonary syndrome.
Yes,
Just wanted to check, have you done an anti-GBM by any chance?
yes, sir, negative, sir.
That was negative. And what was the immunofluorescence on renal biopsy? Because that was not mentioned on your
Negative,
presentation. Negative? It was a posse immune.
Posse immune.
So then it would fit in with a vasculitic syndrome. Now, few things. How would you explain the low C3, C4? Your ANA was negative.
ANA was negative.
You had an ANCA positivity and MPO ANCA positivity.
Renal rapidly progressive glomerulonephritis can have. So RPGN can have low complements.
So more than
undergoing
saying
inflammation.
RPGN, vasculitis can have low complements. Autoantibody overlaps are significantly described. For example, you can have a lupus nephritis patient who's ANCA positive, and when you have an ANCA positive lupus nephritis, it's known that their prognosis is poorer. You have an ANCA associated vasculitis, and occasionally you can have a low complement in them. And when ANCA associated vasculitis is associated with hypocomplementemia, once again it indicates poor prognosis. That's why you have seen a rapidly progressive glomerulonephritis. So there is some description of low complement also even in ANCA vasculitis, but it's not a common feature. But when you have a strong positive ANCA and a negative ANA, you can attribute it to that. So coming to the phenotype, why did you choose GPA over MPA? If I say this is MPA, would you argue or would you agree? Or does it matter?
Histopathology is showing granulomas, sir, which is an odd point towards MPA.
So your histopathological description said vague granulomas. That was the description you had given. Anything vague histologically can't be taken on its face value. But does it matter actually? Doesn't matter. Okay, whether what label you give, it doesn't matter, because aortitis, valvulitis is well described in both phenotypes. Whether it is GP or MPA, it is described in both. The patient has severe renal pulmonary syndrome and the treatment is probably going to be the same. So you have an ANCA to latch on. So you have an ANCA associated vasculitis. Whether you want to call it an MPA or a GPA really doesn't matter. An isolated granuloma may be suggestive, but not a diagnostic feature.
Actually, initially with MPA positivity, we also thought of, Pianka positivity, we also thought of MPA only, sir. After retrieving that report, histopath report only, we went towards GP.
Sure. I mean, if it was definitive granulomas, maybe yes. Since you said vague, that's the reason I asked. But honestly speaking, to take therapeutic decisions, it really doesn't matter. Both are going to be the same. Okay? Then coming to therapeutics, I mean, one thing I've been seeing from all the presentations since yesterday is everybody's got a fancy for 5 days of IVMP. Yesterday, when dermatomyositis was presented, I assumed it was the neurologists who were doing this job because they have fancy 5 days of IVMP. Where did rheumatologists start taking off with 5 days of IVMP? Even your Pexivas trial had only 3 days of IVMP. So why the 5 days? We understand very well in vasculitis or any other illness, it is the steroid that kills as much as the disease. So we have to be cautious in terms of our immunosuppression. So there is no scientific rationale for 5 days. We know that there is no data for 3 days, there is no data for 5 days either. Okay? But in the general recommendations for any severe vasculitis would say that maybe 3 days, yes, I'd agree. So that's point one. What was the weight of the patient?
80 kgs, sir.
80. So, cyclophosphamide 500, because that is the other thing that I would want to point out. In somebody with renal dysfunction, how much cyclophosphamide would you give in somebody with such severe vasculitis?
Actually, high dose of cyclophosphamide needs to be in 3.
So you might reduce it from 15 to 12.5 milligram per kilogram at least. Okay? Or if the patient is above 65, you might reduce it to 10 milligram per kilogram. That is what was the the trial of cyclophosphamide, intravenous cyclophosphamide. So one important thing is don't underdose medications. I don't think you should be so much worried about cyclophosphamide toxicity, because I think when you're bold enough to give 5 grams of steroids, I think you should be bold enough to give cyclophosphamide also. Because cyclophosphamide works beautifully in this situation. And how many pulses of cyclophosphamide did the patient receive?
6.
6. So just be careful, because sometimes if somebody with a severe manifestation as this, if the patient is doing well, we should not stop cyclophosphamide in between. If you look at the US protocol, you would go for 8 to 9 doses of cyclophosphamide. And I would go for it because it is not about treating the acute situation, it is also known to prevent relapses. The trials that looked at cyclophosphamide, when it compared IV versus oral, both were good, but oral was slightly marginally better in preventing relapses, but IV also prevented. So you're also looking at complete disease suppression. So underdosing, I mean, it's not just you, but I find this lot in people. People just give random doses of cyclophosphamide. That should be avoided, and US protocol has to be followed unless there is a strong reason not to. So that's one point. Then finally, your maintenance therapy, why MMF?
Azathioprine.
Sorry? You written MMF there.
No, ma'am, I haven't mentioned actually.
Is it? Okay.
You said azathioprine, right?
Ah, yes.
You haven't mentioned here, but I think you
Because
said.
I think we had the original presentation, no? It was said MMF. That's why I put this
The
question.
presentation which we got in the mail, I think it was shown.
Yeah. The other presentation that we were sent, it said MMF. That's why. But if you've given azathioprine, that's okay.
Azathioprine.
Yeah.
Why wouldn't you give MMF?
He was doing well after the cyclophosphamide induction, and there is no requirement of such a, and cost constraints also. MMF is more costlier than azathioprine, so we go ahead with azathioprine.
I think your answer should be that the data for relapses is better with azathioprine compared to the MMF. MMF should not be used in vasculitis in all patients. It is to be restricted only to the renal phenotype of P-ANCA type, where for some reason you're not able to use any of the drugs and you're left with no choice but MMF. Because one common mistake that nephrologists do when treating a renal limited vasculitis is they equate renal vasculitis to lupus nephritis and everybody gets MMF, which is not the right thing to do, because relapse rates are very high in ANCA-associated vasculitis treated with MMF. So the one important observation that I saw was there was a delay in referral to rheumatology by 1.5 years after the aortic valve was found to have granulomas and, I mean, that's not your problem, but, from the surgeon's point of view, when they saw, aortitis and aortic vasculitis in somebody, the least they could have thought, and they had the histopathology also. Many times people don't even send the specimen to histopathology, they just dump the specimen. They could have made an early rheumatology referral. It just speaks about how poorly informed a lot of specialties are about vasculitis. But a good presentation.
Shankar, your contribution.
Regarding this patient, yeah. The CT surgeon, when he was doing surgery, he felt the valve, the morphology was a bit unusual. So he suspected something was going on. Then he sent. But by the time the report came, patient was discharged and patient was doing well. So it was ignored. And next time, he was admitted with rhinopulmonary syndrome. That time, our nephrologist sent a referral to us. And during the course of that disease, what we felt is actually, there was no good response to immunomodulation. So we came to that, probably it's a chronicity, there is no activity. That's the reason we stopped, not being aggressive. That is the reason we didn't continue cyclophosphamide for long. We waited for 6 months, there was no response. Now he's on maintenance hemodialysis. There is no disease activity.
The response was not just renal, it was also the pulmonary. So obviously you need to keep them on full immunosuppression. It is not just for the kidney. I know the kidney is gone.
Yes.
But for the lung, plus to prevent future relapses.
Thank you.
Shankar, quickly.
Ma'am, I think on renal biopsy, we haven't been provided the details, but I don't think whatever is being presented here is showing a lot of chronicity. Interstitial fibrosis is only mild. There is some tubular necrosis, and predominantly it is glomerulus, crescentic glomerular nephritis. very focal glomerulosclerosis. So chronicity was not there at the time of biopsy at least. So more immunosuppression, probably higher dose of cyclophosphamide as per the weight, and that might have made a little bit of difference. And probably using rituximab as a maintenance therapy would be a better option than even azathioprine, because even if there are financial constraints, 500 milligrams of rituximab would not be very costly. If you compare over a period of 6 months, it would be around 1,000 rupees per month. So that will almost be equal to azathioprine.
Okay, I have two basic questions addressed to you. You mentioned only about the chest X-ray with infiltrates. Here was a patient who had aortic valve regurgitation. It could have been congestive cardiac failure also. No? Before you commit that it is pulmonary renal, pulmonary component, it's advisable to do a CT unless the patient, CT is not very expensive. There are gross differences between bleed and pulmonary involvement of GPA versus CCF. The second thing is this patient had cardiac, pulmonary and renal involvement. So we go by the 5-factor score which is applied to PAN, and if we choose the 5-factor score, obviously cardiac manifestation plays a very grave, it's of grave importance, great importance. So ideally the immunosuppression should be high. And ideally rituximab should have been the drug of choice. Of course affordability is there, cyclo also does wonders.
But the cardiac involvement happened 1.5 years back, ma'am.
Sorry?
Cardiac involvement happened 1.5 years back.
That doesn't matter. Once it's affected, it's affected. Okay, target organ involvement is something that has to be addressed. There's no guarantee that other areas and recurrence, of course the valve has been replaced, but then other areas can be severely involved, isn't it? Thank you. Thank you for the audience.
Any comment on indication of plasmapheresis in this, and what is the usual approach we have to take regarding plasmapheresis when we have a renal involvement with DH?
So, I mean, obviously, we all know that plasmapheresis is a controversial topic now, especially when it comes to DAH. If you had done plasmapheresis, I would not fault you, for the simple reason that the kidney involvement was gross and there is a definite indication. So if you had done it, I wouldn't fault you. If there were cost constraints, I would not force you. You can argue either ways about plasmapheresis. When you look at the initial data, it said that it made no difference at the PEC-CVAS. But further subgroup analysis, when it was done, it was shown that people with a creatinine of more than 500 micrograms benefited in the long run because it prevented end-stage renal disease at a higher rate. So for the renal point of view, yes, plasmapheresis could have been an option, but then cost, and if the patient has made a remarkable recovery within 3 days of steroids, then why would you bother going for plasmapheresis? Alveolar hemorrhage, the verdict is still not open, because even at the PEC-CVAS trial, you had only about 25% of patients who had alveolar hemorrhage. And the subgroup analysis only for this lot of patients is still not yet published. So as of now, most of the recommendations say for an alveolar hemorrhage, no, but for a renal, definitely, yes.
We had a debate at IRACON also on the same topic, and I think audiences were 50% on either side.
We have time. Well, the valvulitis we've seen with lupus, I haven't seen with MP, and it affects, as you know, it affects certain areas of the valve. So I was just wondering if ANCAS is with such valvular involvement. That's very interesting. Nobody does a biopsy on aortic valve at 60. So the surgeon, and it is invariably the cardiologist who tell you that ye rheumatic fever wala nahi hai in lupus. They are able to make out somehow. It's less often in the chorda and the papilla, as we know, muscles in lupus. So whether there is a difference in vasculitis affecting the valves versus lupus affecting the valve, is there any data there or the same?
So, as such, cardiac involvement in ANCA vasculitis is less than 10%, and valvulitis out of those 10% would be even more or lless.
Would it be the same areas, or
I discussed with Aman sir, and he said I think he saw one patient out of the 400 odd patients we had, only one patient had a proven valvulitis. So based on one patient, I don't think we can say anything.
Yes, we'll close this case. Thank you everybody for your interaction. Nice presentation. Thank you. Dr. Sri Rekha. We'll move on to the next case. I think it's about Beshe. Some sealing, something. Over to you. You can introduce yourself.
Warm wishes of this morning to the August House. I am Dr. Rahul Bisrelli, Assistant Professor of Rheumatology at SDM Medical College, Dharwad, Karnataka. So I'll be discussing a difficult case of Behçet's with pulmonary artery aneurysms today. I have titled the case as Sealing the Deal, Managing Behçet's pulmonary artery aneurysm with immunomodulation and early endovascular care. So this was a 28-year-old male who was a photographer, presented to us in June 2023 with massive hemoptysis, significant respiratory distress, in shock. So he was treated by emergency team and pulmonology. He was intubated, mechanically ventilation was done, started on broad spectrum antibiotics, a chest X-ray was done. His complete hemogram was normal with raised acute phase reactants of ESR 42, CRP of 119, normal coagulation parameters, serologically negative with normal biochemistries of liver and kidney function tests. So what revealed in chest X-ray was mediastinal widening, and the shadows were suggestive of a vascular malformation, probably a aneurysm arising of pulmonary arteries. So a rheumatology referral was sought. So when we revisited his history, he had complaints of bilateral ankle pain and swelling, suggestive of inflammatory arthritis, and recurrent oral aphthous ulcers and genital ulcers. And patient, after he gained consciousness, he agreed to this fact that he had continuous oral ulcers on and off going on from Jan 2021 till June 2023. So coming back, so this we provisionally diagnosed him to be Behçet disease with Hughes-Stevens syndrome. So we did a pathology which was negative, sent a HLA-B51 assay which later turned out to be positive. We did a 2D echocardiogram to look for RV mural clot. As expected, he had a highly echogenic mass in RV, suggestive of thrombus. His APLA panel was negative. We planned for a CT pulmonary angiography. What revealed in CT pulmonary angiography was very grave for us as well as for the patient. He had multiple aneurysms in pulmonary circulation. As we can see here, right descending pulmonary artery had a huge aneurysm of about 3 into 3 centimeters. Left interlobar branch of the descending pulmonary artery had about 3.3 into 2.5 centimeters with in situ thrombosis. And in the lung window, we could see multiple areas of wedge-shaped opacity suggestive of active valvulitis, active vasculitis. Then even he had multiple aneurysms even in segmental branch of right upper lobe, segmental branches of the many segmental branches of pulmonary artery as well, which is not shown here. So what we did was we started him on prednisone 1 milligram per kg. We avoided pulse steroid as his ET culture by second day showed culture positive Acinetobacter. So then we started him on low molecular weight heparin 60 milligram, colchicine 0.5 milligram BD, continuing with his broad spectrum antibiotics. We took an emergency cardiovascular surgery opinion and as well as interventional cardiology opinion. They were of the opinion patient could have grave risk and undergoing a vascular surgical or an endovascular procedure, so it was abandoned. So the next in line, we discussed the second line immunosuppression with the patient's family as cyclophosphamide versus adalimumab. So they agreed, they took a decision to go ahead with injection adalimumab. The patient received 6 doses of adalimumab from June to November 2023. In November, patient had a relapse of hemoptysis, but it was not serious as in June. He had a moderate amount of hemoptysis which was managed in wards, not requiring any ICU admissions. So we stopped warfarin for him. We changed the line of immunomodulation from adalimumab to cyclophosphamide. He received about 2 doses. However, in December 2023, about 3rd week of December, he had again moderate amount of hemoptysis. Again, he was admitted, but not requiring ICU. So after that, we took a decision to refer him to endovascular procedures. All throughout from June to December, patient was on prednisolone at tapering doses and colchicine 0.5 milligram twice daily. So this was the serial X-rays from June, and this was the first instance of hemoptysis wherein probably a right pulmonary aneurysm rupture was happened and there was a bleed into the parenchyma. Then this was in December 3rd week. Again, he had hemoptysis. Probably this was slightly resolving. Probably he had some rupture from the left side. So we decided to refer him to Jaidava Institute, Bangalore for a possible endovascular intervention. So here, you can see angiographically, intraoperatively, this was the interlobar branch of left pulmonary artery, which had huge aneurysm. This was tackled by putting a covered stent here, so with minimal residual flow post stenting. So this was the right main pulmonary descending artery, which showed saccular aneurysm again, which was the mouth of the aneurysm here was small, so this was dealt with a modified PDA closure device, so with no residual flow across after putting. So this is a schematic diagram wherein we can see this is the covered stent. This was a wide mouth aneurysm, so it was dealt with by covered stent, and it was a small mouth aneurysm, so this was dealt with by modified PDA closure device. So this is a timeline of events from June to December. So initial presentation, he was on adalimumab, steroids and anticoagulation. At the first instance of hemoptysis, we stopped his anticoagulation, changed his line of immunomodulation from adalimumab to cyclophosphamide. Then we referred him for a endovascular intervention. All throughout, his CRP values correlated with his probable disease activities. At the instance of hemoptysis, he always had high CRP. This is a recent one in March first week, which is 6.9. So patient all throughout from December to March, he has received 5 pulses of IV cyclophosphamide of 500 milligrams. We went ahead and followed ELND protocol and given cyclophosphamide 500 mg every 15 days. So continuing is this prednisone and colchicine. We did not continue his anticoagulation. Patient as of March is doing well with no recurrence of symptoms. So reviewing the topic, pulmonary artery aneurysms can be congenital or acquired. Congenital can be Eisenmenger's, valvular abnormalities, or hereditary connective tissue diseases. Acquired are usually sequelae of pulmonary artery hypertension, idiopathic, or it could be associated with vasculitis, as our case, or it could be acquired due to post-infectious, malignancy-related, or traumatic. The data for Hughes-Tovin comes from this group, international study group for HSS, which consisted about 57 cases, of which 3/4 were males. 93% had recurrent hemoptysis with a mortality of 21%. Pulmonary artery aneurysms mainly were seen in interlobar and segmental branches, with 10% had cardiac thrombus. Rupture of aneurysms were seen in about 33 patients, where surgical endovascular procedures were done. An important point in this cohort was no patient had uveitis or retinal vasculitis. Oral ulcers were seen only in 20%, genital ulcer in 10%. So they found out early initiation of immunomodulation had favorable outcomes. CTPA still is the gold standard for vascular involvement. And look for signs of aneurysmal wall, loss of aneurysmal wall definition that indicates impending rupture. Usually these pseudoaneurysms have high risk of fatal hemoptysis. Intracardiac thrombus warrants anticoagulation, however, should be promptly stopped at any suspicion of leaks. Euler guidelines recommend IV cyclophosphamide pulses for at least 2 years. Anti-TNF can be used in refractory diseases. So this was a recent algorithmic approach wherein again they recommend cyclophosphamide and anti-TNF in refractory cases. This was evidence for TNF inhibitors, mainly comes from retrospective case series where they found out it is safe option in vascular Behçet's, and combination with second line immunomodulation would be better than monotherapy. The questions to panelists on dilemma we faced during managing the case was what should be the initial line of immunomodulation in a young male with Behçet's vascular manifestations, cyclophosphamide versus anti-TNF, as cyclophosphamide recommendations are to be given for at least 2 years. What should be the timing of referral for an endovascular intervention? What is the role of anticoagulation in case of cardiac thrombus with vulnerable pulmonary artery aneurysms? What is the time interval to wait for achieving a meaningful remission, and how do we monitor? And one more question which I felt would be relevant is Hughes-Tovin a completely different phenotype with association of Behçet's, or it's still a variant of Behçet's? Thank you.
Thank you for that nice presentation. It's over to Ramesh for his comments.
Hello. Thank you, Rahul. For me, this is a very severe vascular Behçet's with a tough case with a lot of therapeutic dilemmas. It's not an easy case to manage. It's any doctor's nightmare. So I have a few questions for you. You had the patient on adalimumab for almost 3 months. What happened to the RV clot after that?
Sir,
Because initially you had the patient on anticoagulation.
Yes, RV clot still was persistent, sir, at November. The second image we couldn't get the echo image. RV clot still it is persistent, sir.
So the RV clot is still there?
Still persistent.
Okay. Okay. So few things. What made you discuss adalimumab versus cyclophosphamide as your first induction therapy?
Sir, patient being a young male, and the recommendation is to go on for with cyclophosphamide for at least 2 years in URAL guidelines. So we discussed the possibility of a gonadal failure as he was an unmarried male. So the family came up with this decision to go ahead with adalimumab. Even they were ready to take the risk of recurrence also, sir. We told probably it may not work as well like cyclophosphamide, but still they. And we told probably we have used earlier, it has been used, this adalimumab has been used in refractory cases, so they took that decision to go ahead with adalimumab. So we gave, at the first instance of recurrence, we counseled them again and we gave them cyclophosphamide.
So I gather the patient is still taking cyclophosphamide.
Yes, sir.
As we talk, the patient cyclophosphamide is still going on.
He's on cyclophosphamide.
Okay. And what is the weight once again of this patient?
Sir, he was a lean male, about 48 kgs, sir.
Okay.
Yes, sir.
48.
48.
So probably you will need probably a little bit more of cyclophosphamide than what you are giving.
Sir,
okay. So two things. I wouldn't bother initiating a discussion about marriage. He should be alive to see his marriage. Because there are huge big pulmonary aneurysms, 3.5, 4 centimeter pulmonary aneurysms which are going to rupture any time. And the cardiothoracic surgeons backed out in the first instance.
Yes, sir.
Nobody wanted to touch him.
Yes, sir.
So he wouldn't be even alive to see his marriage. So the choice of immunosuppression has to be something that has to be the best for Behçet's. Although anti-TNF agents, yes, work, still today for somebody with very severe Behçet's, particularly vascular Behçet's, cyclophosphamide is the drug of choice. That is point one. If for some reason, they read up the literature of cyclophosphamide, they're completely against, irrespective of you trying to convince, amongst the anti-TNF, still infliximab is a better choice for vascular Behçet's than adalimumab. And infliximab not in our conventional dose of 3 mg per kilogram, what we give. Hello. Yeah, 3 milligram per kilogram what we give, it has to be 5 milligram per kilogram and sometimes as close as 4 to 6 weeks, every 4 to 6 weeks. So that is the dose of infliximab if you have to choose a biologic. So if you were to discuss the therapeutics with this patient and his family, my choice would be cyclophosphamide versus infliximab.
Yes, we discussed infliximab versus adalimumab. We gave them the options. They chose this due to the cost constraints.
Yeah.
Even adalimumab, they didn't take at regular intervals, sir. It was spaced out more than 15 days in some instances.
I mean, I understand it's easy for us to sit now and talk. It is more difficult for you when you have a patient sitting in front of you. But all said and done, I wouldn't have broached the issue of adalimumab at all in the first place. I would have just told them, your only choice is cyclophosphamide. Okay, that is point one. Because relapse rates are very high. I don't know about the 2-year business because, conventionally, once the aneurysms have been secured, the stents have been placed, I agree all of us have very limited experience of vascular Behçet's. All of us would have treated maximum 2-3 patients throughout our careers. And I have conventionally used it for 6 months and then switched over. Later on I would like to hear it from the audience and their experience. But this is just a thought, I may be wrong. From my discussions with the Behçet's experts, Hassan Yaziki and all had come to Bangalore, Professor Raskinelli. Behçet's compared to all other vascular TDs is one of the diseases with very intense inflammatory response. So whatever you are going to give has to be in very high doses for a very long time. And from this patient, obviously immunosuppression is going to be lifelong because we know that the relapse rates of aneurysms are going to be very high. So in terms of duration of therapy, it is going to be long term. In terms of choice of adalimumab is only reserved for minor vascular manifestations like a peripheral DVT or a non-responsive uveitis, which doesn't respond to azathioprine cyclosporin combination. Then I would use adalimumab. Otherwise, the choice is between cyclophosphamide and infliximab. And what was the thing? Yeah. Yeah, the dilemma of the clot, there is no answer. I mean, ideally, the recommendations say when you have somebody with a clot, make sure you don't have a pulmonary aneurysm, rule out a pulmonary aneurysm, and then anticoagulate the patient. But nobody says what to do when you have an aneurysm as such. So, I mean, there's nothing wrong in you very cautiously trying to do something, but obviously understanding that there is a very high risk of bleed. But hopefully, once since you have secured everything and anti-inflammatory therapy has worked, the clot might have stabilized now, even though you see it on echo. So these are my thoughts.
Just one point regarding the statement about intracardiac thrombus and anticoagulation. The guidelines, those are for the patients who are having intracardiac thrombus secondary to MI and other causes. I don't think they included the patients that are not. So for patients, I think, as in DVT and other arteries and thrombosis, we usually don't try to take anticoagulation from the.
Secondary to the disease, aggressiveness of the disease itself. So, and TNF blockers versus cyclophosphamide?
Yes,
the option was only
Yes.
between infliximab and Adali.
No, no, ma'am. We discussed all three drugs and the cost of each of it.
See,
and the duration also, sir.
Hughes-Stovin itself, which is a variant or a type of manifestation of Behçet with pulmonary aneurysm, ideally cyclophosphamide, a very aggressive dose, high dose cyclophosphamide, should have curtailed the aneurysm even before giving adalimumab. Adalimumab definitely was not, maybe, I mean, circumstances might have led you all to give Adali, but certainly that was not the drug of choice in the initial presentation, because cyclophosphamide is there, no? It is there, it's a non-expensive drug and it's going to produce wonderful results. The aneurysms might have melted also, we don't know. Yes, there was an impending rupture, but we have seen smaller aneurysms reducing in size. Cyclophosphamide is a wonderful drug for this. And why colchicine? It's there in the guidelines, I agree. But
he had
what's the effect of
mucositis.
colchicine in this particular vascular base?
Ma'am, he had mucositis, ma'am, ongoing.
He had-
Recurrent
okay,
ulcers, it was ongoing, so we continued colchicine.
Okay, over to the, you want one more?
Just one. You had another question on the timing of referral for vascular interventions. I don't think any one of us know what is the ideal time, but from Takayasu's, which is where more vascular interventions have been done, it is known that at least some degree of immunosuppression is important before subjecting them to any procedure. I don't know whether 1 month of immunosuppression is enough or 2 months of immunosuppression is enough, or whether somebody with a huge aneurysm as big as this can wait 4 months. So I think it's all due to mutual convenience. I would at least maybe 1 or 2 months of immunosuppression and then go for it before the aneurysm ruptures, because I've lost a patient of because there was a delay in taking an officer. So any time is fine, but ideally 1 month at least I would wait.
Again, what they have advised is he might have again pseudoaneurysms at the end of graft is what the interventionist told us, sir.
Dr. Anita?
I just wanted to say that it all depends on the physician how you convince, or how you talk. If you are not yourself convinced about cyclophosphamide, you will never be able to convince anybody. That is the first thing. The younger generation now feels biologics are the answer for every therapy, for every disease. And they are more convinced about biologics than cyclophosphamide. So that's banking. You tell the family you can do semen banking, and cyclophosphamide has not taught me. This man will die. What Ramesh said, well, first he has to live, then he has to see the side effects. So in this patient, thinking of any other drug is absolutely beyond imagination. Even discussing adalimumab or anything, you can't just think it.
It should have come down last in the
At
list.
least I won't
Never,
think it.
never. Never. Gupta?
Yeah, role of apremilast in this case.
Apremilast. No role.
Resistant
For the orogenital
oral
ulcers
ulcers and all those things.
Colchicine resistant orogenital ulcers,
Yeah.
apremilast has been shown, but for the pulmonary aneurysms, I don't
Even
think it has.
uveitis also sometimes it works.
If this patient had had uveitis and you'd have said Adaali, infliximab, all of us would have been happy. But not for this. Because so much time was wasted, no?
It was regarding, ma'am, cases. We have had 2 patients who had intracardiac ventricular thrombus. We did give them anticoagulation. And as you said, like cyclophosphamide is the choice. And these patients, if they have cardiac dysfunction, then we need to avoid anti-TNF anyway. That is one. Second is that just a small story, because one patient got admitted, young male, 17-year-old, with fever and back pain. Extensively investigated, nothing was found. But on evening rounds, one of our brilliant residents found out that patient has developed some pulsatile swelling in the arm. And then we got the clue that patient has Behçet, and turned out to be that. And methylpred was given in the evening. And morning when we saw the patient, the swelling has completely disappeared. Had he not documented it with the ultrasound Doppler, we would have said that he was lying. But this is how prompt treatment of these cases helps.
Was an APLA profile done?
Yes, ma'am, I had mentioned. It was negative.
Okay.
Ramesh. Ramesh, I just have
Kaushik,
one small point before this entire discussion ends. For the benefit of the students, there's always a confusion in the use of cyclophosphamide regimen between the urolupus and the UAS, and which is why you will find a recurring theme of 500 milligram fortnightly being used. And I thought before your panel discussion ends, for the benefit of the students, if you emphasize that part, because people have just become standard cyclophosphamide, 500 milligram fortnightly for 6 doses. But they've confused the urolupus versus the...
Yeah, the question was, are there any markers which tell you which are the patients, biomarkers tell you likely to have aneurysm? Because the story is to act before they go into that aneurysmal thing. Uske baad to, there are these definitely subsets of Behçets we are seeing, clusters of those with the orogenital ulcers, those with vascular, those with neuro-Behçets. And so do any markers or genetics tell you beforehand that these are the patients likely to go into? I'm sure there must be some kind of angiogenetic markers.
Not aware, sir. We may.
If there are no more points for discussion, we'll wind up this case. Thank you for the nice interaction and the good presentation.
Thank you.
Thank you. We will move on to the final case. You can introduce yourself.
Yeah. Good morning, everyone. I am Dr. Ashish. I am from Hinduja Hospital, Mumbai, and I will be presenting a case of deja vu, a case of EGPA. Okay. So, briefly introducing, ANCA-negative EGPA and hypereosinophilic syndromes are often clinically indistinguishable. However, first and second line treatment options and response to the therapy differs in both these cases. Our case highlights this dilemma that the physicians face when encountering a case of hypereosinophilia. So, 5 years back, a 23-year-old male was admitted to our hospital with the complaints of 1 month progressively increasing purpuric rash on the bilateral lower limbs, a tingling and weakness in the ulnar and median distribution of the right hand, fever, and a weight loss of around 3 kgs. However, he had no history of any allergy or asthma. A skin biopsy done had suggestive of numerous eosinophils in the dermis. However, there was no evidence of any vasculitis. On investigating the patient had a eosinophilia with an absolute eosinophil counts of 11,800, thrombocytopenia, raised inflammatory markers, transaminitis, raised serum Ig levels, However, the P-ANCA, C-ANCA, and MPO and PR3 ANCA by ELISA were negative. NCS was suggestive of axonal changes in the distal right median and ulnar nerve, and USG abdomen was suggestive of hepatomegaly with multiple patchy hypoechoic areas in the liver. On discussion with the radiologist, these hypoechoic areas may suggest eosinophilic infiltration which is causing the transaminitis. So our patient had a mononeuritis multiplex, had a deranged LFTs, raised inflammatory markers, skin biopsy which had no vasculitis, eosinophilia with a high serum Ig levels. So differentials being either a hypereosinophilic syndrome or an ANCA-negative eosinophilic granulomatosis with polyangiitis. However, the patient had all features like in the form of thrombocytopenia, and there was no history of any allergy or asthma. So we treated the patient with the pulse methylprednisolone followed by oral prednisolone, and his parameters significantly improved in 9 days. His eosinophilia reduced to 0% with the thrombocytopenia improving. However, his inflammatory markers also got better and transaminitis was resolved. However, 2 days later, the patient presented with sudden onset abdominal pain and 3 episodes of melena. On investigating, he again had a hypereosinophilia with absolute eosinophil count of 9,354, a transaminitis with a normal amylase lipase and urinary routine. Upper GI scopy could not find any source of bleeding. Hence, a CCT abdomen with angiography was done, which was suggestive of a thrombosis of middle hepatic vein, of the portal vein as well as the superior mesenteric vein, and the multiple hepatic hypointensities which were seen on the USG were actually infarcts. At the same time, the patient also had tachycardia and a sudden onset breathlessness with an ECG of sinus tachycardia and raised D-dimer levels. On CT pulmonary angiography, he had a pulmonary thromboembolism in the bilateral main trunk, middle and lower lobar branches of the pulmonary arteries. A coagulation profile of APLA profile antithrombin 3, factor V Leiden mutation and JAK mutation was negative, and bone marrow did not show any increase in eosinophilic precursors. In view of the multiple site thrombosis with eosinophilia, we treated the patient with anticoagulation with warfarin overlap, a pulse methylprednisolone followed by prednisolone, and an injection rituximab 1 gram first dose and the second dose planned 14 days later. However, 10 days later, the patient had sudden onset vomiting, obstipation, diffuse abdominal pain, and hemodynamic instability. An urgent CT of the abdomen showed a perforative peritonitis. An urgent laparotomy with a jejunostomy was done. The histopathology has a fibrinous material with dense transmural neutrophilic infiltrate. There was vessel congestion and there was thrombosis of the mesenteric veins there. However, there was no granuloma or eosinophilic infiltration or arteritis. After the patient stabilized, we treated him with warfarin and prednisolone followed by slow taper, and no maintenance drug was given at this point of time. On discharge, after a long stay of around 5 weeks, the patient eosinophilia had resolved, thrombocytopenia had resolved, his inflammatory markers were normal, and transaminitis was in resolving trend. In view of the recent perforative peritonitis, the second dose of rituximab was withheld during the admissions. And since all of these manifestations fell within the scope of the hypereosinophilic syndrome, we had a dilemma whether we should give this patient a long-term immunosuppression or not. But in subsequent follow-ups for a year in the clinic, he was clinically stable on prednisolone, warfarin, with a normal eosinophil count, liver enzymes, and inflammatory markers. However, a year later, we lost the patient to follow-up. Now, 5 years later, in November 2022, he came back with the same complaints of progressively increasing purpuric rash, abdominal pain, and a high-grade fever. Again had a eosinophilia with an absolute eosinophil count of about 3,500, thrombocytopenia, raised inflammatory markers, and a transaminitis. His serum Ig levels were raised, and P-ANCA, C-ANCA, and MPO PR3 ANCA by ELISA were still negative. A CCT abdomen with angiography was suggestive of an acute or chronic thrombosis of the portal vein and the superior mesenteric vein. The liver was lobular and shrunken, mostly sequel to the portohepatic venous thrombosis leading to a cirrhosis. However, OGD-scopy had no varices indicating he had no decompensation. A histopathology of the skin lesion at this time had a perivascular infiltrate with eosinophilia, extravasated RBCs, and fibrin deposition suggestive of vasculitis. Hence, the final diagnosis of ANCA-negative eosinophilic granulomatosis was polyangiitis was made. This time, the patient was treated with methylprednisolone pulse and 2 doses of rituximab, 1 gram, 2 doses, 15 days apart, and his rash healed after the injection of methylprednisolone. His eosinophilia resolved with normal platelet count and normal inflammatory markers. The patient is now on 6-monthly maintenance dose of rituximab and is doing well at his 12 months follow-up, currently on prednisolone, cyclosporine, and apixaban. So, hepatic vein and assembly thrombosis in EGP is extremely rare. However, it can be threatening and can lead to a long-term sequel. The risk of venous thrombosis in EGP is around 5.8 to 30%. This is due to a combination of vasculitis as well as eosinophilia. Eosinophilia can cause thrombosis by its release of eosinophilic cationic protein, the major basic protein, as well as by direct endothelic damage, and this risk increases when the absolute eosinophil count is more than 4,000. the presence of thrombocytopenia in a case of EGPA should arouse the suspicion of a thrombosis which needs correction by anticoagulation. Histopathology is the only way which can differentiate hypereosinophilic syndrome from ANCA-negative EGPA. In cases that are difficult to differentiate, treat the case as if treating EGPA, because prompt treatment and erring on the side of caution can prevent long-term damage as seen in our case. And current guidelines delineate the role of rituximab as an induction as well as maintenance agent having efficacy comparable to cyclophosphamide. And the target is long-term normalization of eosinophil count to reduce the risk of recurrence of thrombosis, particularly in patients with thrombosis. So at the end of this case, my questions to panelists as well as to the house is, when the patient presented the first time having eosinophilia and all those manifestations which could be explained by the scope of hypereosinophilic syndrome with no biopsy evidence of vasculitis, whether the patient should have been treated as an EGPA at that point of time or should the patient be kept on the follow-up as done. Thank you.
Thank you for that wonderful presentation. Now it's Shankar's turn to offer his comments.
So I'm still not sure what I can label this patient as, whether he's a patient of EGPA or hypereosinophilic syndrome. I was thinking from the day I saw this presentation, even now, I am tilted towards hypereosinophilic syndrome rather than EGPA, based on only one strong point is the presence of thrombocytopenia every time he had an active manifestation. So that would be very odd for EGPA. So I did look at one of the references that you have mentioned. There is one case report of EGPA with thrombocytopenia, but what we have seen in last series, thrombocytopenia is one thing which would go against a primary vasculitic disorder. So that is why I am tilting towards hypereosinophilic syndrome. So among the hypereosinophilic syndrome, another possibility that I was thinking about is the PDGF receptor mutations. So there are a significant subset of hypereosinophilic syndrome patients who have been diagnosed with, who have been found to be having a fusion protein between FIP1-like protein and the PDGF receptor alpha. So this fusion protein has an increased clinical presentation, which is very much similar to what your patient has. So I think it would be wiser to get a PDGFR mutation in this patient, and if it is positive, then that would be a proof that this is hypereosinophilic syndrome. And the other point regarding your skin biopsy showing some amount of leukocytoclastic vasculitis with eosinophil infiltration can happen because of many reasons. It is not very specific for primary vasculitis. Patient receiving multiple drugs, patient having any kind of infections in the recent past can have some leukocytoclastic vasculitis on skin biopsy. So it is not very specific for primary vasculitis. And there was one paper which had shown the skin biopsy findings in patients who are having hypereosinophilic syndrome versus EGPA, like proven vasculitic disorder. So around 15 to 20% of the patients who have been labeled as hypereosinophilic syndrome also had evidence of vasculitis on skin biopsy with eosinophil infiltration into the vessels. So just based on one report of skin biopsy which was showing vasculitis, I would not be very confident in labeling this patient as EGPA, because your he had a GI perforation, and that histopathology was not suggesting any vasculitis. The initial biopsy that you have done was also not suggestive of vasculitis. So to go with only based on one report to go with EGPA would be very difficult for me. And till we get the PDGFR mutation analysis, I don't think we'll be confident in labeling this patient as EGPA.
So just to add on to that, sir, when the first time the patient had presented to us because it was a 1 month history and it was the first time, he had received some drugs from a local physician which were not sure, which might be a steroid and might have changed the biopsy findings. And the other odd thing which pointed, we were thinking of EGPA was the mononeuritis multiplex. I looked up the literature and there are case reports, but a very few case reports of hypereosinophilic syndrome causing a mononeuritis multiplex. So, and the raised CRP levels and a mononeuritis multiplex, which were the odd features which pointed towards a diagnosis of more of an EGPA and rather than HES. Also, reviewing up the literature, there are some mentions of a overlap with an idiopathic HES with a EGPA. No defined term right now, but I think this case might fit into that term of idiopathic HES with an EGPA in an overlap fashion.
So that is why I told in the beginning I have been going on, at the back of my mind I was thinking what could this patient be having. I reviewed your presentation multiple times to see whether is there any point which would tilt my opinion towards one disease in a strong way. So finally, the first thing that came to my mind was this is hypereosinophilic syndrome. So I'm standing with that. This would be hypereosinophilic syndrome and not EGPA.
Ramesh, your comments?
So I'll try to argue for vasculitis more. See, there are two things here. Skin biopsy, for the skin lesion. What was the morphology of the skin lesion? You classically said it was a purpura.
Yes, sir.
Right? So it was a palpable purpura.
Yes,
looking at, because obviously some of those lesions were healed, some of them were hyperpigmented. So on the pictures, it is difficult for me to make out. Skin lesions in hypereosinophilic syndromes, generally the descriptions are that of angioneurotic edemas, urticarias. Vasculitic classic palpable purpura is less well described in hypereosinophilic syndromes. Some types of vague neuropathies are described, and as you rightly pointed out, mononeuritis, classical mononeuritis multiplex is less described in hypereosinophilic syndromes. Biopsy of the skin yield itself we know is poor. The skin as a site for biopsy. Actually, if I have a patient with vasculitis and I want to know the etiology of vasculitis, if he has a skin lesion in another organ, I prefer to do the organ biopsy rather than the skin. Apart from IgA vasculitis, skin doesn't give any clue to the cause of the vasculitis, so I would defer a skin biopsy if I am confident that it is a purpuric lesion. Coming to your bowel biopsy, why did it not show any lesions of vasculitis? You did the bowel biopsy after 6 grams of steroid. The patient had received 6 grams of steroid. The infiltration was predominantly neutrophilic. Eosinophils melt the moment you give them any steroids. So that is the reason. And the pathology in EGPA, if you look at the gut manifestations, is predominantly eosinophil driven. And vasculitic driven. So many a times you may not find classical vasculitic lesions like what you see in other vasculitic diseases in EGPA. But if you find an eosinophilic cryptitis or an eosinophilic enteritis and you have excluded all other causes like parasites and whatever, secondary causes of eosinophilia, I'm talking about a patient with isolated bowel involvement and no perforation, then it could easily fit in, So you need not have classic vasculitis, but you don't expect vasculitis to see after 6 grams of steroids. The very fact that the bowel was inflamed, it has perforated, is more than enough evidence to say that the process was very severe. And obviously, you've had a good therapeutic response to rituximab. Your patient is doing well. So with all these points in mind, I would, put my money on EGPA rather than hypereosinophilic syndromes. So anyway, it's open for discussion.
Okay, I will offer it to the audience first before I give my final comments. Kaushik, Amita, Sapan. You can take it according to your convenience.
Yes. So I would have very different points than Ramesh. If you have had gut perforation, you may not have eosinophils, but you will see vasculitis. You didn't see any vascular disruption at all in the specimen. So why did the perforation occur? Steroids will not remove the vascular damage. So that is why it looks very odd. Second, what Naidu said, thrombocytopenia in a setting of EGPA is extremely uncommon. So I still feel with Naidu that it is hypereosinophilic syndrome. We are struggling with the same patient just a day ago. And the patient has hepatitis, eosinophilic hepatitis, eosinophilic enteritis, and vasculitic lesions, a similar lesion, exactly. I was having a deja vu feeling looking at this patient. And I don't know why, rituximab, why will it work? You are also giving steroids. So which is working, who knows? And you're also giving cyclosporin. Why cyclosporin to this, man?
So, ma'am, for the cyclosporin, actually, since we were not sure whether this is a case of EGP or a case of idiopathic HES, on discussion with the hematologist was of the opinion that idiopathic HES cyclosporin works better. So we started the patient, and since he is responding on... So for HES.
Regarding ma'am's point on thrombocytopenia, actually HES has more association with thrombocytopenia than EGPA. And extensive thrombosis, even though it has been described with EGPA, if you look at the percentage wise, HES has much more extensive thrombosis than EGPA. So these are 2 points which are, and thrombocytopenia obviously. So Mepolizumab is another option if it is, even in idiopathic HES, they have used a mepolizumab.
Just one point about the thrombocytopenia part. Thrombocytopenia has been described in vasculitis patients with clots. So it is believed that it is platelet consumption. It has been more described when you find thrombocytopenia in GPA or MPA, that is what is described. So nothing stops it from in a EGPA thrombus to have thrombocytopenia. So I wouldn't give too much importance
And
to that.
regarding, ma'am, for the perforation part on discussion with the histopathologist as well as the operating team, they were of the opinion the perforation was not due to vasculitis, it was mostly of a mesenteric thrombosis causing a congestion. That because on the histopathology also there was a mesenteric vein thrombosis and also there's congestion of the vessel. So it was a congestion and a backflow causing a perforation rather than a vasculitis maybe.
Saptan Yojana.
You had taken hematology reference, you said, so did they not tell you to do a FLIP1 platelet-derived growth factor mutation?
No, ma'am.
That's very
Sapan?
odd. I mean, hematologists would always ask for it in any
Yes,
patient
ma'am.
with hypereogenemia.
We almost all patients of hypereosinophilia we do send for this by fish it can be done and it is easily.
My votes for Ramesh, I'm coming to Bangalore for the ARICON, so is that two things. One thing, and we had this dilemma before also. The response to steroids of eosinophilia is better with vasculitis than with HES. That's number one. And in your first shot of steroids, the eosinophils went down drastically to 2% or something. I had a patient of EGPA referred to me from Jamnagar, and we did extensive bowel involvement. The physician actually said that it looks like EGPA, and I gave steroids and let the patient go. The second time she came, the gastro fellow said this is colitis, and I saw that there are multiple reports of ulcerative colitis like lesion with EGPA. You can have severe bowel involvement, including perforation with EGPA, and the patient died actually. So I should have given cyclophosphamide the first time that the patient came. So that's very much possible in these patients. So you can have monotus multiplex. I agree with Ramesh. There will never be a clear answer, but I have not seen thrombocytopenia. EGPA itself we have not seen very many, and of course thrombocytopenia is a problem. And with rituximab, I would agree with madam. There is not much evidence of retux with EGPA than the others. My question was, has an APLA profile been done in these patients?
Yes, sir. In the second time, yes, sir. APLA profile was done.
Mononeuritis multiplex, one would really think more of a vasculitic etiology. So EGPA, but I think cyclophosphamide should have been given instead of rituximab.
Durga?
Thank you. My comment would be that actually mepolizumab, benralizumab, even in the recent trial in NEGN, if you read it critically, a majority of patients, nearly 50% had BVAS of 0. So actually the patient population was one with predominant eosinophilia rather than actually EGPA. So one should be a little cautious in the presence of vasculitis while using these drugs.
I agree with respect to EGPA. Obviously in this patient, mepolizumab would not have been an ideal choice, but hematologists are using mepolizumab in idiopathic HES where they are having difficulty using with only steroids. Like when the patient is having recurrences with tapering of steroids, they are using mepolizumab to control hypereosinophilia. But if it is a PDGFR mutation HES, then tyrosine kinase inhibitors like imatinib can be a better choice. So that is why in this patient, I think you can still get these mutations by analysis done, and probably if that is also negative, maybe you will be treating this patient as EGPA probably.
Madam Rajeshri, I'm sorry to interrupt. You are stepping on to the next session. Actually, your time is up, but the rapporteur work is still pending.
The final comments as a chairperson, I would like to, in my opinion, it could be an overlap of HES with EGPA, different stages of HES, different varieties. There is a component called HES. EGPA overlap also, and finally it may have come down to EGPA. The response to rituximab has been very good, and all the explanations have been offered. I open up, I invite the rapporteur to offer her final summary.
Thank you.
Quickly. Thank you for the opportunity to all of us. I think all of us had a very good discussion.
Good morning all. Thank you for presenters for your excellent presentation and the panelists and the chairperson for focused discussion. So the key points from this, the first and foremost is any patient presenting with autoimmune manifestations, predominantly autoimmune thrombocytopenia with lymphoproliferation in the form of lymphadenopathy or splenomegaly. Think first about autoimmune, that is systemic lupus erythematosus, that is monogenic lupus. Then second important thing is if the patient does not fit well into lupus, then second possibility is the SOX mutation, which has been recently defined. Now, as far as ADA2 deficiency is concerned, the most important manifestation of ADA2 deficiency is the neurological manifestations associated with that is cytopenias. And the new point which we have learned is over here is, it is a well thought that most of these patients, they respond to anti-TNF agents. But the cytopenias, they respond very well to azathioprine and MMF, as madam said, they also respond very well to treatment. Moving on to the second case of valvulitis and granulomatosis with polyangiitis. The crux of here was that cardiac involvement is very well seen in these patients, but the important point is treat the patients adequately. Inadequate doses may not do benefit for the patient. For example, in this case, cyclophosphamide was used at a very lower doses. So it is essential to use cyclophosphamide in proper doses. In case of vasculitis, the dose is 15 milligram per kg to be used it is to be used every 15 days for initial 3 weeks, that is every 2 weekly, followed by every 21 days. So it is a total 7 to 8 doses of cyclophosphamide, pulses of cyclophosphamide which are given. So as per the UVAS regimen. Now moving on. Moving on to the third case of EGPA with hypereosinophilic syndrome. So here there is always a dilemma. But important learning point is that thrombocytopenia is very odd for vasculitis. If we see a thrombocytopenia in a patient suspected of vasculitis, either think about it could be SLE related or autoimmune phenomena is going on, or there is underlying sepsis. For a vasculitis to have thrombocytopenia is very odd. And as far as Behçet's is concerned, so in this case, vascular involvement is very common in patients with Behçet's, and it is seen in around 50% of patients. And important thing is immunosuppression is to be given. Anticoagulation is not advised, and the immunosuppression is mainly cyclophosphamide. Cyclophosphamide is a drug of choice for pulmonary artery involvement. And if at all need to use that is anti-TNF, then infliximab is to be used, and that too at a higher doses of 5 milligram per kg, and that too the dosing interval is also less. Thank you.
Thank you for summing up so nicely. We'll close this session. Thank you one and all.
Just a small announcement. For those who couldn't present their posters yesterday, there'll be a session again during the tea break. So you can please join us in the poster hall at that time. Thank you.
And there's another announcement. A couple of our delegates, they lost their belongings. Laptop and ID cards, purse. Couple of doctors. I think please check your bags and see, you can exchange back to your original belongings. Now today's the second session is on miscellaneous rheumatic diseases. Now I call upon Professor Uma Kumar, Chairperson, panelists Dr. Fani Kumar, Dr. Padmanabh Shenoy, and Rapporteur Jyoti Ranjan Parida. Over to Dr. Uma.
Good morning, all. At the outset, on my behalf of my panelist and rapporteur, I'd like to thank Dr. Sharat Chandramouli for starting this wonderful, wonderful concept of clinical case-based discussion. We all know that physicians always get tempted to diagnose patients, giving them a label. But many a time, we have seen that patients, they don't fit into any existent concept of that particular disease. And they become outlier. So basically, it's a path between outliers and inliers, which is beautiful. And that is the actually beauty of the medicine. So today we are dealing with that path. So I'll invite the first presenter, Dr. Siddharth Jain, who's from AIIMS, Delhi. Over to you.
Thank you, ma'am.
So you have 8 minutes to present.
Yes, ma'am.
12 minutes would be for discussion. First panelist would like to respond to the questions, and then it will open up for audience.
Good morning, everyone. Thank you, ma'am, for the introduction. So today I'll be taking you through the journey of one of the challenging cases that we came across recently, which gave us a lot of learning points, and I would like to pass this across to the trainees and the august audience. Pardon me if I'm rushed, but I have to finish in 8 minutes and the case is long. So this was a 52-year-old male presented with complaints of intermittent fever for last 5 months with new onset nodular swelling over the extremities for the last 15 days. For his complaints, he was initially treated as pulmonary tuberculosis because of findings of a right middle lobe consolidation on CT and IGRA positivity. However, the ATT was discontinued within 15 days by another physician because of lack of evidence. 1 month later, he had an episode of left eyelid swelling, which was painful tender, which was diagnosed as preseptal cellulitis, treated with antibiotics, gotten better. 4 months later, he again had a recurrence of his eye symptoms. This time, it was associated with severe headache. He was again evaluated outside, was treated along the lines of query meningitis, query cavernous sinus thrombosis, MRIs, etc. Everything was done. Treated with antibiotics. Got somewhat better plus minus response, but the fever did come on and off. As you can see, the ESR and CRP were high. And on this background, he developed new onset nodular swellings over the extremities, for which he presented to us at AIIMS. So on a review of history, he did give some history of on and off dry cough, and there was a 4 kg weight loss in 3 months. There was no history of any other systemic involvement, no history of classical features of any connective tissue disease or systemic vasculitis. The vitals were normal on examination, and the general physical showed presence of pallor and multifocal, firm, nodular swellings over the extremities. The basic labs revealed presence of anemia, which was on peripheral smear showed some macrocytes. The MCV was borderline elevated, 103. The rest of the cell lines were normal. The liver renal functions were normal, but there was hyperglobulinemia, which on evaluation was found to be polyclonal. And as we can see, the inflammatory markers were markedly elevated. The local site ultrasound of the multifocal nodular swellings of the extremities showed that they were all superficial thrombophlebitis. And in addition, there was an incidentally detected thrombosis in the right axillary vein. The hypercoagulable workup, including APLA, was negative, and the patient was started on anticoagulation. So considering this sort of a profile, our initial differentials were obviously very broad, ranging from, so this was a middle-aged to elderly male, so ranging from malignancy, chronic granulomatous infection, or an autoimmune disease. So we proceeded along the lines of evaluation along all of these lines. So the fecal occult blood was positive, however, the pan endoscopies were normal, the tumor markers were negative, the entire battery of autoimmune tests was negative, a detailed infection workup was also done, which was negative. There were some GGOs in the chest X-ray. Obviously, the next step would be to go ahead with an FDG PET scan, which we did. And we were surprised to find that there were evidence of FDG avid thickening along the subclavian veins, bilaterally, along the portal vein, and along the femoral veins. In addition, as we can see, there were some FDG avid GGOs in the right lung. There was an FDG avid soft tissue thickening in the tracheoesophageal groove, some avid mediastinal lymphadenopathy, and an asymmetrically enlarged FDG avid right palatine tonsil. So as we all know, tissue is the issue, and since we can't really sample the large veins, so we looked at other sites. A BAL could not be done because of very focal findings as opined by the pulmonologist. The paraesophageal soft tissue was really small to be sampled. So we targeted the right palatine tonsil. We did a biopsy, which was unremarkable, showed an admixture of both T and B cells. However, 1 day after the biopsy, the patient developed a painful left-sided neck swelling along with tenderness over the tracheal rings, suspicious for a chondritis. So we went ahead with an urgent CCT neck, and as we can see, there was a large mass centered around the left palatine fossa, which was extending and involving the laterally to the pterygoid muscles, inferiorly going as much as to the larynx, to the aryepiglottic folds. And it was a point that this would possibly be an inflammatory / a neoplastic mass with an epicenter in the left tonsillar fossa. So based on the CT neck findings, we did an FNAC from the left tonsillar region lymph node, which showed reactive lymphoid tissue. But again, after this FNAC, he developed a new onset tender left cheek swelling. So there was, in the CT neck, we also found out that there was left submandibular, bilateral submandibular and parotid sialadenitis. So we did a Schirmer's test, which was found to be positive. But after doing the Schirmer's, he developed a new onset periorbital swelling. So these photos are with consent. So with this cheek swelling, new onset periorbital swelling, we did an MRI of the face and neck. And again, showed really an edema in the preseptal area, extending caudally to the retroantral area and up almost up to the floor of the mouth. Again, query inflammatory, query infective. So as we can see, this patient was having a weird sort of a symptomatology. We targeted the right palatine fossa. He developed a painful left neck swelling. Once we did a FNAC from the left cervical lymph node, he developed a left cheek swelling. Once we did a Schirmer's, he developed a periorbital swelling. So all of these swellings tended to resolve within a few days. And they were classically inflammatory, as we had shown on histopathology, and they were provoked by trauma, reminiscent of a pathergy-like phenomenon, which we are known to see in Behçet's. But there was no history of any oral genital ulcerations, and the HLA-B51 was also negative. The only thing remaining so far was a marrow, because there was anemia, there was some raised MCV polyclonal hypergamma, but again, the bone marrow was essentially normal. There was some plasmacytosis, 8% polyclonal, not significant. So in this elderly, middle-aged to elderly male with this sort of symptomatology, we had extensively worked up for malignancy, infection, autoimmunity, but not found any cause. So we started thinking whether this was an undifferentiated autoinflammatory syndrome and sent a whole exome sequencing. Meanwhile, we took a decision for starting the patient empirically on oral glucocorticoids. And before doing that, we thought, why not do a PET scan repeat just to see what is the burden of systemic inflammation so that we can better follow it up for treatment response. So we did the second PET scan. This was 4 weeks after the first PET scan. And lo and behold, all the periphlebitis all had gone away. So there was complete resolution of phlebitis without any treatment. There was new onset periarteritis that had come up in the large veins. So along the ascending aorta, the arch of the aorta, there was new onset periarteritis. There were more lymph nodes, FDG avid, although subcentimetric, but very avid. And the pulmonary involvement had become slightly more scattered and more bilateral. So again, with this sort of findings, it was reported as, oh, this is suspicious for IgG4 related disease. And we did have sialadenitis, as we saw, there was IgG4 level elevation, but this was more of a part of pan-hypergammaglobulinemia. There were significant clinical negatives with the moderate grade fever, the sky-high inflammatory markers, the phlebitis, the lung parenchyma involvement. So we did a minor salivary gland biopsy nonetheless. It was not suggestive of IgG4. So we started the patient on low dose steroids, and he had a significant treatment response. Within 24 hours, he became afebrile, the periorbital swellings resolved. He had appetite improvement, general well-being. We discharged him. And the NGS report came back to us on OPD basis, showed mutation in the UBA1 gene, exon 3, MET41 valine, allele percentage mutant 60%. So final diagnosis came out to be Vex's syndrome with this sort of a presentation. Obviously, as everyone would be wondering, we went ahead and looked at the marrow again. And despite a close look at the marrow, what we had was only very occasional vacuolation, which was not significant. And again, no dysplasia and only occasional plasmacytosis. So after starting steroids, the patient became afebrile, the CRP settled, but it was still high. It was still hovering around 100. We needed another agent. We wanted to start tofacitinib, but elderly male thrombosis were not willing. So we started methotrexate after shared decision making. He was not really willing for any other therapy. We were not very hopeful, but the patient did respond. And with methotrexate, we were able to taper steroids. The inflammatory markers also became normal. And we did a follow-up PET scan after 6 months, complete resolution of disease elsewhere. And at 1 year of disease follow-up now, the patient is asymptomatic. We have managed to taper the steroid successfully to 2.5 mg. Methotrexate is at 20 mg. Did give an option of hemopoietic stem cell transplant, but he's not willing because he's absolutely okay and has never felt better. So I'd like to close here and with some points to ponder, which all of us thought at our center as to what was happening, and probably the audience would also like to have a comment upon. Thank you.
Right. Good presentation, Siddharth. Dr. Fani?
I think good case, Siddharth. I think when we were given this miscellaneous category, because as you know, these cases are so rare. So I think than my comments will be more on the literature review than my personal experience, because they're very rare to see. And we suspected few in near, I think around 2-3 months back with fever chondritis and this phlebitis, but we didn't find that mutation in UBA1. So coming to our case, because when you said, I think in our case, I think when you said started with periorbital edema, I think the past also he had 2 episodes of periorbital edema and it was treated with has preseptal cellulitis. But I think if you go with the literature, when I've seen this periorbital edema, so that's the most common ocular manifestation in vexus, because
Absolutely.
being reported, the French registry, which is a bigger number with 120 cases, I think they report it as 16%
Absolutely.
of that 110 cases. So it is most common.
Yes.
That is one comment. And regarding the nodules which this case had, whereas skin biopsy was done.
So there was superficial thrombophlebitis everywhere, so we didn't go ahead with the skin biopsy, sir. So the ultrasound correlation of all of those swellings were superficial thrombophlebitis.
So I think the most common skin will be the neutrophilic dermatosis. So I think which is most common, they parent with a sweet syndrome.
Yes.
That is one. The third comment, when you said anemia, I think the more stress should be on macrocytic anemia. So I think macrocytic anemia with high inflammatory markers, with fever and with this sterile swelling. So that is very important if you find it.
Yes.
Then in an elderly male, then you should be suspecting vexus.
Absolutely. Yes, sir.
And coming to the other things, which I felt very odd, which I didn't find anything in the literature, about the gland involvement, the secondary lymphoid organ. You said the tonsil, you said submandibular gland, and you mentioned pathogen-like phenomena. And when you did the first CT and the second CT, and you said before starting steroids itself, when you have repeated CT, the phlebitis has disappeared. And you said periarthritis has reappeared and bilateral GGOs. So what do you think? Because I think this type of phenomena, because without treating him, I think it is evanescent. It has just gone away. And when coming to the phlebitis, I think it is one of the things I think your case has very prominent, the venous involvement. So venous involvement to the rheumatologist, mostly it's Behçet's. So whenever we think it should be Behçet. And when you go to the initial cohort of vexus, I think Behçet's is also being reported in the Bex cohort, the initial cohort where the vexus discovery being made. So saying that the phlebitis is very important, and there are few cases in literature where phlebitis is documented in vexus, and they say that is linked to the venous thrombosis. So that is the one I think I felt.
Can I add? Yeah. Basically, I agree with all the Fani's comments, but what more important is what we call Behçet's may not be really Behçet's. It may be all these mutations, that's where clearly I put endotyping. Some of the patients of Behçet's will have this mutation which we never checked previously. And we used to label them as Behçet's, treat with them steroids, methotrexate, and they respond. And we think it's and we know, and maybe we will see reclassification of all the diseases, how we look at each disease and how we treat these people. So excellent case.
And, one comment on the vacuoles, because for the residents here, I think the vacuoles in bone marrow, there are other conditions which can have vacuoles, like copper toxicity, zinc deficiency, chronic alcoholism, and there are hematological malignancies which can have these, mostly MDS, AML. So I think those should be taken, and without vacuoles, as was shown in this case, with less than 1% of vacuoles in the neutrophils. So I think the mutation. So combining mutation analysis will, along with looking to vacuoles, will clinch the diagnosis.
Absolutely, sir. So for the want of time, there were actually 4 oddities, but I didn't get time to delve into it. So I reviewed this part about vacuoles specifically. So although the initial series more or less had a mandatory vacuole requirement, that's why V in vexus is vacuolation. But subsequent data, so the first data where I found out that vexus had been diagnosed without bone marrow vacuolation was from the Japanese cohort, where they had one patient who did not have vacuolation. Subsequently, I very carefully saw the Dutch data. So there's 8 out of 16 patients, 50% do not have vacuolation. So we did have a discussion with Dr. Dan Kastner also on this. So basically, when vexus was conceived, our information data points were very limited. Now, after the discovery of vexus in 2020, the spectrum of vexus is rapidly increasing. So we don't really understand vexus as of now. The spectrum is expanding not just clinically, but also genotypically. And manifestations like these need to be added more to the literature so that we know that even when there's not enough vacuolation, we still should go ahead with genetic confirmation, otherwise we'll miss the diagnosis.
So, looking at the cost of whole exome sequencing, which is coming down very fast, now I think 15,000 rupees you can get in, or even 8,000, 10,000 rupees you can get whole exome. So, do you think we should lower our threshold of whole exome sequencing? And second question is, when should you appropriately time it, looking at retrospectively?
Sir, I think my answer to that would be slightly nuanced. So I would say that that's a very delicate call because relentless use of whole exome increases a lot of noise as well. We get a lot of VUS we don't know what to do about. So my personal take about approaching whole exome is, so like in this case, we extensively evaluated, did not really have a pre-test probability of what really is happening. If you were very sure this is Vexus, we would have directly done a Sanger. But there were a lot of phenotypic abnormalities like we saw, and we extensively ruled out any other cause. So autoinflammatory when we are suspecting, so if you've reliably excluded malignancy, reliably excluded autoimmunity, reliably excluded infection, and objectively demonstrated inflammation, not just in the tissue, but also systemically, not fitting into the phenotype of a known autoinflammatory disorder, I would do a whole exome without a doubt. But just any undiagnosed patient, maybe I might get a lot of VUS where I may not be able to interpret what really is happening.
No, only question, are you, the undiagnosed these kind of diseases, are you storing the files together? And because you are interested in AML, later date, we can run these programs and see whether some new mutation is there and that kind of stuff coming up.
So we are maintaining a cohort of these patients, sir, and we are also biobanking them. So all of that will come in handy later, sir.
Yes.
Siddhartha, fantastic case. Can you tell the approach for detecting a somatic UBA1 mutation?
Yes.
Because a routine whole exome will miss.
Absolutely.
Yeah. And your allele frequency is 59.7, which
Yes.
is like a heterozygous
Yes, sir.
UBA1.
Yes, sir.
So can you tell what is the molecular strategy that you should follow to detect a somatic UBA1 mutation?
Yes, sir.
And second thing, how do you explain the heterozygous UBA1? Did you sort the immune cells and then you did the mutation, or it is the whole DNA?
So there were two things that were done. So one was testing at a greater depth. So this was done at a 250x depth. So that enabled picking up mutations which were low frequency. That was one. Secondly, we sent a comparative buccal swab. So to subtract the germ line, and what remains is essentially somatic. So that was the approach that was followed in this case. So overlay and then removal of the germ.
Yeah, I think as you rightly said, there was this data, I think about an year back from two large cohorts about that the prevalence is about 1 in 4,000, which is quite a bit. So we'll keep seeing more and more of this. But a male, 52-year-old male with a MCV which is 104, 103 with these kind of things, I think we should have start suspecting these cases and get maybe the Sanger also done these. But the other thing is also that this is just one somatic mutation and phenotypes that we've come up with. I'm sure there must be more such mutations, and we'll increasingly find such phenotypic the more we do. So as Srinath said, we'll have to keep that data to see.
Yes. And even if we go into the details of the genetic part, if the available published Vexus literature is concerned, the methionine to valine mutation carries the worst prognosis amongst the, so three have been described: methionine to valine, methionine to leucine, methionine to threonine. So amongst the three, methionine to valine carries the worst prognosis, but our patient is really responding atypically. So maybe we are looking at, again, the data that we have, we need larger numbers so that we can really collate what is the outcome correlation with the mutations.
We can take one more question.
If time is there, I'll just make one more comment. There is also one recent study that just presence of this mutation does not confer a Vexus phenotype always.
Yes.
The same group, the Dan
Yes.
Kastner group, they have
Yes.
screened multiple normal individuals and they have found somatic UBA variants who do not have Vexus syndrome.
Yes.
So I think we need to have a good pretest probability and then go for a...
Exactly. So that's why blind genetic testing would create more problems rather than helping us.
So summing up this, that for the residents, start looking at basic parameters on blood investigations, because many a time indices are not looked at. So if the MCV is high, very high, and with this multi-system kind of presentation, one should have high index of suspicion in those cases. So thank you so much, Siddharth.
Thank you.
We invite the next presenter, Dr. Swapnil.
for those who ask questions, registration free. So I encourage all students, trainees, please answer questions actively. Don't allow faculty to speak. Okay? To ask questions, I mean.
Start, please.
Good morning, all of you. My name is Swapnil Jagtap from HGPJ. I am third year resident at HGPJ Lucknow. I will be presenting a case of polyglandular exocritinopathy with systemic involvement and some diagnostic dilemma. When we consider glandular involvement in rheumatology, we will come across the few differences like Sjogren's syndrome, sarcoidosis, IgG4 related disease, and rarely a GPA-like presentation. So here I will present a case of a 60-year-old female with known case of hypertension. She is symptomatic since 6 months with a history of low-grade intermittent fever and inflammatory polyarthritis involving small plus large joint. And since 3 months, she is having painless, gradual progressive swelling at the angle of mandible and neck bilaterally. Erythematous rash over the face and gradually progressive proximal muscle weakness involving both upper and lower limbs, dyspnea on exertion and reduced hearing. She presented to us in October 2023 for first time. At that time, she had no oral ulcer, photosensitivity, alopecia, Zika, or Raynaud's or gangrene, no distal weakness, no bowel bladder involvement, no tinnitus or ear discharge, no cough, hemoptysis, chest pain or palpitation, or no any history of weight loss. On examination, she had pallor. As we can see, the faint erythematous rash over the face, bilateral cervical and axillary lymphadenopathy, largest measuring 3/4 in the left axilla, which was mobile and non-tender. Further, breast examination was normal, but thyroid was uniformly enlarged. She had bilateral painless parotid swelling. Her Shermers were borderline right side 5 mm and left side 6 mm. She had bilateral pitting pedal edema till mid-thigh. Her respiratory and cardiovascular examination was normal. She had non-tender hepatosplenomegaly around 4 to 5 centimeters below costal margins. And her muscle power testings revealed power of -4/5 MRC grade in both proximal upper and lower limb. She had truncal weakness. However, she does not had any pharyngeal weakness or no distal weakness or any muscle wasting. Her reflexes, her bilateral plantars were flexors and all her deep tendon reflexes were absent. So, considering these clinical manifestations and examination, we went ahead with investigations. She had anemia, raised inflammatory markers, ESR and CRP, low hypoalbuminemia. Her creatinine, her renal function was deranged. Creatinine was 1.9. Her potassium was persistently high in the range of 7 to 9 equivalent per liter. She had hyperuricemia, hyperphosphatemia, and all her immunological workup like ANA, ENA blood, MSA, complement level and ANCA levels were negative. Her total IgG was normal and serum IgG4 was slightly elevated, 205 mg per deciliter. Reference range is 10 to 140 mg per liter. Her serum electrophoresis did not detect any M band, and her kappa and lambda ratio was normal. Considering her absent DTR, we went ahead with nerve conduction studies. She had on nerve conduction studies generalized axonal and demyelinating sensorimotor neuropathy in both upper and lower limbs. Her 2D echo was normal. Audiometry showed bilateral sensorineural hearing loss, and her HRCT was done outside. That was suggestive of non-necrotizing mediastinal lymphadenopathy. We don't have the films for that. So, considering this 60-year-old female having inflammatory polyarthritis, fever, proximal muscle weakness, generalized lymphadenopathy, organomegaly, hepatosplenomegaly, and in anemia, raised CRP, some renal dysfunction, hypoalbuminemia, with electrolyte imbalance, slightly raised IgG4 levels, along with evidence for neuropathy on NCS and bilateral sensorineural hearing loss. We kept the differential diagnosis of lymphoma first, then IgG4 related disease, and some histiocytic disorder like Castleman disease and Sjogren's were on the lower side. We did minor salivary gland biopsy for Sjogren, that was normal. So for a definitive diagnosis, we went ahead with a lymph node histology. As we can see in the H&E staining, there are several atretic follicles which are surrounded by distinctly thickened mantle zones, which was arranged in the characteristic onion skin-like pattern, as we can see in the figure. And further, this interfollicular space was filled with proliferative vasculature and small lymphocytes, histiocytes, and sheets of plasma cells. We did IHC on the same. The plasma cells were positive for CD138 and IgG4. The ratio of IgG4 positive plasma cells to the total plasma cells was more than 40. Here comes the confusion. Dilemma was whether it was IgG4 related disease or Castleman disease. We went, then we searched for Castleman disease. Castleman disease can be basically classified in unicentric and multicentric Castleman disease according to the involvement of the regions of lymph node. And multicentric Castleman disease can be further classified with systemic feature. Those are associated with HHV8, Kaposi sarcoma infection, and those with idiopathic MCD. And histopathologically, the further classifying multicentric Castleman disease, they have 3 variants actually: hypervascular variant, plasma cell subtype, and mixed subtype. So it is very difficult to distinguish on histopathological basis the IgG4 related disease and Castleman disease, because in interfollicular plasmacytosis variant of IgG4 disease, there we can get the Castleman-like phenotype, in which the interfollicular areas on histopathology will have sheets of plasma cells, and that will be positive for IgG4 levels. And those and serum IgG4 levels or absolute number of IgG4 cells in the lymph node biopsy are also not useful to distinguish between these 2 conditions. And in our case, as the patient had fever and splenomegaly, that was points against the diagnosis of IgG4 related disease. And in exclusion criteria of IgG4 related disease on histopathology, if we get histocytes, that is odd for IgG4 related disease. And in our case, we got the histocytes on histopathology. And in some Castleman, in Castleman disease, patient tends to have some autoimmune phenomenon. So according to the international classification criteria for Castleman disease, we have to exclude these common autoimmune diseases like lupus, RA, or Still's disease while considering the diagnosis of Castleman disease, taking into the consideration of these autoimmune manifestations. So my question to the panel and audience is, what is the final diagnosis? How we should treat these patients besides steroids, and what is the cause of proximal muscle weakness and renal dysfunction in this patient?
Thank you. Very good presentation, Dr. Swapnil. Dr. Fani.
I think going through the case, I think just like the first case, I think it is one of the difficult cases to differentiate and keep a complete final diagnosis. But if you go with the data provided with the case, I think when you see this lot of fever, weight loss, and high inflammatory markers, and polyclonal hypergamma-globulinemia, I think then the IgG4 will go down. And these are all, people talk about hyper IL-6, because it's all Castleman is IL-6 mediated. So there will be just like an IL-6 cytokine storm having all this. And when to talk about other things, because when you talked about pitting pedal edema up to thigh, if you go with Castleman, other than your classification of unicentric, multicentric, and multicentric has lot of recent additions. In the multicentric, when you have HHV8, I don't know whether HHV8 was done in this case or not.
Not done, sir, actually, due to financial constraint.
Okay, then if it is not, then before you call it as idiopathic. So most of the multicentric are plasma cell variants, because they don't have the hypervascular variant. So they will be mixed or plasma cell variant. And when you talk about what are the multicentric, we have, before you call idiopathic, you should rule out poems. But when I've gone through your case, I think the polyneuropathy, which is very significant in this case, so which is a demyelinating, that is mostly seen with whenever you have Castleman on histology, with these atrophic follicles, sheet-like plasma cells, the mantle zone. So it's very classical, it definitely fits into Castleman like lymphadenopathy. But whenever you have a neuropathy, you should look for poems.
Yes,
I
sir.
think
We actually considered POEM as a differential diagnosis, but the patient never had any endocrinopathy, no typical skin lesions that are seen in the POEM syndrome, and serum monoclonal gammopathy is not present in the. Actually, it can be in the literature we reviewed that multicentric Castleman disease associated with POEM syndrome. In 1/3 cases, the M-band can be absent. So we can consider, but the other points were odd for POEM syndrome. So
and again for idiopathic, I think you should rule out poems before you call idiopathic.
Yes.
And definitely she has a volume overload. You said pitting edema till thighs.
Yes.
And
Yes,
that
sir.
is known. And people talk about because of intravascular depletion, they can have a renal failure. That is
Yes.
one thing people talk in idiopathic Castleman. So that can explain her renal dysfunction, which I felt, an IgG4. But for odd points for, if you call it as a multicentric Castleman idiopathic, for that time, I think odd point is the involvement of salivary glands. Salivary gland involvement is not seen in idiopathic because that should be an exclusion. That should be most with IgG4,
IgG4,
which
yes.
is seen. And second, the muscle weakness, I am not able to sort out any comments. I think the renal dysfunction, I may say that because of the edema and again she has, you didn't provide ultrasound abdomen, whether she has SITs also. So because of the volume overload, whichever can explain the renal dysfunction in this case.
now she developed, actually she came back after some time and she had developed volume overload. She was in ascites and bilateral pleural effusion when she came back to us.
Random thought. So when we see some cases, especially in case reports, when he see some patient presents with something, they have some manifestation. Later they develop some other manifestation. I read one case report in NEGM where they have done whole exome sequence in multiple points. So what happens is at one point they have a mean allele frequency of 10%, they will have one kind of manifestation. When it becomes 20%, 25, 30%, the number of manifestations increase. So what I'm trying to tell you is whether this IgG4 related disease, Castleman, POEMs, is based on some kind of mutations which we are yet to pick up. Yeah. Probably I can, maybe Madam can enlighten us or somebody else can enlighten us whether this is the kind of thing, because we keep, it's a whole lot of confusion area, a lot of overlapping features. Maybe one STAT4 or some other mutation which is causing these kind of things which we are yet to pick up, and whether we should do really genetic studies for these patients.
Yeah. And that rightly so, this Castleman disease we still don't know fits into malignancy or this is got autoimmune disease. So it's that, yeah. You said on histology we cannot differentiate between IgG4 and Castleman's. So we got this onion peel appearance on histology. What about storiform fibrosis? Is that helpful in making the diagnosis of IgG4 related disease?
Yes, ma'am. Storiform fibrosis and obliterative phlebitis is described in IgG4 related disease, but in our case it was absent, and they have said that it is not a diagnostic of IgG4 if you get it is so.
But that can zero down to one when we have two differentials that can help.
Definitely help.
Now it's open to questions from audience, please. Dr. Siddharth.
I would just like to share my experience. Had treated 2 Castleman disease because we did not have a hematology backup in our hospital. Ideally, I would have referred to the hematologist, but I had to treat because there was no hematology backup. So basically, I think we have to do the HHV8 levels. So that's what when I read the literature, that's what I came to know, that you have to do the HHV8, and if it is HHV8 negative, then I think interleukin-6 inhibitor, tocilizumab is the first line choice. If it is HHV8 positive, then I think rituximab. And also you can stain for HHV8 on the tissue, on the lymph node.
Yeah. Actually, in US FDA, siltuximab is recommended. In Japan, they are using tocilizumab. In our country, we can use interleukin-6 receptor inhibitor like tocilizumab. So, and trials are ongoing for sirolimus also, because it is the mTOR pathway is involved. So trials for sirolimus are going on.
Those with significant ascites and volume overload features, they tend to do bad, and their prognosis is bad actually.
Bad, yes.
So we lost the patient who had significant ascites and nephrotic range.
Dr. Siddharth?
I have a patient where Dr. Anita Borges madam has reported it as IgG4-RD with Castleman-like histology. No?
Yeah.
In literature, there is a mention of overlap syndrome. Some cases they have reported of overlap of IgG4 with Castleman disease.
And even with other autoimmune diseases like dermatomyositis and rheumatoid with CDs reported.
So, I've managed a few such cases, about 4 or 5. So I think it may not be just one disease. So I feel that the lymphoproliferative aspect of this disease could be Castleman, and the host of other things that you're having may be the associated disease, which may actually be an inflammatory myositis as well. So we recently had 3 predominant cases of inflammatory myositis with Castleman. We recently discussed this as a meeting at a meeting as well. But if you see the clinical case presentation, so IgG4 won't be the first thing that will come to our mind with the clinical profile that you have showed as far as the case is concerned. So, and
yeah, we have considered lymphoma actually in the first diagnosis because she had generalized lymphoma. In my differentials, first was lymphoma, second was IgG4 related disease. Inflammatory myositis we kept down as the patient has absent DTR, CK level were normal. So it is low.
So that may not completely exclude. What I'm trying to say is that rather than fitting everything into IgG4 and everything into Castleman, what I'm trying to say is Castleman gets associated with a lot of other things where the lymphadenopathy, hepatosplenomegaly may be a part of Castleman, whereas the renal dysfunction, proximal muscle weakness may be more systemic. If you look at the autoimmune manifestation of Castleman per se, renal dysfunction is well reported, mechanisms being interstitial nephritis or TMA-like physiology. But proximal muscle weakness, to the degree that you have reported, is not reported as a part of autoimmune manifestations of Castleman. So maybe there's an underlying autoimmune process operating and associated there's a Castleman physiology. And for this, so the way we have managed these patients so far is we give rituximab or tocilizumab. So rituximab works well for these patients, even for the severe cases of Castleman that Dr. Hari Krishnan was saying. So they fall under the TAFRO spectrum of multicentric Castleman. Even they have responded fairly well to rituximab.
Yes, we actually gave rituximab to this patient. After giving rituximab, in first 10 minutes, patient had developed anaphylaxis reaction, so we stopped. And we have given now the first dose of tocilizumab to this patient.
Dr. Sapnil, I have a question to you. Like, did you consider the possibility of ALPS, autoimmune lymphoproliferative syndrome, in this? Because there again, patients can have multi-system.
Yes, ma'am, but other
no,
renal dysfunction and
clinically.
Clinically, clinically
I mean,
we
that
can
is one
consider.
thing
Yes,
can be thought of. We do get that also. Questions from the students and the trainees. Yeah.
Hi, Dr. Jagtap. Very interesting case. I just wanted to ask, your differentials were lymphoma, followed by IgG4, followed by Castleman's. So based on the presentation, the pretest probability probably of IgG4 was, as discussed previously, lower than that for Castleman's.
Yeah.
Right? No pancreatic involvement, Mikulicz-like presentation, all that. So, so the testing that you did, that is a lymph node biopsy, that would have helped you rule in maybe Castleman's, but it doesn't really help you much with IgG4 because the characteristic histology of IgG4, you wouldn't expect it to be there in a lymph node. Yeah, so your lymph node biopsy was primarily targeted at differentiating between your first and second differential, or differentiating a lymphoma from a Castleman's possibly.
Yes.
So when you got the histology and you found the onion skinning and all that, why bring up the possibility of IgG4? Because the
because of interfollicular areas has so many plasma cells, so on histology we can always consider if plenty of plasma cells, that is the same fibroinflammatory disorder like IgG4 we can consider. Because
I agree with you, but based on a lymph node biopsy to consider IgG4 in a patient with low pretest probability of IgG4 just based on one finding, do you think that is a little
I think it's not so simple to dissect the two conditions. So in his best of the wisdom, he and his team has evaluated. Your point is very well taken. The confusion can remain till the end and we may not be able to diagnose these cases. Last question, Dr. Israrul, please.
I just wanted to know IgG elevation in IgG4 levels versus other diseases, because increased IgG4 can be a problem for us, whether because we are considering IgG4 diagnosis. What are the mimickers? How much elevation can be there in other diseases? Like you said, Castleman. How is the case reported or literature review? IgG4, how much elevation can be seen? in compared to IgG4 related disease? To panelists also, sir.
Yeah, I'd like to.
I think level of IgG4, I think we can't differentiate. It is to the tune with IgG4 disease. Only the ratio they feel on the tissue, which will be much more in IgG4 when compared to Casielman. But IgG4 levels are too high.
There's no cutoff as such.
There are no
So
such
thank you
levels.
so much. And now I invite the next presenter, Dr. Mayank.
So good morning, everyone. I am Dr. Mayank Goyal, second resident from Max Circuit, Delhi. And today I'm going to present a case on scleroderma and PVOD, a rare but important paradox. So a 55-year-old female who presented with complaints of dry cough for 3 years and now recently had a worsening of symptoms since 3 months presented to the pulmonology OPD, where then on further evaluation they found that the patient also had complaints of reflux, pain, abdomen, bloating, dryness, and some skin tightening. So the patient was referred to us, and the patient also had a long-standing history of Raynaud's phenomena. So on further examination, the patient was found to have a normal SpO2 of 94% on room, blood pressure 110 by 70 mmHg, some dry skin, grade 2 clubbing, and absence of pedal edema. On examination of the skin, the patient had thickening, tightening, Raynaud's, reduced mouth opening, old heel digital ulcers with an MRSS of 10. On system examination, the chest had bilateral crackles all over, a loud P2 on cardiovascular examination, and other systems, including musculoskeletal system examination, were normal. So on investigations, the patient had normal routine investigation were fairly normal with a raised NT-proBNP of 880. On the autoimmune workup, the patient from outside ANA-IF was done, which was simply reported as 1:80 nuclear. When we did a ANA-LIA, we had a centromere B positive, along with the ANA panel showing the same. HP panel was negative, and NFC showed giant capillaries with an active scleroderma pattern. On echo, the ejection fraction was 60% with a severe pH, and on PFT and CT scan, the FVC was 64%, FE1 was 67% with a very markedly reduced DLC of 31%. The CT chest showed central lobular ground glass opacities along with a dilated pulmonary artery. So it looked like a fairly simple, easy to treat case, and we started the patient for treatment for Raynaud's and anti-PH medications, and the patient was started on nifedipine and ambrisentan. So it looked like a simple and easy to treat case of a limited scleroderma with PH, but rather than showing improvement, the patient had a worsening of dyspnea and uneasiness along with increased chest discomfort. So what had happened? Basically, what we realized was that rather than making the treatment, the patient had a paradoxical worsening of the condition. So we were dealing with what we were thinking was basically a case of PVOD, which is pulmonary venous occlusive disease. So introducing this PVOD, it is a rare subtype of PH group 1 characterized by post-capillary PH due to venous occlusion. The cause is unknown, but it is seen to be present in 5 to 10% of the PH1 patients. So we carefully reviewed the CT again of a patient, and this patient fulfilled the HRCT criteria for the diagnosis of this condition with a triad of mediastinal lymph node enlargement, central lobular ground glass opacities, and a smooth thickening of interlobular septa. As we can see in this case, there is mediastinal lymph node enlargement, central lobular GGOs, and thickening of the interlobular septa. So 75% of the confirmed PVD cases demonstrated at least 2 HRCT abnormalities and a high risk of pulmonary edema following anti-PH therapy. But it is important to mention that presence or absence of one finding will not include or exclude this disease. So after the diagnosis, we started the treatment again. Patient was started on immunosuppressants, mycophenolate mofetil 500 mg twice a day, in keeping in mind the view of the skin condition. We did not give any antifibrotics. The patient was continued on anti-PH medications despite the initial worsening, but this time we gradually introduced the medicines and titrated the doses and started the patient on low doses of the anti-PH therapy. So on follow-up, the patient is doing all right. After 3 months of follow-up, the patient is in usual state of health. And the PFT and DLCO, the FVC and DLCO are fairly stable. To confirm the diagnosis, of course, the gold standard remains lung biopsy and histopathology, which would demonstrate stenosis and occlusion in the pulmonary veins. But since the patient was unwilling and it is not imperative to make the diagnosis, we confirmed our diagnosis by non-invasive methods. To conclude the basic, in this case, the overall prognosis is poor. Most patients die or require lung transplant within 2 years. It is an important differential, and failure to recognize this can be fatal. It may do more harm than good by treating these patients conventionally, and it should be considered in all CTT patients presenting with PH. So some review of the literature. A study performed, a retrospective study, showed that it is probably an undiagnosed cause of pulmonary hypertension in patients with systemic sclerosis. So what they did was that this study had a look at the patients who underwent lung transplantation for refractory PH, and what was found was that a high number of patients, up to 80% of the patients in these cases, were found to have PVOD on autopsy. And what initially was thought as a highly refractive PH was ultimately turned out to be PVOD. So there is another paradox whether that this case is as such a very rare case, or is it a very rare case, or are we underdiagnosing this case? This is another dilemma. So a look at the basic genetics of such basic difference between PH and PVOD. So one is genetic mutations. In PH, we see that BMPR2 is one of the most common genetic mutations. And here in PVOD, EIF2AK4 is an important mutation, where loss of function mutation of this gene is seen in PVOD. It is seen in both sporadic and familial cases, with familial cases showing up to 80 to 90% association, and sporadic cases also having a high association. The disease is autosomal recessive, and while the pH shows female predominance of 1.2 to 2:1, there is no sex predominance in PVOD. There can be an history of organic solvent exposure with trichloroethylene in PVOD as compared to an absence of this in PH. Smoking has shown to be more prevalent in PVOD than PH. And as far as the clinical examination is concerned, hemoptysis is possible in both the cases. But what clue which we initially did not pay much heed to was that pulmonary crackles are usually absent on auscultation in PH, but present in presence of pulmonary edema in PVOD. Right heart catheterization is similar in both the cases. And acute vasoreactivity testing is not a predictor of CCB response in PVOD. Pulmonary function testing, which was another clue here, was that DLCO is normal or mildly reduced in PH initially, but there is a severe reduction in the cases of PVOD. Desaturation on exercise is often present in PH, but often there is a severe reduction in PVOD. HRCT, there is a normal parenchyma on PH, but a central lobular ground glass opacities along with septal thickening and mediastinal lymph node enlargement due to venous congestion is seen in PVOD. As far as the bronchoscopy is concerned, it is not of much help, but there is a possibility of occult alveolar hemorrhage in PVOD. Targeted pH therapy in PH, as we know, it has demonstrated improved hemodynamics, functional capacity, and clinical outcomes. But as far as PVOD is concerned, there is a high risk of pulmonary edema, and there is conflicting data whether we need to give it or not in cases of PVOD. So as far as the diagnosis, this is just a diagram showing how to approach a case. So we make an initial diagnosis of pre-capillary pH. Then we go for non-invasive approach in the form of medical history, where we can have a history of symptoms associated with pulmonary edema or increase in pulmonary edema specific pH therapy. And we go for a BAL or HRCT. And if there is suspicion of PVOD, we will again usually not perform a lung biopsy. And we will start the patient on basic therapy. If the patient is in NYHA class 2 or 3, we will consider oral therapy and plan to refer the patient to lung transplantation center. As far as NYHA 4 patients are concerned, we will start them on a prostanolol infusion, and we will monitor the patient and consider them for suitability of lung transplant. We will consider immunotherapy, suppressive therapy only if it is associated with systemic autoimmune diseases or sarcoidosis. Thank you. My question to panelists will be that could we have suspected PVOD earlier without initially giving the anti-PH therapy and considering it after the patient got worse? And the second is whether it is such rare, or have you encountered cases of PVOD in patients which were having initially a refractory PH?
So before panelists answer the question, I have a question for you. Why patient was given just 1 gram per day of mycophenolate mofetil?
The patient was initially started on this. And in as far as the immunosuppression is concerned in PVOD, we do not usually go for immunosuppression, but in keeping in view of the patient's complaints of skin thickening, tightening, and
But 1 gram, dose is usually 2 to 3 grams
Ma'am,
if we
initially
give it
started on 1
water.
gram and then we ultimately
thanks.
titrated to
Dr.
2
Shannon.
grams.
I have 2-3 questions totally because CRC I think is extremely important to point out that why did you do ANA and ENA together? Somebody who is centromere positive, first of all ANA immunofluorescence was maybe outside somebody has reported wrong, but doing ENA by 2 methods, one eye laser, one eye blot, should you really do it?
No, sir, we would, ideally we were suspecting, so we could have just gone for a simple year.
Simple is one is positive. Is there any really indication? Because somebody has a limited scleroderma, you're very clear, eye node, skin thickening.
Yes.
So I think it is a waste of resources. We should really restrict ordering this kind of thing. Second, slightly different from Madam's question, what is the indication for immunosuppression in this patient after all?
Sir, initially in the CT we thought there is some minimal, ILD, and as well as the patient had an MRSS of 10, and we were thinking that we will go for some immunosuppression because of some.
Really, centromere positive, limited scleroderma, what we are trying to achieve is basically whenever we immunosuppressant scleroderma comes with a risk. Yes. Especially somebody has a GERD, a lot of stuff. Yes, and it causes increased infections. You are giving mycophenolate, it's a strong immunosuppressant. How long? Unless somebody has an interstitial lung disease, with a limited scleroderma, usually the role of immunosuppression is really limited. Yes. Especially when centromere positive, you know that chance of ILD and chance of skin progression is less. Another question is, do you do right heart cath in these patients?
Sir, we could have gone for that, but then again it's an invasive procedure, and we were fairly certain that we were dealing with a PH. And even if we would have gone for right heart catheterization, it would not have actually really helped us in differentiating the two entities.
That I agree, but right heart cath, see, I think we need to change our perspective. That's the point I was trying to make. You are talking about a disease which has a 73-year mortality of 70% or 80%.
Yes, sir.
Or even if it's a pulmonary hypertension, pulmonary arterial hypertension, whichever way. So, whenever you speak to some experts across scleroderma, they always say that right heart cath is a must. Usually should be done unless the diagnosis is very obvious, somebody is in function class 3 or class 4. Otherwise, it's better to do right heart cath in most early cases, and you confirm your diagnosis. That is one. And second thing is, my other reservation was about giving nifedipine as a PH therapy. We should be an ambrisentan as the first line therapy, which we need to be. Nifedipine does not have much evidence in pulmonary hypertension, and one. And second thing, tadalafil is much cost effective when compared to, or sildenafil is cost effective when compared to ambrisentan. Maybe center to center differs, but I think, yeah.
This patient did not have pulmonary arterial hypertension.
Initially when they started, man.
So initially, we thought it was.
You thought that, but it was not proved.
No.
Yeah, it was pulmonary venous occlusive disease which you diagnosed.
Initially.
Initially we thought
Before
it was
we started nifedipine and ambrisentan.
So after starting the treatment, we retrospectively, once the patient got worse, we thought that
your patient worsened on calcium channel blockers, right? So which is known, like these PVOD can worsen with calcium channel blockers.
And regarding the diagnosis of PVOD, because if you say, because we don't have biopsy and you can't do because of severe pH and complications, and you say right heart catheter can't differentiate, so no point in doing. So I think whenever you talked about radiological signs, when they said the triad of radiological signs, like mediastinal lymphadenopathy, centrilobular GGOs, and interstitial thickening, when they say more than 2 present, then your chance of PVOD will be more than 75%.
80%.
Yeah, but I think when you said your case on CT, other than mediastinal lymphadenopathy, nothing there.
This was
Patient had ground glass opacities and
septal thickening.
Yeah,
interlobular. Ground glass opacities and interlobular.
Yeah. So now, questions from the audience, please.
I really have the question. When do you suspect? I don't think I've ever suspected. I may be missing, but these things are very non-specific. Septal thickening, all that. Half of the radiologists say the other half will say not there. So when do you really suspect this in these patients?
Sir, whenever you see the resting hypoxemia, because we had 2-3 cases with us. So when you see resting hypoxemia and DLC was so low, it is 30%. You don't see a normal pH with scleroderma. When you see this and 6-minute walk, if they have an exceptional, very low desaturation, I think this case has 81%. So I think whenever these things, I think, and again the CT, showing this triad, because most of the studies which has proven are mostly the lung transplant cases, which an ILD, and they proved on the explants having this post-capillary venulitis, but no histological studies as such. Yes. But again, worsening on anti-PH therapy is definitely a clinical thing we should.
Hypoxemia, which is disproportionate to lung or cardiac involvement. I think that will be the most important clue. And we can tell the radiologist that we are suspecting this, and then they can come back to us.
Please give her the mic.
Have you, in the review of literature, did you look at the MRI findings in this pulmonary veins? Can it image?
So we did not go for the MRI. The patient at this point of time when we were was not willing for a lot of investigation. So we and the patient also started showing some improvement. So we did not consider doing it.
PET and PET. Some people say to differentiate between PCH again, which say
it's an important difference.
More or less, almost similar disease.
Yes, sir.
Almost similar disease. MRI and PET can be helpful in some cases.
Yes, sir.
And you said mortality is high because these cases are not detected. And therefore, if they are started on treatment, there are studies which have shown that it's a 5-year survival is good.
Yes, ma'am.
Should we give combination of diuretics and vasodilators, ma'am, in such case?
Yeah.
If there is a marked pulmonary edema, then we do go for diuretics, and then we tend to start with anti-PH therapy. Then again, there is a controversy whether we just need to give diuretics or we do need to give targeted PH therapy. But we can give diuretics if there is a lot of pulmonary edema, and that is a distressing symptom.
I think regarding the treatment, I think the lung transplant is
definitive.
1 year mortality of the diagnosis is around 70 to 80%. But again, when you talk on PH therapies, people say calcium channel blockers to be mostly avoided because they have more chance of failure. So either you should give either tadalafil or bosentan, because you said your patient is doing well after giving ambrisentan.
So right now, this was after 3 months of follow-up, so we will still need to see where the patient progresses ultimately.
And regarding your question, vasodilators with diuretics, yes, they can be combined when needed, but you have to be careful regarding blood pressure monitoring in these patients. So thank you so much.
Thank you.
Now I'll invite next speaker. Can you introduce yourself, please?
My name is Dr. Augustine. I am from JIPMER. I'm a third-year trainee. PPT is not there. They'll do it. Thank you. So I would like to tell the story of a case. This I actually saw in orthopedics. So I got a call late night from my orthopedics colleagues that there was a case of septic arthritis that they operated. And apparently the cultures had come sterile, so they wanted us to have a look at that. So I reviewed the case. This was a 38-year-old male who had a catering job in Dubai. He had returned. He was previously healthy. He used to consume alcohol thrice a week for about 12 years before this. And except chronic dyspepsia, he did not have any other significant medical history. So he had come with acute onset severe pain and swelling involving right ankle, left ankle and left elbow, progressing additively over a period of 3 days. And he had come with a worsening over the past 10 days and he was really disabled. This was associated with high-grade fever, which started 2 days after the onset of the joint pains. So he got admitted to the emergency department, was seen by the physician as well as the orthopedician. He was febrile, he had tachycardia, he was toxic looking, he had warm, swollen and severely tender joints. BP was borderline, but it was fluid responsive. There was leukocytosis, high ESR and CRP, and USG angle showed an echogenic effusion. So they suspected multifocal septic arthritis, blood cultures were taken, IV antibiotics were started, and cover for melioidosis was given, which is a favorite DD down in our center. Joint aspiration was attempted, emergency arthrotomy was done, which revealed purulent-looking synovial content. Drains were left in situ with persistent agent, and pus was sent for analysis. So when we review the case, this was an acute febrile inflammatory large joint oligoarthritis at postoperative day 6 of arthrotomy and lavage. There were no prior episodic arthritis. There was no preceding infection. There was no high-risk sexual behavior, no IV drug abuse. There were no prior recurrent infections. There was severe tenderness and swelling of the involved joints, no enthesitis or dactylitis, no tophi, skin rashes, nail changes, or any signs of uveitis. There was no axial spine involvement, and there were persistent drain noted. He had neutrophilic predominant leukocytosis. There was some AG reversal, ESR and CRP was quite high, and procalcitonin was 6.86. Chest X-ray and USG abdomen were normal. There were no solid organ abscesses. Echo did not show any vegetation. All the microbiological initial studies had come out negative, including the bacterial culture, gene expert, fungal stain, and the blood cultures. So at this point, I reviewed the case. So his X-rays were not really contributory. So at this point, the differentials that I thought of, yes, multifocal septic arthritis or osteomyelitis, very much possible, or associated with other infection as severe viral arthritis. And when we look at this septic arthritis, the most common organisms that we get is group A, streptococci, staphylococci, melioidosis, salmonella, and definitely disseminated gonococcal infection. Other predispositions include infective endocarditis, immunocompromised, or post-transplant patients. Now, other DDs in the reactive spectrum, the reactive arthritis, a post-viral or even an acute rheumatic fever, a crystal arthropathy, paraneoplastic syndrome, or all the autoinflammatory spectrum or the osteoarthritis spectrum. So I just asked the orthopedician, like, was it really necessary to operate this patient early on? But their clinical picture was convincing, and he sent me this image and the video, which showed expression of purulent-looking material from the joints. Now, postoperative day 8 into the illness, he developed these erythematous tender subcutaneous indurated lesions over both sides of chest, arms, thighs, and buttocks. So at this point, I considered the differentials of paniculitis, erythema nodosum, leprosum, Sweet syndrome, or PAN, and sometimes superficial phlebitis of Behçet can also present like this. So I went back and reviewed the history. The last binge alcohol intake was 1 month back. He noticed a difference in the nature of epigastric discomfort for the past 1 month. There was no dysglycemia, features of malabsorption, or weight loss. We ordered a pancreatic enzyme level, and amylase came out to be 9,000, and lipase was 421. We did a CT. Pancreas was looking fairly normal. However, the radiologist commented that there is possibility of a revolving collection around right paracolic gutter. And we ordered the tumor markers with respect to the pancreas, which were also normal. So we did the MRI of the involved ankle joints, and which were suggestive of fat necrosis. And later on, biopsy from the skin nodule was suggestive of, again, a fat necrosis, paniculitis with no vasculitis. And the cultures for mycobacteria and fungi had come out negative later. So looking at his course, he had a bad course throughout. Assuming the change in nature of pain, the date of pain would have been 2 weeks prior to the onset of the joint pains. And from admission day 8, we had skin lesions, and at this time, the amylase lipase were elevated. Later on, he had some resolution of symptoms with supportive care, and again, a flare-up of symptoms later around day 30, now with a new joint involvement. If we look carefully at the X-ray, there are some foci of lytic lesions that are noted. At this point, the synovial fluid from the knee was aspirated, which showed neutrophilic leukocytosis again, and LDH was elevated, and amylase and lipase were also elevated in the joint fluid. At this time, he had a swelling in the lateral malleolus, which ruptured and discharged the caseous necrotic material. So he again had a long course and took time for the pain to settle down, but still was left with significant joint damage, something like an untreated septic arthritis. So it's predominantly under the care of the gastroenterologist and the orthopedician. But I just called him up and asked him for his status. So he sent me his pictures. He really lost a lot of weight, and he had some discharging sinus later on. And he's yet to be reviewed again in the OPD further. So take-home points: pancreatitis, paniculitis, and polyarthritis syndrome is a lower limb predominant oligo to polyarthritis. It can present with severe disabling arthritis. It could mimic septic arthritis. And very importantly, nearly half of the patients do not report any abdominal symptoms. And flares of arthritis may be noted with persistent pancreatic injury. And there's always a caution with drug use when the patient is admitted with acute pancreatitis and SIRS. Thank you. And these are the questions to my respected panelists. How would we approach a case of acute onset polyarthritis with skin rashes? And also, I just wanted to add a question. Like at that phase when we see the patient, was there anything that we could have done to improve? Like the role of steroids are questioned. There is not much benefit offered by giving steroids. So what could we have done more for that patient?
Nice case, Augustine. A couple of questions. One, why did you do a skin biopsy at that point, anytime?
Yes, sir. We took a skin biopsy and later got the report as panniculitis without vasculitis, fat necrosis predominant.
There were some ghost cells and other kind of stuff.
Yes.
No, it was there.
Not typical, no, sir.
Not typical.
Probably it was inadequate, I think.
And very odd point is within 10 days or 15 days, there are erosions.
Yes,
How
sir.
common is erosions in these patients?
Sir, erosions are possible. There are some patients who are left with damage actually post severe arthritis, but not common, sir. Definitely not common.
Yeah. Sorry, ma'am.
They are very, very common, and they are very deep ulcers actually, which are erosions reported in these patients.
Yes.
Yeah, because if pancreatic enzymes coming in circulation, inciting intense inflammation, so very destructive lesions can be there.
How do you treat this patient? What did you do?
Sir, I was skeptical about using NSAIDs initially, but then I discussed with a gastroenterologist, so he was okay that even in a phase of acute pancreatitis, it's safe to use NSAIDs. So mostly he was on NSAIDs and opioid analgesics.
And for pancreatitis?
Sir, in fact, I had a doubt that over the course of stay, he got settled. The subabdominal issues were not predominant. There were no collections. So it was predominantly joint and the skin that were involved.
I agree, but there is a asymptomatic pancreatitis,
yes, sir,
which is causing amylase and lipase is coming from pancreas. So
yes, sir,
should you give some octreotide and that kind of stuff so that the pancreas just cools down? I'm just throwing, because primary pathology is in the pancreas, which is
yes,
throwing
sir,
up.
yes.
One alcohol he has stopped, which has been done.
Yes, sir.
And but I was just thinking whether should we do something to. Madam, your thoughts, ma'am?
Yeah, actually there are studies which have shown that level of pancreatic enzymes does not go parallelly with joint disease.
Right.
And these patients can even have cartilage destruction. And surrounding soft tissue like panniculitis, which is there, can actually penetrate into the joint, and it's all been published. So I think we can't do anything more. Even steroids people have not indicated, and these patients are very frequently been treated with DMARDs, and various labels have been given. We had seen a patient where patient was labeled as having septic arthritis and was treated with antibiotics multiple courses. But there are lots of clues with which we can actually diagnose these patients in the synovial fluid, which is very, very thick, and we can look at the fat globules there. And even triglyceride is very much elevated if it is done inside. Even enzymes, and people have done amylase in the synovial fluid, which is elevated.
We also have. But I could not find many reports of the amylase and lipase levels in joint fluid also.
I have seen a difficult case to treat for this PPP syndrome.
Yes, sir.
And these joint symptoms were not responding to anything. That patient is stabilized on etanercept 25 milligram every 15 days.
Okay.
So
that's interesting.
So whether it's really PPP or spondyloarthropathy, I don't know. Etanercept. Bit of pus. Very nice. Yeah. What are the other diseases? Sorry.
Classified into auto-inflammatory. What is the mechanism?
No, pancreas gets injured, the lipase and amylase comes out and does the damage, circulation.
The origin is innate, is it auto-inflammatory or?
No, you can't call it auto-inflammatory. It's basically alcohol is there, alcohol is causing the pancreatitis.
Yes, sir.
Yes. It is not a dry state. Pondicherry is a wet state. Unlike Gujarat. Yeah, how common is melioidosis still? When we used to be there, we used to see a lot of cases.
Yes, sir. Yes, sir. We
It's
still
very
do
common.
get occasionally. But then most of the time we get any solid organ abscess, lung involvement, pneumonia.
Another part of country, how common is melioidosis? Pondicherry, a lot of has melioidosis. Tamil Nadu, that part of Tamil Nadu.
But it's not that common. Actually, there is osteonecrosis basically because of fat embolism. Enzymes are playing their role, that's fine. But there's fat embolization which is causing osteonecrosis. So that is the culprit mainly. So it's very difficult to treat that situation. Only we have to control the inflammation, and non-steroidal is what we had also given. Any questions from the audience? And Yeah, before.
Nice.
Preeti.
So, was there any history of any episodic arthritis prior to presentation?
No, ma'am. No.
And was hyperuricemia looked at?
Mm, not really, because it was strange for
Since it was
gout
a
to present
lower limb
first time with
predominant,
and
arthritis
with
with
so
the
much
history of
systemic
that.
symptoms and shock.
I just wanted to ask you, in your review of literature, how many patients did you find had PPP syndrome without a prior diagnosis of pancreatitis, and what is the underlying mechanism? So what would make somebody look for amylase and lipase in such a case? So you have panniculitis without
Yes, sir.
vasculitis,
So
you have a destructive arthritis. So do you suggest that we screen for pancreatitis by doing an amylase lipase in asymptomatic patients?
So here the clue was the skin lesions. So just we had polyarthritis, we had panniculitis. So out of reflex, I just asked them to order amylase and lipase, to be honest. But then, yeah, such severe arthritis produced so much damage within a short time. Definitely, I think doing an imaging of the joint might give us an idea of fat necrosis happening around the joints and the involved bones. So that is one clue for the osteonecrosis or osteitis part. Apart from that, yeah, it might be difficult to initially suspect a case without. Yes, sir.
X-ray patients can have, as he said, osteonecrosis, can have periosteal reaction, and there's cortical thinning can also be seen at the shaft of the long bones. Yes. So these are some of the clues which are described.
So
in
initial
these
X-rays
patients.
is normal, but when he had knee involvement, his joint was actually showing some lytic lesions around the tibial metaphysis.
Yes.
Hi, sir. Sir, I had a doubt. Patient has got very mild pancreatitis,
Exactly.
and the joint musculoskeletal involvement is out of proportion to the pancreatitis, which you purport is the cause of the musculoskeletal involvement.
Yeah.
So I was thinking, could it be that there is a common infectious pathology maybe that is causing both the asymptomatic pancreatitis and the possible superadded septic arthritis? And what all microbiological workup was done for this? You said gene expert and all that.
Yeah.
So
Then we have talked to the microbiologist for the melioidosis specifically that we have done. Apart from that, all the cultures were negative, including fungal and mycobacterial. But then they would be presenting with more chronic symptoms, I
that
suppose.
is another thing.
These were all very acute. So
yeah. So no, but later on the patient developed chronic arthritis, a draining sinus, and things like that. So are you planning to change your treatment protocol accordingly, or are you just going to call it?
honestly, I'm not sure how to tackle this case. But then one thing I would say is when you don't have pancreatitis, one important cause is pancreatic malignancy. So apart from screening that, I think we should get his imaging done again, probably an MRI and a MRCP. So that is one thing that it is left to do when he comes back. So yeah. Regarding the viral, I'm not really sure. Yeah. Less likely, I think.
Yeah. All right. Thank you so much for that presentation. And now we conclude this session with the. Acha, sorry. Yes. The time pressure. Please, yeah. Please, sorry.
So good morning all. I think once again thanks to the organizers to make us part for this extraordinary clinical practical classes. I'll rather tell that we're undergoing. In other conferences we see theory classes and this is a practical class. In 2 days I think we are almost reviewing our rheumatology text. So coming to the first case, Bexas, I think rheumatology is always exciting because every 5-6 years you have a new disease to look at. You have a new partner to look at, you are never bored. So last decade, I think this is a decade of IgG4 and this DADA2, and this decade started with Bexas and this PPP. So Bexas, when to suspect Bexas, that elderly male, when presented with that he has told sky-high inflammatory markers like high ESR, CRP, ferritin, and you have multi-organ involvement. Particularly many of these patients previously were diagnosed as relapsing polychondritis. So if you have that kind of a catalase involvement, if you have Behcet-like involvement like thromboembolism or different thrombophlebitis, if you have different funny skin lesions which you are not able to explain. And in the laboratory, if you look at the CBC, if there is macrocytosis, if MCP is high, then think of Vexas. And although Vexas start with B, that B is now at stake because recent literature is telling that vacculation may not be present in 100%. And whenever there is a vacculation, you have to cautious about the common causes of vacculation, like alcohol abuse, copper deficiency, zinc toxicity, and MDS, or malignancies, hematological malignancies. If you have suspected Vexas, the only way of conferring the diagnosis is a whole genome mutation, and as Dr. Bignes has pointed out, you have to look at the somatic mutation. But if you'll blindly order all patients with these tests, then there may be a noise. And treatment, these are poor prognosis, steroid responsive. If this is a steroid dependent disease, once you'll start decreasing steroid beyond 20 milligram, once again you'll have a flare. But there may be different diseases, there may be different clusters, like this case has an excellent response to steroid. So I think the future, this thing will help us in knowing more and more that how many types of Vexas are there. The second case was the debate between Castleman disease and IgG4. The whole debate is because the ideal equation of IgG4 plasma cell by IgG plasma cell more than 40% doesn't work here. Even in Castleman, you can have the same histological findings. So only thing to remember for the residents, absence of constitutional symptoms, absence of inflammatory markers are normal to very mild increase in inflammatory markers are seen in IgG4, whereas if there is a lot of constitutional symptoms, fever, anemia, and a very high ESR and CRP, this is not IgG4, something else. And if it is a lymphocyte predominant, like spleen is involved, multiple lymphadenopathy are there, this may be Castleman because lymph nodes, although this may be involved, but these are not so much like Castleman. And the distinction is very important because many Castleman diseases are IL-6 driven, they will not respond to your steroid and rituximab, you may have to give tocilizumab. The third case was about PBOD. Yes, this is again a clinical challenge because many a times we never think beyond pH. So suspect, if a patient, you are suspecting pH in a background of scleroderma in other diseases, if the patient is developing pulmonary edema after starting of the therapy, this could be PBOD. The clinical clues, like Sapan sir has asked, is very low DLCO, extreme desaturation, resting hypoxemia, and patient is deteriorated after starting pH therapy, and the CT is showing those classical triad. One is septal lines, mediastinal lymph node, and central lobar shadow GGOs. And the treatment is difficult. You can start with pH therapy. Don't start calcium channel blocker because that has the highest chance of getting this pulmonary edema worse. So other pH monitoring therapy, other pH therapy you can give with caution. And if the patient develop pulmonary edema, you have to give diuretics. The last one is a PPP syndrome. This is again a new described entity with three very unusual things. One is pyogenic arthritis, which is sterile pyuria. Most of the time I have seen a case, there will florid pus. You'll be actually scared to start anything else other than antibiotics, along with the pancreatitis and along with paniculitis or lobular paniculitis. So the treatment is usually the treatment of the underlying cause. If there is acute pancreatitis, chronic pancreatitis, or most of the time it can be pancreatic malignancy. The cause is the fistula from the pancreas to the systemic circulation. It leaks a lot of these pancreatic enzymes which cause the damage. So you have to treat the underlying cause, that if there is malignancy or there is pancreatitis, that is the only curative treatment for this. I think this is end.
Thank you. So just 3 points to the postgraduates and trainees. One, don't jump into making a diagnosis when you think that there is an outlier. Just wait and observe patient very closely. Second is, if you order an investigation, then interpret the results very carefully. That can actually, something can give you the clue. We are talking about very exotic, advanced investigations. Sometimes the basic basic investigations, they come clues to the diagnosis. And treating, it's not always immunosuppressives. And we do not have treatment for many of the conditions which are being diagnosed with the latest current investigative technologies. So there we actually need multidisciplinary approach, and don't shy away from talking about those cases with your colleagues, with your seniors, to reach to a conclusion. Thank you so much.
Can you please come out to the poster area, please?
Not the poster, you can remove. No, yeah, on the laptop. Yeah, you can show your posters either on the laptop, or if you have a friendly mobile, you can use that as well. So scientific chair also very friendly to assess them. Please stay back here for the poster assessment. Yeah, share 50-50. Is that clear? Also the CME certificates. So now we'll start the rapid fire session. I invite Dr. Krishnamurthy, chairperson, and the panelists, Dr. Durga Mishra, Dr. Sapan Pandya, and Dr. A.K. Khan, to start the session. I call Dr. Krishnamurthy as my Anna. You can see some resemblance we have. Thank you, sir. Please start the show. Thank you.
Good morning. I think this is going to be a rapid fire program, and the customary thanks to Sharaj and to Moli Taba for having organized a beautiful session. Really very interesting and informative sessions. The rheumatology, what we saw long back in the 80s, has completely gone into severe transformation. We were reading about inborn errors of metabolism. Now we are having inborn errors of immunity. So with a lot of investigations and very rare disorders, lot of acronyms. And however, I find still the steroid seems to be in the baseline. So we have very eminent panelists with Sapan Pandya, Dr. Durga, and Khan from Kashmir. So we move forward with the program. We have to get the list, program list now. Only in the phone. Yeah. Thank you. So may I call Dr. Parag Vijay to be the first presenter.
Good morning, everyone. I am Dr. Parag Vijay, third year resident at KGMC. So today I'll be presenting a case of back pain with antiphospholipid syndrome. So to start with, the patient is a 31-year-old female with total duration of illness of 2.5 months. She had past history of 2 pregnancy losses. The first one was a IUGR baby at 6 months of gestation 3 years back, and the second was at 3 months of gestation 7 months back. And the patient presented with complaints of generalized headache, recurrent vomiting, 5 episodes of GTCS, and had a documented BP reading of 200 by 120 mm of Hg in the emergency. And then she was started on antihypertensives, antiepileptics, and CT head was done, which was normal. And then she was discharged from there. 5 days later, she came with complaint of acute lower back pain, which was severe non-radiating, with no focal neurological deficit. And at that time, she was admitted in neurology, and X-ray spine and MRI spine was done, which showed multiple vertebral collapse, and the patient was started on ATT empirically. At that time, the workup for young hypertension was also sent, and then 20 days later, she had complaints of pain in distal part of her right forearm and bilateral leg. And then she was referred to us for the young hypertension evaluation for ANA positivity, which was sent in previous visit. So to look at the investigation, at the baseline first visit, when she came to emergency, she had leukocytosis and AKI, which likely we collaborated to the multiple episodes of vomiting which she had. And she also had low albumin, and urine RM at that time showed scanty proteinuria and RBCs 10 per high power field. And at the second visit, when she came to us, she had the creatinine had improved from previous visit, but still was on higher side, which was 1.43. And the 24-naive protein showed 1.6 gram proteinuria. And the ANA was 3 plus nuclear homogeneous, ENA was negative, dsDNA was 56, and C3, C4 were low. And LAC was positive, and beta 2 GP and ACL1 negative. And for the proteinuria, we did the kidney biopsy suspecting lupus nephritis, but the kidney biopsy showed FSTS and acute interstitial nephritis with few higher arterioles showing luminal thrombi, and immunofluorescence was negative. And on the right side, we can see that MRI showing the acute infarct in the centrum semiovale, and X-ray showing multiple vertebral collapse. So we suspected bone infarct secondary to APS. And when we reviewed the MRI again and discussed with the radiologists, they said that it is likely vertebral infarcts. And in this, we can see that there is a T1, T2 hypointensity in the D11 to L2 vertebra and L4 vertebra. And we did the bone scan for the diffuse pain, which showed multiple healing phase of the multiple bone infarcts. And the discussion, mainly we had doubt that whether it is primary APS or it is secondary APS with SLE. So considering the two abortions and hypertension, we thought that maybe it is primary APS, and the high dsDNA was against, but it can be seen in 7% of the patient with primary APS, and hypocomplementemia, although rare, but can be seen in primary APS. So the questions which I had were whether it is primary or SLE with secondary APS and how to treat, whether with anticoagulation or anticoagulation with immunosuppressants. Thank you, sir.
Thank you very much. A very nice case. First question would be primary SLE or secondary APS. It's very difficult to actually differentiate. I think it has been already discussed yesterday extensively. But still there are few pointers which would tell us whether this could be primary SLE, this could be SLE with secondary APS, because it's mentioned that high levels of ANA, so ANA in a titer of more than 1:320, you could consider that it being a lupus. Number one. Number two, dsDNA positivity, low complement levels. I mean, these go in favor of lupus. And if you have other features, then it's an icing on the cake. But also, if you have anticardiolipin, this was mentioned in one of the literatures which I came across. If you have IgM anticardiolipin antibody, that's most of the times associated with lupus, then with the primary APS. But the thrombotic, there is no difference in the thrombotic mechanism. So these could be indicators. Now, how to treat, whether to treat with anticoagulants or immunosuppressants is again, this was discussed extensively yesterday. If you have, there are two types. You have the thrombotic APS and you have the extra thrombotic, or the presentation could be other than thrombotic. So if you have mainly thrombotic, then you give anticoagulation. That's very important. And if you have other features, then you might require immune suppression in that case. So, which could be, if you have a lupus associated, and it depends on whether you need to give immune suppression for the other underlying condition or not. So that's how it can be differentiated and treated properly.
So for this patient, the proteinuria of 1.6 gram and the renal biopsy showing just FSGS, not typical feature of apial nephropathy or lupus nephritis. So how should we proceed? Should we give?
If your anticoagulation in the beginning has shown response, proteinuria has calmed down, and then you might only go ahead with it. But if it has not calmed down, it's persisted, it is showing on worsening of the proteinuria, then you may consider giving immune suppression.
Yeah, just one question from the audience. Okay, thank you, Doctor. Thank you. We move on to the next presentation, Dr. Srilekha.
A quick reminder to everyone. So these are like bullets coming out of, the short run. So very crispy presentation. Only, I said 3 to 5 minutes. 3 to 5 slides, but some slides are more in some presenters' PPTs. Restrict your timing, only 3 minutes allowed for the presentation, 2 minutes for discussion. Thank you.
Good morning. Myself Srilekha, second year resident in Department of Rheumatology, NIMS. Coming to the case, it is an isolated cerebral nocardiosis in a lupus patient, and cerebral nocardiosis causes approximately 2% of all the cerebral abscess. Being a big masquerader, delayed diagnosis lead to high mortality and morbidity, which accounts for more than 80%. And coming to the case, she is a 25 years female, symptomatic since 7 years, diagnosed to have SLE with initial manifestations of inflammatory polyarthritis, class 3 lupus nephritis, and mucocutaneous features. And she received cyclophosphamide initially. Thereafter, she was on immunosuppression with azathioprine. 6 years down the line, she had a relapse of lupus nephritis, and the immunosuppression was changed to MMF. 2 months following that, she presented with pyelonephritis. As her blood cultures growed ESBL producing E. coli, she was treated with piperacillin tazobactam for 2 weeks. 2 months after this, she presented with left upper limb weakness with in the form of involuntary movements, and she was diagnosed with left human facial palsy and left upper limb monoparesis. And her blood investigations were normal except for mild anemia, and the MRI was done, which showed 2 ring-enhancing lesions involving the right parietal lobe. Our differentials at that point of time were tuberculomas, pyogenic abscess, toxoplasmosis, and last nocardiosis, and for which we have done aspiration and which was sent for histopathological examination, which revealed plenty of polymorphs, and on silver methenamine stain and 1% AFB, it growed branching filamentous organisms, and which on cultures revealed to be nocardia. And she was treated with meropenem for 2 weeks, and cotrimoxazole was initiated. Patient gradually recovered, and on repeat imaging after 4 months, there is a resolution of abscess and edema, and patient currently she is doing well. Coming to discussion, nocardial infections are primarily caused by nocardial asteroides complex, and only 25 to 40% of systemic nocardiosis cases leads to cerebral infection. Diagnosis is challenging because of the limited clinical signs and the bacteriological confirmation and examination of the pus and pus is necessary. Treatment involves a complete abscess excision and antimicrobial therapy up to 1 year. And my questions were, the role of prophylactic Septran or cotrimoxazole in SLE patients who are on long-term immunosuppression and who are on high-dose steroids, and when should we suspect cerebral nocardiosis in cases presenting with brain abscess? Thank you for the opportunity.
Yeah, Mishra.
Thank you for this excellent case. With respect to the first question, actually prophylactic cotrimoxazole is now recommended in patients who are receiving corticosteroid dose greater than 20. Because at least in ANCA vasculitis, it has been shown that otherwise the risk of adverse events is more than the risk potential benefits. And there is no way to suspect cerebral nocardiosis unless you actually have a look at the pus. So you have to have a look at the pus, you have to talk to the microbiologist, ask them to look for nocardia, particularly in a situation when you have an immunocompromised patient with these multiple abscesses. A couple of other points, lung lesions are generally universal in these patients. Other options, if the patient is not tolerating cotrimoxazole or has contraindications, could be doxycycline, levofloxacin, and other drugs. Questions from the audience, please.
I think you can consider doing a nitroblu-tetrazolamide dihydrorhodamine testing for underlying CGD, chronic granulomatous disease. Because patients with CGD, they can develop hyperinflammatory complications, lupus-like manifestations. And since we have had a signature organism, which is a catalase positive nocardia, I think it is worthwhile investigating.
I think it's 20 milligram prednisone more than 2 weeks. That is for the immunosuppression. Then you, as he said, 20 milligram equivalent of prednisone steroid more than 2 weeks. That is taken as the dose very.
Okay, thank you very much. Thank you. I think we have saved 20 seconds. Yeah. We will now move on to Dr. Alekia Amadalapalli, a case of abdominal groans and painful bones.
Can I request all the presenters in the rapid fire come and occupy the front chairs so that we can save a few seconds for each case? So can I call upon Dr. Jagan Babu? Sapan Pandya is already there. We save a lot of time. Arjun, Prithvi, Nidhi Chandra, Vimal, Mahabaleshwar, Amberdeep. Please come to the front row.
Good morning, everyone. I'm Dr. Alekia Amdalpalli, final year DM resident from IMS and Sam Hospital, Bhubaneswar. Today I'll be presenting a case of abdominal groans and painful bones. She's a 16-year-old girl from Orissa, presented with a history of episodic abdominal pain since September 2020 and polyarthritis and tender subcutaneous swelling since July of 2021. And by the time she has presented to us in 2022, her baseline investigations were a low hemoglobin with low MCV, leukocytosis, thrombocytosis, an elevated ESR and CRP with an elevated amylase and lipase levels. So we did an ultrasound abdomen, which showed a chronic calcific pancreatitis with echogenic thrombus in main portal vein, which is extending to right branch of portal vein, and she was also having bilateral isoechoic kidneys. Her urine was showing 2+ albumin and 305 RBCs, which was not a menstruating sample. And then we went ahead and did a 24-year urine protein, which showed a 527 milligrams per day. And then we did a renal biopsy, which was showing a resolving post-infectious glomerulonephritis with C3 2+ deposition in a mesangial coarse granular pattern. Then we did an A&E by ANA by HEP2, which was negative, C3, C4 were normal, and then we did a LAC and APLA profile, which were negative. Then we did ECT abdomen, which was showing extensive interrectal and parenchymal calcifications, measuring 10 mm, and a dilated pancreatic duct up to 9 mm with mild fluid collection, and a complete thrombosis of splenic vein, partial thrombosis of portal vein, and complete thrombosis of left branch of portal vein. Then we did a biopsy of the skin nodules, which showed a subcutaneous fat showing necrosis, surrounded by foamy histiocytes, which were showing a lobular paniculatus, and they were ghost adipocytes. And we did a diagnosis of triple P syndrome, which was a pancreatitis, polyarthritis, and paniculatus syndrome with intra-abdominal DVT. Pancreatitis was managed conservatively. For the polyarthritis, we initially started her on prednisolone 10 mg with NSAIDs, but then she had inadequate response, so we added a colchicine. And she was started warfarin. And after this, she lost to follow up with us and then presented 1 year later. And over the 1 year, she had 2 episodes of pancreatitis and also 2 episodes of arthritis flare. But by the time she has to come to us, she has come with a right shoulder swelling with restricted movements. And here her hemoglobin was normal, ESSCRP was still elevated, and MLS lipase were elevated. And the X-ray is showing an osteolytic lesion, which we suspected as either lipase-induced osteonecrosis versus osteomyelitis. And the bone histopathology was showing an organizing inflammation, no granulomatous or neoplastic, and the infective workup was negative. And a possibility of chronic non-bacterial osteomyelitis was given, and we did a whole body MRI, which was showing multiple hyperintensities in metaphysis of multiple bones. So it was given as a chronic recurrent multifocal osteomyelitis. We did a whole exome sequencing, which was showing a SPINK1 mutation, which was of a hereditary pancreatitis. So a diagnosis of triple P with CRMO was made, and pancreatitis is being conservatively managed. And for the osteomyelitis part, we have started her etanercept, and now she is doing well with her normalized inflammatory markers. So my question would be, what, this is just a triple P syndrome, or this could be a triple P with an underlying autoinflammatory disorder?
Dr. Mishra.
Thank you for this interesting case. Probably this multifocal osteomyelitis might indicate inflammatory disorder. My question was, did you look for other hypercoagulable states apart from APLA?
Yeah, we did a thrombophilia workup, but it came out to be negative, sir.
Okay. Any questions from the audience? Students?
No, we couldn't find any osteomyelitis reported.
Possibly you could go to the OMIM database and have a look.
Okay, sir. Most of this triple P syndrome, pancreatitis, paniculatus, and polyarthritis syndrome, this occurs with chronic pancreatitis only, chronic recurrent pancreatitis, so SPINK1 mutations or even gallstones or other causes of recurrent hereditary pancreatitis. And many a times when we diagnose them with triple P pancreatitis, that time is silent. Many of them would have diabetes also if searched for. So mostly it is chronic recurrent pancreatitis.
Yeah, she is having chronic recurrent pancreatitis. The other corroborating factor, she had a cousin who is also having chronic pancreatitis, which was a calcific chronic pancreatitis.
Now, does the age of incidence help you in diagnosing? Like the previous case where they discussed the same PPP. Yours is a much younger age. So here, do you look for gene mutations rather than in the adult? Okay.
Thank you, sir.
Thank you. So the next presenter is Dr. Jagan Babu, an effective treatment for Candle syndrome.
So, good morning all. I'm Dr. Jagan from Jipmer Pondicherry. So the title of my discussion is an effective treatment for Candle syndrome. So Candle stands for chronic atypical neutrophilic dermatosis with lipodystrophy and elevated body temperature. It is one of the proteasome-associated autoinflammatory syndrome. It is also an interferonopathy. So it is characterized by recurrent fever, skin lesions, lipodystrophy, arthralgia, anemia, and elevated body inflammatory markers. So far, the available treatment modalities are unsatisfactory. So coming to our case, this 12-year-old male child presented with recurrent history of fever, erythematous maculopapular rashes, polyarthritis since 6 months of age. So the important point to be noted here is the onset is from 6 months of age. So elsewhere he was being treated as GAA with methotrexate, leflunomide, cyclosporine, and steroids with no significant satisfactory response. So at the presentation, he had facial dysmorphism in the form of hyperterorism, high-arched palate, and heliotrope-like rashes, short stature, muscle atrophy, lipodystrophy, splenomegaly, hypergammaglobulinemia, and basal ganglia calcification. So at this point, we had differentials like autoinflammatory syndrome at the first, and the second, primary immunodeficiency like hyper-IgE syndrome with facial dysmorphism and eczema, and third one, juvenile dermatomyositis, and fourth, sweet syndrome and cutaneous leukemia. So workup revealed anemia and globulin was high and splenomegaly. Since we were thinking of interferonopathies, we did CT brain that showed bilateral symmetrical basal ganglia calcification. Yesterday we were discussing Aicardi-Gautier syndrome and C1q deficiency, which also had similar finding, basal ganglia calcification, which is a significant peculiar finding in interferonopathies. And also we did skin biopsy that showed neutrophilic infiltration, that is neutrophilic dermatosis. And also we ruled out PID by IG profile and TBNK analysis, which was normal. Indeed, IgG was very high. And inflammatory marker HSCRP also very high, ANA was negative. So we proceeded for gene exome sequencing that revealed PSMB8 exon mutation, homozygous mutation in the patient, and heterozygous mutation in the both parents. So since there was a failure of DMARDs, we started on tofastinib because it is an interferonopathy. So with 6 months of treatment, he has drastic response in the skin, joints, fever, and anemia. Anemia improved to 11 gram, and also he started to gain weight. So there are case reports of baricitinib usage, 2 case reports in this case, Candle syndrome with good outcomes, but due to financial constraints and availability issues, we started on tofastinib and had good response. So learning points, DMARDs, no use in these interferonopathies. And also they have case reports of tocilizumab and IVIG which were not successful. The prognosis is historically poor and standard of treatment is not available yet. So we report a case of Candle syndrome with good response with tofastinib. So points for discussion. So what other mechanism might explain the effectiveness of tofastinib in Candle syndrome? Is there is a blockage of JAK-STAT pathway or other mechanisms? So how can we approach the use of tofastinib and other JAK inhibitors in dosing, monitoring of side effects, and assessing long-term outcomes in pediatric cases? How this successful use of tofastinib can be addressed in other rare autoinflammatory disorders, like in other interferonopathies?
Khan, please.
Again, a very good case. It's the response of Candle syndrome is mainly seen with the baricitinib. But in this case, it can again, its pathway could be the JAK-STAT pathway, which is very important and crucial for type 1 interferon signaling. I mean, that's one thing. And again, the inhibition of JAK-STAT can reduce the burden of the inflammatory cells, predominantly the T lymphocytes, T cells, which can again, I mean, it's multifactorial. It could be because of that. And also type 1 interferon gene signatures, which are inhibited again in the JAK-STAT pathway, could be the reason why tofastinib is working in this case. Second is, how can we approach the use of tofastinib and other JAK inhibitors in dosing? I mean, dosing, it's very important that to look at the child's age, his weight, and accordingly to them, we have to give small doses to begin with, and depending on the severity, we could jack up the dose and proceed further on till the disease is controlled. And then long term is again, we have to follow them very frequently, follow them regularly. And in long term, we have to keep in mind that we have to, in fact, counsel their parents and also look for the malignancies and also see cardiovascular events if they might occur, if the patient has to be taken these medicines for a longer duration. Any other comments?
I also have one question, sir.
Yeah.
Is there a role for anifrolumab in these cases?
So I don't think anifrolumab is available in India. I think what another important aspect is the antenatal counseling of the parents.
Yeah, yes.
Because for next pregnancy, there is a chance of recurrence, 25% chance of recurrence because it's an autosomal recessive condition. I think that needs to be kept in mind and the parents have to be counseling.
Good. Thank you, doctor. Now we have a real session. Dr. Sapan doesn't need any introduction. He will pose the question and he will dispose it with his own answer. He'll be the panelist as
so
well.
I told VK sir that I'll ask myself questions and then answer that. So anyway, this is a very sort of a common problem that not a very uncommon problem that we face. And so this is a 44-year-old lady who came. She was diagnosed hypothyroid in 2018. Much of the stuff, her husband happens to be a physician, so much of the stuff he himself has done. And September 2020, she came first. She comes from almost 200 kilometers from Ahmedabad to my rheumatologist colleague. And she had proximal muscle weakness with rash, which was very typical of dermatomyositis in the form of Gaucher's and those things. Subsequently developed pharyngeal weakness within 20-25 days of presenting then. This was in the notes of my colleague rheumatologist. And she had a hoarse voice as well. So she was, and he went ahead and did an MRI. He had started steroids rightly, keeping the diagnosis as dermatomyositis. And but he got an MRI done because of continuing weakness and this hoarseness developing on this, which showed patchy hyperintensity in these muscles, which confirmed sort of myositis. A biopsy was not done. The physician was reluctant to get a biopsy done in his own wife. She herself is a dermatologist, so. And doctors are sometimes, as all of us know, difficult patients. Anyway, so corticosteroids and then methotrexate, and then after 1 or 2 months, he changed to azathioprine. Tried that for a while. This is MMF, sorry for the G. And also gave IVIG during the time that the patient had pharyngeal weakness. So he was rightly treated actually, but he had to shift these because she was not responding to the extent that she should have. She came to me around June 2021, and that we also continued this treatment, but then when she had continuing weakness and stuff, we decided to give her rituximab. The first one was given in December 2021. So we induced with 1 gram, 2 boluses, and then maintained with 500 milligram almost every 6 months of 2 boluses of 500 milligram. The induction was 1 gram. The last was given in September 2023. And she came back on January, February this year with a fresh problem. But if you look at the reports, early reports, these are the first reports in 2020. And I'll just put one to know. And you can see here the CPKs were raised, the LDH, the ferritin. An anti-Rho was positive. The other muscle-specific enzyme, the others were negative. And she came with these reports with high fevers in January, a count, platelet dropping, ferritin which was high. And so suspecting macrophage activation, we gave methylprednisolone bolus, another IVIG in January this year. And in February, the physician, her husband, he also does a bit of ID, got in touch with ID specialist, and this was the titer, the copies of CMV. He went and so he consulted an ID specialist. He also consulted people in Delhi and elsewhere, and they suggested this. So he gave that treatment along with dexaboluses because she had continuing cytopenias. So it seemed like a macrophage activation, whether it was due to CMV or due to myositis disease, we could not make out. He also did these tests and then went ahead and gave posaconazole. My ID colleague was not very convinced about this, but anyway. So the discussion points here were, whether and so as of now, when I talked to him just before coming, she's not on any treatment, she's fine. The course of both of these have been over and she's off any drugs. The next rituximab bolus was due in March because September was the other, but she's asymptomatic. I said, don't do anything. And steroids also, she's off steroids and she's maintaining okay. So the points were whether the macrophage activation syndrome, I just thought, let me review this a bit. And so this is what one series reports about 4.2%, and more with MDA5. We know that there are these reports, increasing reports. And there's a difference in the mortality when you have mass. So most of even if you go through the case reports of macrophage activation as a complication of inflammatory muscle disease, they die more often. Another series of autoimmune associated hemophagocytic syndrome, 6.9% was dermatomyositis. And in that earlier series, some of them were anti-Jo1, most of them, but now there are increasing reports MDA5. I also went through CMV and inflammatory myositis, and I found one series where about 19 versus 7% in one series. Again, more of MDA5 had this because we also have more of lung involvement there. 33%, this was the survival. So the difference in survival in the CMV copies were higher. All of us should know that you can have normally harbor CMV. So it is my ID specialist went on to say it has to be 1 log increase in 1 week. You have to do it again and see if there's a log increase then you can think that is significant. CMV causing macrophage activation, again 9% in one series. EBV was the number 1 and then followed by CMV. So this can also be there. And finally CMV after rituximab therapy, I think we are increasingly seeing that. And I think Pooja will recall those patients that some of them we lost when we gave rituximab with cyclophosphamide. And they had both CMV disease, we thought, and one patient toxoplasma. So these can happen. About this is one in one series reported, and it was actually second highest after JC virus. We know that in lupus, especially JC virus complicates rituximab therapy. So these treatments are sometimes problematic, and we have to really monitor. So if you have cytopenias in these cases, maybe you should get this CMV and repeat that after 1 week to see if there is a 1 log rise in the titer of that. And then I think all of us are now have started suspecting these. So this is just to share this experience of this patient. And these are real life scenarios that we are facing in lupus also, not just atopic dermatitis. So I'll be ready to take up any other questions if there are.
Yeah. Any questions from the audience? Excellent.
Thank you.
Yeah. So no marks for him, only remarks. And infection is always a looming threat in the management of systemic connective tissue disorders. So now we move on to Dr. Arjun Kumar, a novel clinical presentation in a case of adult inborn error of immunity.
I'm Arjun Kumar. I'm third year resident in NIMS. So it's a novel clinical presentation of Icaros-related disorder, a divergent case of adult inborn error of immunity. So adult II predisposes individuals to recurrent infections, autoimmunity and malignancies, accounting for 25 to 40% of all PAD cases. This report discusses a unique case of Icaros-related disorder presenting with AML and spermatogenic failure. So he is a 47-year-old male, exhibited symptoms of easy fatigability, and on evaluation found to be having anemia, thrombocytosis, and leukocytosis, and requiring recurrent blood transfusions for 1 month. So from the age of 20 years, he has been suffering from recurrent chest infections and was treated with IV antibiotics. And at 25 years after his, he has been evaluated for primary infertility and diagnosed as azoospermia. And he has been referred from hematology to rheumatology in view of pancytopenia and ANA positivity. So on examination, pallor was present, clubbing is present, and auscultation is showing bilateral lower lobe coarse crepitations. So we have worked up in view of low hemoglobin, anemia, and thrombocytopenia and leukocytosis. We did bone marrow aspiration and biopsy. And in view of recurrent chest infections, we suspected ciliary, and in azoospermia, we suspected ciliary dyskinesia, and we have sent for whole exome sequencing. So after that, he, by the time the bone marrow report has, after the bone marrow report, we have he has been diagnosed as AML and has been referred to the hematology, and he succumbed later. So investigation has shown HB of 8 and platelet count of 90K, and HRCT from his old records is showing cystic bronchiectasis with peribronchial thickening and traction bronchiectasis in right upper lobe, middle lobe, and bilateral lower lobes. And his immunoglobulins and lymphocyte subset analysis were normal. And whole exome sequencing is showing IKZF F1, Icaros gene mutation, autosomal dominant, exon 5 at heterozygous pathogenic variant, and TTC21A, which is a variant of uncertain significance correlating with spermatogenic failure. So to conclude, Icaros is a spectrum which presents variably from common variable immunodeficiency, combined immunodeficiency, immune dysregulation, and malignancy. So based on the type of mutation, the haploinsufficiency leads to loss of function, leads to autoimmunity, ALL, and infections. And dominant negative, which is the most severe, there is very severe reduction in levels of Icaros, leads to infections. So this case reveals the novel presentation of recurrent chest infections leading to bronchiectasis, absent hypogammaglobulinemia, coupled with development of AML, attributed to dominant negative mutation with missense variant in Icaros gene. So my question is how to differentiate between somatic and germline mutation in this patient. The patient has been suffering from 20 years of age from recurrent chest infections. Could his chest infections are secondary to this variant of uncertain significance, TTC21A?
Thank you for this excellent case. Immunodeficiency is well described with Icaros, so I think one could very well attribute the mutation to be the cause of immunodeficiency. So the variant of unknown significance, I'm not sure what is the relevance of that. I'm not sure what gene it encodes. So just a few messages for the residents. These factors Icaros and Iolos are involved in B cell activation and differentiation. And there is this drug iberdomide that increases degradation of Icaros and Iolos, which has been trialed in lupus. And as has already been mentioned, haploinsufficiency can result in a phenotype like CVID, whereas dominant negative mutations can result in a phenotype like severe combined immunodeficiency with both T and B cell defects. And what is uncommon again in this case is that this was acute myeloid leukemia, whereas more commonly you have acute lymphoblastic leukemias. In haploinsufficiency, B cell ALL, and in dominant negative mutations, T cell ALL. So any questions, comments?
Any comments? Can you be brief? We have only 20 seconds.
Yeah. Getting a genetic test in presence of a very high blast cell counts. So in this condition, it is better you take a buccal biopsy or a salivary DNA and look for the mutation rather than looking for a germline mutation in a peripheral blood which has lot of blast, because blast cells, they express aberrant mutations, somatic mutations there. So that will hinder your way of looking at germline mutations. So in these cases, better you go for a buccal swab DNA or a salivary DNA.
Yeah, thank you. That's an excellent point. Thank you, Doctor. Next, we go to Dr. Prithvi Krishna Maniam, malignant twist to the challenging saga of infections in a patient with MSMD.
Good morning, everyone. I am Dr. Prithvi. I am a DM resident at Amrita Institute, Kochi. So today I will be presenting a case of MSMD with malignancy. So the patient is a 35 years old male who is hailing from Kochi. With the birth history, he didn't receive any BCG vaccination at birth, but the details of which are not known. And subsequently, after the BCG vaccination, he had developed spinal TB, suspicious pulmonary TB with skin lesions. And he had been tried on multiple doses of ATT with no response. And he had a preputial lesion at 5 years of age, for which he underwent circumcision, but the details of which are not known. At the age of 12 years of age, again he had an flare of the skin lesions, where the skin biopsy was done showing granulomatous skin lesions with caseous necrosis, where the cultures being negative, and he started on ATT with HRJD regimen, but he was having no response. Then he was treated with atypical mycobacterial infection with minocycline and all, following which he had an excellent response with the treatment. So following which, after the stopping of the minocycline, he used to have a recurrent episodes. So he had been tried at multiple different hospitals with different biopsies with different reports. So one of the report, it is showing granulomatous dermatitis. In some it is AFB positive and rest of there are AFB negative. So in few places he was treated as cutaneous sarcoidosis, and in 2013 to 2015 the skin tissue was cited for the atypical mycobacterial infections, but still not able to get any atypical mycobacteria. Still, with the previous response to minocycline, he was initiated on minocycline with cotrimoxazole with excellent response. So after that he was lost for the follow-up, and following which he had a recurrent of the episodes, and he is taking the minocycline on and off. So in 2024 he presented with history of increased skin lesions now over the face and the lower limbs, and history of fever, night sweats and loss of weight. And in between he had a child, and in the child he developed a disseminated BCGosis after the vaccination. So at the time he got tested for that genetic test and found to have STAT1 gene mutation. In our hospital where we did a CBC, it is showing very low hemoglobin, high inflammatory markers and hypergammaglobulinemia. So we went ahead with the PET MR, which showed both supradiaphragmatic and intradiaphragmatic lymph node uptake, and along with that increased uptake in the skin lesions and in the spleen. So following which we went ahead with the left inguinal lymph node biopsy, which there is a multinucleated multilobular cells with vesicular chromatin, and multilobulated cells are seen with prominent nucleoli, and it is positive for CD30, 15 and PAX5. So it is a classical Hodgkin's lymphoma and nodular sclerosis variety. And the skin biopsy which we did subsequently, which showed ill-defined granuloma, cyst of granuloma inflammation. On the tissue AFB culture, we found out to have a non-tuberculosis mycobacterial growth. So this case is in classical Hodgkin's lymphoma, nodular sclerosis variety, on a background of MSMD with atypical mycobacterial infection. So we started with a hematology consultation for the chemotherapy ABVD with lymphoma and atypical coverage for ATT. So my questions for the panel is like any role of interferon gamma or stem cell transplantation in this patient? And if you want to, the second question is how many months we should continue the treatment for the atypical mycobacterium in this patient? As he had previously when he was treated, when he stopped the treatment, he used to have a recurrence of the lesions once after stopping the treatment.
So I think MSMD is increasingly being reported now. Was the first cases were about 19 going through the literature, and although the reports were the first publication was found in 1996, there are about 18 to 20 now already found. Most of them are related to the interferon pathways, various genes, IL-12, and it's a misnomer because it's basically any organism, not just Mycobacterium tuberculosis, but any organism that can cause an intramacrophage. There are reports of salmonella, viruses, fungi, and all of those. And the other thing is that regarding the treatment part that you asked, people have tried recombinant interferon as a treatment, and they continuously give it. I don't know if it's available in our country, I'm not sure. HSCT, of course, would be curative in these patients if you can take care of the mutation. And regarding the treatment for atypical mycobacteria, I think you'll have to treat it for a longer time, and I would get in touch with an ID specialist for that. And about cancers, there are reports of, interestingly, 6 cancers also reported with these, 6 or 7 types of cancers. I did not find Hodgkin's, but mostly B-cell lymphomas and stomach cancer and esophageal cancer, and those. There are reports of those with MSMD also.
Sir, as the patient has a STAT1 gene mutation, the STAT1
that is also known to
produce Hodgkin's lymphoma, underlying MSMD.
And then it's also one of the transcription factors for interferon. Yeah. Any questions from the audience or any comments?
Yeah, I think it is important when you mention STAT1, it is a loss of function which results in MSMD.
Loss of function.
So
it's a loss of
function.
function.
Two forms of autosomal dominant STAT1.
Yes.
STAT1 gain of function, it's a different phenotype, whereas the STAT1 loss of function, it results in MSMD.
Yes.
And second comment, please interpret your report of Hodgkin lymphoma, because this is an immunodeficient fellow. He can develop unusual infection with lymphoproliferation. And any case of CVID or MSMD, if you're seeing lymphoproliferation, always have atypical mycobacterial infections in back of your mind. And please think twice before you label as a Hodgkin lymphoma. Do your clonality studies, discuss with your histopathologist again before, because erroneous treatment of Hodgkin lymphoma will result in worsening of infection.
But how do they respond to chemotherapy, these patients with mutant genes?
I found only about 7 or 8 case reports in literature, and as he said, depending on, so I don't know about the outcome of these patients. As he said, the problem is they're already immunosuppressed, so.
Yeah, I had one question. So, because there is a STAT1 mutation, will these patients respond to interferon gamma replacement? I think they won't respond to interferon gamma. And secondly, is it because that these people are getting recurrent infections that the the cells which are supposed to produce the IL-12, they produce a lot of IL-12 and cause lymphocyte activation, and ultimately it becomes cancer. It's because these patients, there is an interaction between the macrophages and the lymphocytes. The macrophages are not producing IL-12 because they don't have STAT1 signaling. Okay. So they induce a lot of IL-12 to the lymphocytes, and that is why I think they are becoming cancer.
Fine. Thank you. Just want of time. Thank you.
Thank you.
Next, we move to Dr. Jagan Babu. I invite Dr. Jagan Babu. Young stroke with multiple aneurysms.
Morning once again. I'm Dr. Jagan from JIPMER. So now I'm going to discuss on young stroke with multiple aneurysms, unraveling the diagnostic challenge. So we all know large and medium vessel vasculitis presents with vascular abnormalities like vascular stenosis, occlusion, and aneurysm, which lead to varieties of ischemic symptoms. So not to forget about vasculitic mimics. So not all vascular abnormalities are due to primary vasculitis. It could be due to infection, malignancy, genetic defects, and collagen vascular disorders. So we'll have a big diagnostic dilemma until we arrive at a diagnosis. So we'll have this patient, a 19-year-old female with refractory hypertension since 6 years. So the disease onset is from 13 years of age. So she developed giddiness, vomiting, slurring of speech, nystagmus, left hemiparesis. She was evaluated elsewhere and found out to be had brainstem stroke. And she presented to us with worsening nystagmus, new onset cranial nerve palsy. On examination, she had hypertension and BP asymmetries and feeble carotid brachial and radial artery pulses. So we were thinking of Takayasu and we proceeded for CT angiogram, which showed multiple saccular aneurysms in the branches of bilateral renal arteries, splenic arteries, gastroduodenal arteries, and superior mesenteric artery. We also did CT angiogram, which revealed multiple saccular aneurysms in the left vertebral artery and basilar artery. So this young female with young stroke, abdominal aorta wall thickening, multiple saccular aneurysms in the abdomen and the brain with elevated inflammatory markers. So the first differential diagnosis will put is Takayasu arteritis. Since the age of onset is 13 years, we kept open for other differential diagnoses like antiphospholipid syndrome, polyarteritis nodosa, Dada-2 syndrome, and also collagen vascular disorders like Ehlers-Danlos syndrome and fibromuscular dysplasia. So routine workup revealed basic investigation was normal, and immunological investigations, ANA was negative, APLA was negative, and HSCRP was high. So MRI brain showed multiple bleeds in the bilateral medial temporal lobes, and CT angiogram showing multiple aneurysms in the splenic, renal, and gastroduodenal artery. So since we had we had differences of collagen vascular disorders like Ehlers-Danlos, FMD, and Dada-2 syndrome, we went ahead for whole exome sequencing, which revealed homozygous mutation in the ADA2 gene, and subsequently Dada-2 enzyme was also found to be low. So learning points, you should not forget about vasculitic mimics while dealing with vessel abnormalities. So multiple large and medium vessel saccular aneurysms can be a manifestation of Dada-2 syndrome, thus illustrating the expanding and broad spectrum manifestation of Dada-2. Identifying ADA mutation is a pivotal in establishing Dada-2 syndrome and facilitates targeted therapy with anti-TNF agents. So points for discussion: how to differentiate between FMD, fibromuscular dysplasia, Ehlers-Danlos syndrome from large and medium vessel vasculitis, because most of them have these aneurysms. So aneurysm in ADA2 reversible with treatment like anti-TNF agents. What are the complications we can anticipate? How to follow up and intervention like medical and surgical? Is there any treatment beyond anti-TNF agents? And is it time to screen all adult HbSAg negative medium vasculitis for Dada-2 syndrome?
Khan, please.
Yeah, excellent case again. Now how to differentiate FMD? Okay, how to differentiate fibromuscular dysplasia EDS from large vessel vasculitis can be tricky at times because there are lots of overlapping features. Fibromuscular dysplasias is seen in women, can present with hypertension. They have carotid and renal involvement where they can have stenosis. But the gold standard is the arterial catheterization, which is difficult at times. Yes. You know, under the circumstances, you may not have financial constraints. So on the EDS, if they have if the vascular EDS, I mean, if they have systemic features, they can have, you know, the thin skin, they can have musculoskeletal involvement could be in the hypermobile joint syndromes can be there, and they can have typical features associated with that. But if then EDS, if you really suspect EDS, they don't have the clinical features, then you will have to go for genetic testing. And for LVV, you have to do imaging because that would be the treatment, you know, in the evidence that would tell us that you have the PET scans, the CT angios, that would be one. And anti-TNF is very good for the treatment of Dada-2. It stabilizes it decreases the inflammation and stabilizes the vascular health of the patients, and even stabilizes the aneurysm. Whether there is reversal of the aneurysms, I don't think that has been mentioned. I don't think that's actually there. But the aneurysms get stabilized. And complications we know can be vascular, can be systemic complications. There are lots of them, can be neurological, can be hematological. They can be, you know, there can be lots of them. And intervention has to be early. Once you diagnose the patients, it's better to follow them and intervene early. This is the international consensus statement. So intervene early so that they don't have fatal outcomes subsequently. And in the times, if you have adult HbSAg negative and mononucleosis like virus there in patients, they might not require, it's not recommended to do screening in the population. But if you have patients who have family members there, and they have something like this, their screening is necessary if you are planning for an autologous, you know, HSCT. So there you will have to consider them for screening.
Yeah, thank you. Thank you, Dr. Jagan. Thank you very much. We move to the next case, Dr. Nitish Chandra, unveiling the uncommon.
Good afternoon to all. First of all, at the outset, I would like to thank CSC for giving me an opportunity to present my case. My patient is a 50-year-old female. She is a known case of hypothyroid and type 2 diabetes detected for the past 2 years, fairly well controlled. Her past history dates to 2020 August when she presented to outside hospital with gangrenous changes in the right upper limb, which was subacute in onset, progressed over 2 weeks, involving all the fingers of the right digit, all the 5 fingers, and it was not associated with any other accompanying symptoms. She did not have any history of CTD also. So this CT angio was done at an outside image. Sorry, I don't have the image for this. It was showing circumferential mural calcification involving the descending thoracic aorta, a small atherosclerotic calcific plaque measuring 1.4 centimeter in the right subclavian, causing 70% narrowing, and a long segment 4.7 centimeter narrowing, and non-opacification of the left subclavian origin till the inlet of the thorax with opacification of the distal vasculature by multiple collaterals. So she was treated as a probable atherosclerotic disease with aspirin and low-dose warfarin, which she took for 1 year, and she was completely asymptomatic from 2021 to 2023. So she presented us in 2023 July with severe right retroauricular pain and facial pain for the past 2 weeks. So on examination, she had distressing pain over the right side of the face, and she had a right element facial palsy, and she had hyperalgesia over the trigeminal dermatome. Bilateral radial pulse was not felt, bilateral brachial was feeble, other pulses were felt bilateral equal, her BP in the upper limb and lower limb was normal, there was no bruit or carotidynia, middle ear and sinuses were normal, and we had gotten ENT consultation, infection was ruled out, investigation showed no leukocytosis, no thrombocytosis, her CRP was high, ESR was normal, so literally we didn't know what to do. So she had an MRI contrast which was done from outside, which shows there is post-contrast enhancement in the right petrous apex bone with a post-contrast enhancement with meningeal thickening in the right petrous apex bone, and it was reported as a right petrous apicitis. So, since she has a history of gangrene in the past, we went ahead with the PET, and PET showed increased uptake in the descending thoracic aorta as well as increased SUV uptake in the right petrous bone. So, with a past history of gangrene and current episode of petrositis with active uptake in the thoracic aorta, we considered a possibility of undifferentiated vasculitis. Her immunological workup was negative. MP1 PR3 by ELISA was negative, and IF for NCA was also negative. So, initially we gave antibiotics, there was no response. She was started on 1 mg per kg thinking of a possibility of undifferentiated vasculitis, and methotrexate was started. So 3 weeks later she again came to us with severe bilateral temporal headache. This time ESR CRP was high, temporal artery USG showed halo sign, and she was given pulse MPS for 3 days followed by 1 mg per kg steroid, and she was started on tocilizumab with a diagnosis of GCA. Though temporal artery biopsy was done, it was done after 1 month of steroid, so it was inconclusive. Currently she has received 6 doses of tocilizumab, and she is asymptomatic and her inflammatory markers are normal. So my question to the panelist is, how common is LV GCA presenting as isolated cranial palsy, and I couldn't come across any cases of petrositis in a case of GCA, and what are the probable cause of negative temporal artery biopsy in this case? Thank you.
Yeah, Khan, 1 minute comment.
Yeah, the isolated nerve involvements, cranial nerve involvements in GCA it's almost rare. There is literature mentioning about 6 nerve, 5% of patients of GCA having 6 nerve palsy, yes, and some have abducent palsy. But facial nerve palsy is very rare. I think I came across 1 case report in that. But it's worthwhile, looking for GCA in patients who have isolated cranial nerve paralysis, or who have cranial nerve paralysis, who are more than 50 and have temporal headaches or have visual symptoms. Even if they don't have systemic symptoms, you could look for GCA. That's one. And what's the other question?
Yes, sir. Other thing is that from the panelists and from the audience, is there any other atypical manifestation for GCA without typical vasculitis, like petrositis in this case? Like we say that breast tumor-like presentation of GCA, like this, any other atypical manifestations of
petrositis? I haven't come across any literature which of mentioning petrositis. And third, you mentioned was you were curious about knowing that the biopsy,
yes, sir,
in temporal. See, 1/3 of the biopsies can be negative in patients of GCA. The reasons could be that they have the skip lesions.
Yes, sir.
in the temporal arteries, so the whole temporal artery may not be involved.
Yes,
so if you have skip lesions and if you hit the area which is not inflamed, so you have to have negative. Another could be that you can have temporal artery may not be involved at all. So the third could be, which they have mentioned, is giving glucocorticoids. Before that, though, this has been probably overemphasized, but that could be a reason for negative.
Yes.
Thank you. Nice case. But I would contest your diagnosis. I would think this is Takayasu arthritis.
But the thing is that she had, we also initially, the first presentation, we also thought that it could be Takayasu. We kept our mind open, but she came to us with severe headache and...
The thing is that you have a PET, MR, neither of them shows temporal arthritis. We are not experts. We don't see many GC. Our halo signs are not very good.
Yes, sir.
And second, my question was, why did you give intravenous methylprednisolone? There's hardly any indication for that. Even in patients, experts, I'm not an expert in GCA, but people who see GCA day in, day out, they are even doubtful about intravenous methylprednisolone even when there is vision loss. Verbatim quoting them, it probably treats the physician more than it treats the disease. And final comment, if you have such extensive atherosclerosis without coronary calcifications, it's probably large vessel vasculitis. Atherosclerosis secondary to large vessel vasculitis.
Okay. Thank you,
That's a good point. Any input from the audience? Dr. Gokul.
Takayasu patient where recurrent ophthalmoplegia, recurrent cranial palsy, and it is explained that it is possibly ischemia of the muscles. So whether it may not be actually the nerve involvement, but lateral rectus involved or
but MRI actually we had discussed, so they were saying that there was contrast enhancement along the trigeminal nerve as well as along the facial nerve. So
no, that is a good point. Thank you. Thank you so much. Now we invite Dr. Vimal Maneksha, Fabry's disease mimicking CNS vasculitis.
Good afternoon, everyone. I am Dr. Vimal, Rheumatology resident at KIMS, and I will be presenting on Fabry's disease mimicking CNS vasculitis. So, we have a 37-year-old male, 6 months ago, who had sudden onset of right upper limb hemiparesis. He was admitted and evaluated elsewhere for the same, under a neurologist. MRI brain was done, and it showed an acute infarct over the left corona radiata, and there was chronic lacunar infarct over the right cerebellum. He was thrombolized in view of acute ischemic stroke, and secondary stroke prevention workup was done. It included lipid profile, HbA1c, carotid Doppler, 2D echo, 24-hour Holter monitoring, and a serum homocysteine level, and all were normal. Considering the secondary stroke prevention workup being normal, an MRI brain with vessel wall imaging was done, and it showed concentric wall thickening involving the left M1 and bilateral M2, M3, and M4 segments of the MCA. And there was also a mild enhancement over the V4 segment of the left vertebral artery. And hence, further workup was done, in which ANA by IF, ANA profile, APLA panel, and ANCA by IF were negative. So, the neurologist has diagnosed as primary CNS vasculitis, and he was given IV methylprednisolone pulse 1 gram for 3 days, and he was continued on mycophenolate with prednisolone for the next 2 months. And he had come to us for second opinion, asking whether to continue his immunosuppressive therapy or not. So, when he came to us for second opinion, he had history suggestive of acral paresthesia, and on examination, he had multiple purple papules all over the lower trunk, which was suggestive of angiokeratomas. So we had done a skin biopsy, and it had shown only capillary hemangioma. There was no characteristic hyperkeratosis or vascular ectasia. So we involved a dermatologist and took his opinion, who said the morphology looked more like angiokeratomas, suggesting angiokeratoma corporis diffusum. So considering stroke in young, with vessel wall thickening in cerebral blood vessels, multiple cutaneous angiokeratomas, and acral paresthesia, Fabry's was considered as a possibility. Then we had done alpha galactosidase enzyme activity assay, which was only 0.1. Then an exome sequencing was done, which showed mutation in the GLA gene, and then Fabry's was diagnosed as with stroke as the presenting complaint. He was referred for enzyme replacement therapy for further management. So the take-home message is, particularly in young males presenting with stroke with no other risk factors, with concomitant angiokeratoma, when there is vascular imaging suggestive of vasculopathy, Fabry should be considered as one of the differentials. And my question will be, is there a role of glucocorticoids to treat vasculopathy in Fabry's for a short duration?
I don't think there is a role of steroids in these cases. It's a good diagnosis, because I think based on the palm lesions and those you could make out, otherwise I would have missed such cases, and I've never honestly diagnosed a Fabry's or seen. So these are grouped into lysosomal storage disorders, X-linked, and the enzyme is the alpha galactosidase that you said. And so you have accumulation of sphingomyelins in various areas. They can present with tinnitus and various cornea, something in the cornea, proteinuria, and various other anasarca, various manifestations, lead to heart failure, renal failure, strokes. In Indian series, I found in Indian series about 54 patients where 9% had stroke. So they can present in that way also. And the treatment is to replace the enzyme. There is some molecule called megalastat. I'm not aware if that is available in India. And some agalsidase, which is the enzyme, I think, which they replace. I do not find the role of immunosuppression in literature in these cases. And CNS vasculitis was a difference. So there are atypical cases and classic cases are seen in children. So, but you've not seen, okay. And atypical is in men about 30 years. That is the mean that they say in the series. So that's about Fabry's that I could.
There was only one case report where they have shown enhancement in MRI, and after treatment with glucocorticoids for 2 months, and the MRI was repeated, which showed the enhancement being reversed. So that's
Yeah, so that would be true for any lesion. If you have some edema, it will go with steroids. But if you look at the pathogenesis, sphingomyelin accumulation, I don't think you would have a role of steroids there. Okay. Any audience, anybody has seen or wants to share something? No.
Any other therapies? Okay, it looks like a textbook case. Thank you so much.
Just wanted to add, so we recently had a case of lupus with Fabry's in the kidney. So there was renal dysfunction, and classically, so there was azotemia as well as proteinuria. Pre-test probability was lupus nephritis. We did a biopsy. There were zebra bodies in the kidney biopsy. There was renal involvement of Fabry's. So maybe if you do more biopsies, we'll find more of Fabry's.
Okay, biopsy is the mainstay. Thank you. Thank you. Yeah. He got some claps. Good. Dr. Mahabaleshwar.
Yes, sir. Good morning. I shall be presenting a case of sclerokeratouveitis, a diagnostic challenge. This patient, 38-year-old male, came with redness and diminution of vision in both right and left eye, left more than right. He was also a diabetic on treatment, and he was referred by an ophthalmologist. On examination, he had keratic precipitates, keratitis, and B scan also showed posterior scleritis. There were also epibulbar nodules. And MSK examination was normal, vision was decreased in the left eye, and the ophthalmologist had done various infective workup. Toxoplasma was positive, and the patient was treated on Septran-DS with NSAIDs, antibiotics, topical antibiotics, and cycloplegic agents. Also, the MAN2 was positive. TPHA, actually, repeat TPHA was negative. HLB21 was positive. RF, ACPA, ANCA, ANA profile, and IgG4 levels were normal. CT chest was normal. However, the patient followed up with the ophthalmologist. He was started on ATT along with systemic steroids and had only little improvement over a course of 7 months. So here the epibulbar nodules still persisted. Now, during the course with ophthalmologist, they had also done the left eye incision biopsy, which showed only inflammatory cellular infiltrates, no granulomas, cultures were negative, and viral PCR genome was also negative. However, they had started oral valve cyclotherapy. He was lost for follow-up, and then he came with swelling of left ear with no improvement in symptoms. He had completed ATT. And now slit skin smear was negative, and PET CT showed no abnormal avid tracer uptake. And the ophthalmologist again did the second scleral biopsy. In this biopsy, there was emperipolysis, and the IHC was positive for S100 and CD1A negative, suggestive of Rose-Dorfman's disease. So this patient was started on, they had done some biopsy in removal of the scleral tissue, excision was done, and also he was started on steroids with methotrexate. After 1 month, there was resolution of the symptoms. So Rose-Dorfman disease, also called as histiocytic proliferative lymphadenopathy. It usually presents with painless massive cervical lymphadenopathy. It can be extranodal in 40%. Eye can be involved in 10% of the cases. Can be sporadic, familial, and cutaneous. Our patient had extranodal involvement. And management is 21 to 30% can resolve by itself, and sometimes local excision will help. In some patients, methotrexate, rituximab, or chemotherapy is used. So my question for the panelists is, Another point is the IgG4 levels can be increased in 17% of these patients, and IgG4 disease is one of the close mimics, sir. What are the clinical clues which can help to differentiate, which can help us to rule out RDD and IgG4? In this patient, the first biopsy was normal.
Well, presentation as a nodular scleritis, I think would be distinctly unusual for IgG4. So I think the clinical phenotype did not match with IgG4 related disease. And this had also come up, an IgG4 related disease suspected in a lymph node. Previously it was discussed. So what the message I want to give to the audience is, when you have lymph nodes, be very careful about IgG4 staining, because you will get a lot of IgG4 in lymph nodes. IgG4 related disease is never diagnosed based on IgG4 staining in lymph nodes, because there are already a lot of IgG4. So I think very interesting case.
Yes, thank you, sir. That's all.
Thank you, doctor. Thank you. Carry on. Next, Dr. Amber Deep Tripathi, a great masquerader, lepromatous leprosy mimicking as lupus.
Good afternoon to all. Today I will be presenting case of 25-year-old female presented to us with a history of skin rash since 4 years. The character of skin rash is generalized erythematous rash, comes every 2 to 3 months, lasts only 10 to 15 days, improves with treatment. From outside only antihistaminics or some steroid on and off. Lesions were non-pruritic, scaly, rarely vesiculobullous lesions were also observed. And rarely they leave scars. Other histories, patient also has a history of oral ulcers in 15 days with which was covering oral mucosa and involving palate also, and they were painful. Patient also has a history of non-scarring alopecia since 3 months. Other than that, there is no history of hematuria, decreased urine output, sicca symptoms, muscle weakness, Raynaud's, epistaxis, hemoptysis, or other features which may suggest other diseases. Past personal and family history were not significant at all. This was the appearance of the patient, and on examination there was generalized erythematous maculopapular rash, some having overlying scabs, some scarring lesion present behind the ears, some hyperpigmented lesions with scab were present. So in combination, it was looking like a combination of ACLE, SCLE or DLA rash combination. There was thinning of skin was also present in multiple areas. Other than that, there was bilateral knee and elbow joint and left wrist were tender. No swelling was evident, and there was no evident deformities. No evident muscle weakness or sicca features were there. Other than that, systemic examination was normal. On investigations, we found an ANA pattern of 1 plus nucleolar. ENA was negative, DSGNA was less than 10, APS profile was negative, complements were normal, urine was normal. So in view of multiple oddities for lupus, we went forward to do skin biopsy, and which to our surprise came out to be lepromatous leprosy, which leukocytoclastic vasculitis and panniculitis. So this is a picture of the weight-fied stain which we took from our pathology, and it came. It was showing this multivascular lepromatous leprosy. So patient was started on a multi-drug therapy for leprosy, and which was after 4 weeks of follow-up only, patient had a significant improvement. So the point which I need to emphasize is leprosy. Leprosy can mimic, this present as a mimic or also as a cause of rheumatic disease. So as we all know, leprosy or Hansen's disease is caused by Mycobacterium leprae. It is not uncommon in India still. Needs high index of suspicion for diagnosis. Still 70 to 80%, around 50 to 60% cases of leprosy worldwide comes from India only. So it needs high index of suspicion. And it may present to us with various this rheumatic diseases like erythema nodosum, peripheral neuropathy, arthritis, synosynovitis, Charcot's uveitis, skin rashes of different morphologies. So in summary, it can mimic RA, SLE, vasculitis, and sarcoidosis.
A very interesting case, Dr. Amber. I think the important message here is the patient was negative for most of the autoantibodies, and that was the main reason why you should have done a biopsy, and you did go ahead and do a biopsy. So autoantibodies can be negative in patients who present with leprosy. At the same time, patients with leprosy with rheumatic manifestations can also have RF positivity. So it can be both sides of the spectrum, but very interesting case. Thank you. Any comments from the audience?
Important is that if you have a patient who has arthritis, asymmetric arthritis, not the symmetric one, skin lesions, one should think of leprosy. That's very important. That's what I have come to understand.
So it's an important point ki if we don't think of leprosy, we won't catch it.
That's right. That's right. Excellent case.
Case of uveitis and leprosy and APLA positive, so you can have autoantibody positive and leprosy also. We ran with a biopsy and that showed lepra.
Any comments on type 1 and type 2?
Yes, sir. So type 1 and type 2 lepra reaction. Actually, this is a case of type 2 lepra reaction. And more, to be more precise, it is a case of erythema nodosum necroticum, matlab a severe form of type 2 reaction. So type 1, as we know, it is a type 4 hypersensitivity reaction, and type 2 is a type 3 hypersensitivity reaction. And the treatment usually is for type 1, we used to give this 40 mg steroid or 1 mg per kg steroid we go over. And for type 2, like in this patient, the most effective drug is thalidomide per se. But we, nowadays, we don't use thalidomide. So in that case, also steroids may be used. Thank you, sir.
I think Sharath, yeah.
If time permits, a quick one. Sorry, I'm barging onto your
No problem.
presentations. A quick case for learning for the students. No need.
An uncommon complication in a panel discussion.
Yeah. There's a 36-year-old lady present to the local rheumatologist with a kind of few days history of maybe 1-2 weeks history of oral ulcers. Serology was positive. Earlier she had Zika symptoms treated symptomatically by physician. The rheumatologist thought it was probable lupus, kept the patient on HCQ, Medrol 8 mg BD, and esomeprazole. And a few days later, again, the patient went back to the rheumatologist with a kind of rash. The rheumatologist thought it was HCQ induced. He stopped the HCQ, and instead of methylprednisolone, he gave prednisolone 20 milligrams. And the rash kept on increasing. The patient came to us after 2 weeks with this kind of rash. So what do you think? Guess. Exactly. You got it. You cracked the case. So at the time of presentation, there was no rash. While on good dose of steroid, the patient developed rash. So we confirmed that on biopsy. The biopsy confirmed the drug-induced rash, and we stopped the PPI, and the patient got better. Thanks.
What about steroids causing allergy? Have you come across steroids causing allergy? Because any drug can cause allergy.
Yeah, of course. Off late, while on pre-med before rituximab, couple of our patients developed while on a steroid, steroid Solimod infusion going under the pre-med, they developed rash.
Yes.
And quickly regarding the same case, recently I've seen a couple of cases. Again, treated case of lupus. She came from Calcutta just for filling the prescription. So when I took the history, there was no history of lupus at all. She was a ANA positive polyarthralgia. So I discussed with our dermatologist. Actually, it is tinea incognito treated as lupus rash. And there was another case of known case of lupus, while on good dose of steroid, came with a rash. Then it turned out to be CMV-induced rash, making like lupus rash. So we decreased the dose of steroids, started CMV therapy, the rash disappeared. So we have to be careful, when you suspect lupus flare, think of the other mimickers also. Thank you.
Thank you.
So if the hands have those rashes, the palms, so quite sensitive, and looking to the basic blood tests like eosinophilia which was not there before, so that will also give a clue.
Thank you.
Yeah, thank you so much.
Thank you, Chairperson.
We had a very good plethora of variety of cases and with a lot of information and an excellent panelist. Let's up and conclude it.
Anybody wants a rapture of this? Rapid rapture of this?
Thank you, chairpersons and the panelists. Now we'll move on to the quick, rapid session, image competition. I request panelists Dr. Yojana Gokhale and Dr. Devendra Bairwa to run the session on image competition. We have received, I think, around 96 images, and she selected top 30, and she is going to give prizes for the top 3 winners.
Good morning, all. I'm Dr. Devendra Bairwa, and we have Yojana ma'am with us.
Thanks, Dr. Sharat, for giving the opportunity to judge image competition. We had to, and Dr. Devendra had to judge actually 30 shortlisted images, and we had to select top 3 for cash prize and certificate, but the images were so good that in addition we selected 3 more special certificate prizes. So the criteria used were image quality, novelty of case, learning point, and post-treatment image showing improvement. So we start with the first case. This 9-year-old female child presented with ulcerative lesion over left leg for 6 months, and no other significant history or physical examination finding was noted. Laboratory investigations were normal. While skin biopsy revealed lichen sclerosis with calcinosis cutis, her immunological workup suggested ANA positive by immunofluorescence, and anti-TNF gamma was high, and diagnosis of amyopathic dermatomyositis with lichen sclerosis with calcinosis cutis was made, and the patient was started on oral methotrexate and topical tacrolimus, and currently the patient is doing well. This was from Bangalore, Dr. Karthik. Next. Yeah. Okay, now this was a 50-year-old lady without any history of smoking or comorbidity, presented with
Postprandial abdominal pain and headache.
Postprandial abdominal pain and headache, and actually this is too little small thing. Yeah, please read.
Okay. General and systemic examinations were normal. Her routine lab tests were normal. USG abdomen NCGD has suggested calcification in the abdominal aorta and intracranial arteries, respectively. She was referred to us to rule out tachycarditis. CT angio revealed widespread focal eccentric wall calcification at ascending aorta, arch of aorta, abdominal at origin of right vertebral artery, and intra and extracranial part of bilateral intercalateral artery, and left subclavian artery along with mild segmental narrowing. Distally left subclavian artery was reconstituted by collateral channels. Sagittal and coronal sections suggested high-grade stenosis of celiac trunk and supramesenteric artery with post-dilation. After multidisciplinary review, we decided that this pattern of calcification is more diagnostic of medial arterial calcification, which doesn't require any immunomodulation. Patient was reassured and managed conservatively. Then we have next image. Ma'am, shall I go? Okay. We don't have much time. We will not be reading all the images completely. 10-year-old diagnosed case of MI2 positive juvenile dermatomyositis in clinical remission on methotrexate and no-dose steroid for last 2 years, presented with 1 month history of tender painful swelling diffusely along the medial aspect of left thigh with discharge of thick whitish material. Infective workup negative, pre-treatment X-ray thigh, leftmost image, and CT thigh, middle image revealed extensive calcinosis involving adductor muscles of left thigh. There was complete resolution of calcinosis after 3 monthly doses of IVIG, which is evident in the post-treatment X-ray thigh. The extensive calcinosis in well-controlled disease with patient already on treatment, and the rapidity of resolution of calcinosis on IVIG both were astonishing.
Then we have this case, a 27-year-old male presented with 8-month history of painless, gradually progressive swelling of right third digit with no history of preceding trauma, fever, night sweats, weight loss or cough. 2 months after the onset, he developed a painless, progressive swelling over the lateral border of the left eyelid, as you can see the image. X-ray of the hand showed multiple osteolytic lesions in the right third MCV, PIP with irregular borders and rarefaction. Biopsy of the right lymph node had shown granulomas with central necrosis. The swelling completely resolved with ATT. This case underscores the importance of considering TB in the different diagnosis of rheumatological manifestations, even in the absence of typical symptoms. Then we have this image from Dr. Nidhi Chandra. A 16-year-old girl presented to rheumatology clinic with 6 months history of bony pain over distal forearm and severe back pain. On examination, she was pale and severe tenderness over both distal forearms to this joint and had spinal tenderness at T12, L1, L2 level. MRI has shown T1 hypointense and T2 hyperintense signal in the anterior 1/3 to posterior 2/3 of the middle dorsal, lumbar, and sacral vertebrae, suggestive of bone infarcts. In view of anemia, bone pain, evidence of bone infarct, on MRI, sickle cell disease was suspected, and her HB electrophoresis showed presence of HBS levels high. This case, a 16-year-old female had 3 months history of polyarthralgia with right wrist arthritis, being treated as JIA. On examination, had multiple tender bony points on dorsum of right hand and forearm. Investigation showed normal inflammatory markers, calcium and vitamin D. X-ray of right hand and forearm showed osteoma-like lesions with endosteal thickening of second MCP carpal bone, lower end of shaft of both the forearm bones. Bone scan showed increased tissue uptake in distal 1/3 of the right radius, few carpal bones of right wrist, first, second MCPs, and phalanges of right, second, third digits around elbow joint, ascending to the lower 1/3, suggestive of miloriostosis, thereby mimicking as arthritis. Then this image, 27-year-old male developed erythematous violaceous lesions over upper chest, face, scalp over 6 months, associated with photosensitivity, non-scarring alopecia, ulcers, heliotropic rash, Gotton's papule, progressive ulceration over bilateral malar area and left angle of mandible followed. Ulcer edge biopsy showed perivascular and periadnexal lymphoid infiltrates, vacuolar interface dermatitis, and basement membrane zone thickening, with no clinical, radiological, or lab evidence suggestive of myositis, ILD, or arthritis. Anti-MDA5 associated amyopathic dermatomyositis was diagnosed. Treatment with moderate dose of steroid, MMF, and topical tacrolimus. There is result of lesions. A 30-year male with history of inflammatory arthritis with pyoderma gangrenosum, diagnosed as lupus and treated with cyclophosphamide from a peripheral institute, developed sternoclavicular arthritis and referred to us for workup. Patient found to have new bone formation as shown in elbow X-ray and bone scan suggestive of right clavicular osteitis with increased tissue uptake in multiple joints suggestive of Sappho syndrome. Patient started on adalimumab, is now asymptomatic. Case emphasized the necessity of comprehensive evaluation and consideration of rare syndromes like Sappho when managing patient with overlapping symptoms of pyoderma gangrenosum and arthritis. A 6-year-old female patient presented with painful skin ulcerations with discharge over both elbows and knees for 10 days. No other symptoms of CTD. On examination, she had ulcers over both extensors of elbows, knees, and lateral malleoli with crusting. Gotton's papules were present. Muscle power was 5/5, CPK, LDH were normal, ANA was negative, and myocytes profile was positive for anti-MDA5 antibody. CT chest was normal. She was managed with IVIG and IV methylprednisolone. She was discharged with prednisolone and tacrolimus. 1 month later, the skin ulcers have healed. A 49-year-old man with dermatomyositis, characterized by asthenia, itching, skin lesions, and proximal weakness. On examination, had heliotrope erythema, Gotton's papule, V sign, Scholl sign. He had elevated muscle enzymes and positive MI2. Despite multiple prior therapies, the patient showed poor disease control until 5 months before consultation. He received simultaneous treatment with oral steroids, HCQ, and MMF. Due to progressive worsening and severe skin lesions, he was added on tofacitinib treatment along with low-dose steroid. Clinical improvement was notable within 2 weeks, and at the time of writing, all skin lesions have significantly improved. The hiding eagle in the neck. 60-year male presented with symptoms of difficulty in chewing for 8 months due to throat pain. The pain was insidious in onset, progressed to severe intensity, and was localized behind the angle of mandible. No other peripheral joint involvement or axial symptoms. On findings, bilateral temporomandibular joint area were tender, and there was decreased mouth opening. On investigation, bilateral TMG was normal on lateral X-rays, and there was enlargement of bilateral styloid process. The enlarged styloid process were better seen from Townes view on X-ray. Normal morphology of TMJ was confirmed 3D CT scan and dynamic MRI. Other routine investigations, including acute phase thickness, were unremarkable. RF and anti-CCP were negative. Prescribed NSAIDs and gabapentin. Regional glossopharyngeal nerve block were given, with which he had a marked reduction in the pain. The mouth opening has improved, and he is stable as of now. Bilateral mechanics handling partial anti-synthesis syndrome. 74 male symptomatic for 11 years with symmetric additive inflammatory polyarthritis involving small and large joints, along with episodic self-resolving low-grade fever without chills and rigor for the last 3 years. Presented with difficulty in getting up from squatting position and lifting his hands overhead. No truncal involvement, no bulbar involvement, no cuff, and no other typical features of CTDs. On examination, he had bilateral mechanics sign. He had florid synovitis, and power in the proximal skull was 4/5 with no neck weakness. Respiratory and cardiac system unremarkable. Investigations were unremarkable except for increased acute phase ejection. Rho 52 and anti-Jo and RF were positive. He was given 0.5 per kg steroid and methotrexate, with which he had near complete resolution of arthritis and other symptoms. A 30-year-old male diagnosed as a case of systemic sclerosis based on generalized skin thickening, sclerodermally, PAH, and abnormal nail fold capillary finding. He had acute onset painless loss of vision in both eyes, progressive weight loss, uncontrolled hypertension, rising creatinine level without detectable autoantibodies. Started on MMF, tadalafil, remipil, and supportive treatment. NFC showed active scleroderma pattern. Fundoscopy revealed sheathing of retinal vessels with proliferative retinopathy. Fundus fluorescein angiography revealed retinal vasculitis. Kidney biopsy showed onion scanning of arterioles, thrombotic micropancreatic changes, and ischemic collapse of glomerulus suggesting of SRC. An 18-year-old male with history of recurrent oral ulcers, erythema-nodosum-like lesions over bilateral lower limbs, and intermittent episodes of blurring of vision of both eyes for the past 7 years, was managed as a case of Behçet's disease with oral steroid with suboptimal response. On examination, vision was 6/36 in right eye and 6/6 in left eye. Investigation revealed normal acute phase ejectants and positive pathology test. Ophthalmic finding revealed panuveitis with festoon pupil in right eye. Distant eye, right eye, distant vision 36 with normal left eye. Fundus fluorescein angiography showed characteristic retinal capillaritis, furning pattern, solid yellow arrow as shown here, resembling the frosted branches of a tree. He responded to infliximab and oral steroids. A 28-year-old man, resident of Afghanistan, presented with painless crusting lesion over right ear with bluish discoloration of skin, was diagnosed as sclerose ulcer and was given interlesional sodium stibogluconate but had no improvement. Past history of blurring of vision, recurrent oral ulcers and genital ulcers. Lesion was biopsied and histopathology was suggestive of lymphocytic vasculitis, endothelial swelling, and few neutrophilic debris consistent with Behçet's disease. Pathology phenomena was treated with adalimumab, to which he responded dramatically. A 65-year-old lady presented with chronic pain over right shoulder with swelling over the tip of shoulder. There was cystic swelling over the right acromioclavicular joint associated with minimal tenderness. Drop arm test was positive, suggestive of complete supraspinatus tear. Diagnosis was confirmed on USG. In case of long-standing full-thickness supraspinatus tear, synovial fluid tracks from glenohumeral joint to acromioclavicular joint to form a supraclavicular collection, which appears like a geyser and is referred to as geyser sign. A 25-year-old man with history of juvenile dermatomyositis since the age of 5 years, presented with acute pancreatitis. On examination, had diffuse atrophy of subcutaneous fat, phlevomegaly, and calcinosis cutis involving upper and lower extremities and face. Radiograph demonstrated circumscribed nodular opacities in the forearm, suggestive of calcinosis cutis. MRI thigh showed atrophy of subcutaneous fat with sparing of the medial aspects. Final diagnosis was acquired generalized lipodystrophy, also known as Lawrence syndrome, secondary to juvenile dermatomyositis with complications of lipotrophic diabetes, fatty liver disease, hypertriglyceridemia, and pancreatitis. A case of 70-year-old female presented with nodules over bilateral PIP and DIP joints of hands with contractures at those joints since last 4 years. On examination, she also had similar nodules over bilateral concha of the ear and nape of the neck. Serology for RA is negative, and the biopsy of the nodule showed cutaneous reticulohistiocytosis, diagnosed as multicentric reticulohistiocytosis. It is interesting owing to severity. Treatment with oral methotrexate and low-dose steroid has been started. 9-year-old child, previously healthy, presented with complaints of pain and swelling of left side of mandible, accompanied by decreased mouth opening of 10 months duration. Initially evaluated by dental surgeon and on biopsy showed features of chronic osteomyelitis and referred for further management. Diagnostic imaging through a whole body PET MRI revealed stir hyperintense lesions located within the left hemi-mandible, diagnosed as a case of chronic non-bacterial osteomyelitis, and she was commenced on naproxen injection pamidronate. She showed marked improvement in swelling along with improvement in mouth opening. A 62-year-old female presented with complaints of redness and nodular swelling in left eye associated with dull aching pain, was treated with topical steroids, empirical ATT therapy. Biopsy of the nodule showed plasma cell-rich chronic inflammation. IST showed positivity for IgG4 with the IgG4-IgG ratio less than 40%, but IgG4 cells more than 10 per high power field. Serum IgG4 was increased. She was diagnosed with possible IgG4-related disease, nodular scleritis, treated with methotrexate and oral steroid. No response, then Rituxan was added. 69-year-old male with 15 kg weight loss, ulcerated and necrotic skin lesions, recurrent nasal and oral ulcers, maxillary sinusitis with painless lesion over left side of tongue, referred in view of tongue biopsy showing medium vessel vasculitic changes. Review of biopsy showed atypical cells with ISC markers positive for CD3 and CD30, suggestive of anaplastic large cell lymphoma. A 49-year-old male presented with insidious onset progressive painful erythematous lesions on bilateral palms persisting for the past 3 months, underwent extensive evaluation and blood test revealed elevated ACE levels. Skin biopsy was consistent with granulomatous inflammation. After ruling out TB, he underwent a whole body PET MR which showed FDG, avid, supra and infradiaphragmatic lymph nodes uptake and bilateral parotid lesions. Subsequently, underwent an endobronchial USG-guided TBNA and which confirmed presence of granulomatous lymphadenitis. Thus, diagnosis of sarcoidosis was made. 60-year-old male with no prior comorbidities presented with 1-year history of migratory arthritis, recurrent episodes, painful erythematous swelling of both pinna and with tinnitus, 7 kg weight loss over 6 months and palpitation for 5 months. He received oral steroids and methotrexate 6 months prior to presentation, which he discontinued after 2 months due to non-response. On examination, all his peripheral pulses were palpable, no bruit. Both pinna showed flattening and loss of distinction between helix and antihelix sparing the lobule. PET-CT showed increased uptake in bilateral auditory meatus and pinna with increased vessel wall uptake in ascending aorta, arch and descending thoracic aorta, left circular artery without luminal narrowing. Inflammatory markers were high. He was started on 1 mg per kg of steroid with methotrexate. A 46-year-old female diagnosed case of limited GPA for the last 3 years presented to the clinic with history of progressive nasal blockage and nasal tone in her speech despite multiple visits to ENT surgeons. She was not on treatment for the last 2 years for her GPA. There was depressed nasal bridge and absent nasal septum on examination. Lab findings revealed microcytic hyperchromic anemia with raised inflammatory markers, high ESR and high CRP, and anti-proteinase 3 was positive, titer suggestive of active GPA. She underwent CT-PNS, which showed destruction of nasal septum along with nasal part of maxillary sinus on either side, resulting in a large single nasal cavity formation. No other organ involvement was there. On screening, steroids and methotrexate was started. She reported a negligible improvement in the nasal obstructive symptoms, but her inflammatory markers and anti-PRT levels, they came down. 59-year-old male presented with 10-year history of progressive deforming bilateral knee joint pain, swelling, skin ulcers in 6 months, weight loss since 2 years, hydronephrosis, previously treated with methotrexate as rheumatoid arthritis. PET-CT showed FDG, avid osteolytic lesions in bilateral distal femur, proximal tibia, fibula, tarsal bones, renal pelvis involvement, and pancreatitis. A deep skin biopsy showed atypical neoplastic cells with nuclear grooving, eosinophil dermis and epidermis, with positivity for CD1A and S100 and cyclin D1, suggestive of Langerhans cell histiocytosis, given cladribine-based chemotherapy with significant improvement. A 14-year-old male child had history of headache for 2 years and progressively increased myopia for 2 years. In May 23, he had blurring of vision in right eye, which gradually progressed to finger count at 1 meter over 10 days. Had similar complaint in left eye, which gradually progressed to finger counting at 6 meter over 15 days. On examination, intraocular pressure was increased in both the eyes. Fundus fluorescein angiography had shown picture of diffuse retinal vasculitis, as shown in figure 1. Patient later underwent bilateral eye trabeculectomy. following which IOP had normalized and headache improved, but vision had not improved significantly. Patient was started on steroids, which were gradually tapered over 3 months, and there was an improvement in retinal vasculitis. On workup, HLA-B52 was positive, so patient was kept the possibility of Behçet-associated retinal vasculitis with glaucoma. A case of 56-year-old presenting with necrotizing vasculopathy, AKI angioedema, after receiving treatment for cellulitis with amikacin, augmentin, and aspirin, with prior history of acral paresthesia and recurrent episodes of epistaxis since 6 months. Vasculitis serological workup was negative. Skin biopsy done has revealed multibacillary leptometrous leprosy involving deeper tissue, including muscle, with vasculitis representing Leschio phenomena. It's an interesting case which presented as drug-induced vasculitis with history of neuropathy and epistaxis turned out be untreated leptometrous leprosy presenting with Leschio phenomena. 25-year-old female newly diagnosed as SLE with manifestation of severe acute cutaneous lupus erythematosus, ECLE, 10-like manifestation involving 65% of body surface area, with fever, pancytopenia, and significant proteinuria, class 3 lupus nephritis and biopsy. Figure is showing diffuse dusky erythematous rash with crinkled appearance, with flaccid hemorrhagic blisters and large area of denuded skin. The rash involves the face, oral mucosa, eyelids, genital mucosa, and trunk. DLE lesions on scalp and pinna were noted. IVIG started with steroids. Supportive care were initiated, following which there was improvement. There was improvement with repathology of the denuded skin. She was given modified NH, cyclophosphamide regime, with which she has shown improvement with scarring. A 42-year-old male presented with a 5-month history of inflammatory backache, inflammatory oligoarthritis, nail and scalp psoriasis. The upper figure shows extensive nail pustular psoriasis with nail crumbling, onycholysis, and subungual hyperkeratosis at the presentation. He was started on methotrexate, NSAIDs, and topical medication, with which there's improvement in the nail changes. This figure showing well-defined rounded cutaneous ulcers over the extensor aspect of bilateral elbows, predominantly over the olecranon process, and figure B showing well-defined ulcers with raised edges around the memory area. The above two images define cutaneous ulcers in a 56-year-old female who presented with 1-year history of cutaneous ulcers, arthritis, early ILD, alopecia, inverse Gauthron's, and telangiectasia, and on evaluation had MDA5 positivity without any definite muscle weakness. Patient was started on steroid and tacrolimus in view of this persistent ulcer, with which patient has shown improvement. So these were these 30 images. Now I can take a breath.
Well done, well done. So actually, I have submitted the results, and Dr. Sharath or Dr. Moli Taba would be announcing results at the end.
Thank you.
Thank you, Dr. Yojana and Dr. Devendra Bairwa. In the last 2 days, we have discussed 40 cases, oral presentations, and rapid fire. But in 20 minutes, both of them gave 30 extra cases. So, for a period of 2 days, we discussed 70 plus cases. Thank you. And without wasting your work, all the people who have submitted, I told you around 260 plus, we have received either abstracts or the images. And to make it permanent, we made the book available. I think you have all souvenirs. I spent 6 lakhs to print the souvenirs. Please take them with you. And also I have sent the soft copy, a PDF, I shared it in the group. And the whole 2-day session is going on live. Today morning when I noticed that actually 1900 viewers watch the YouTube. And this is, all these meetings, are available throughout our life. Yeah, because the YouTube, 2019, 2022, 2024, all are available on YouTube. Permanent, recorded. Thank you. Now I call upon the quiz masters. Today we have the final round quiz. I hand it over to Dr. Siddharth Jain, Shaunak Ghosh, and Namrita Gopalan to take over. can I request all the 6 people who are yesterday's winners in the preliminary rounds to come and occupy the front row chairs. I request the senior faculty to move back a little bit to the next row so that those 3 winners can come into the front row. Please announce those 6 winners.
So since by the time we conducted the prelims yesterday, a lot of people had moved out. So yesterday we had an interesting round of prelims. We had around more than 60, 70 participants, and out of them we managed to shortlist top 6. Shortlisting the 6th one did require a tie-break as well. Such was the level of competition between the trainees. The level of the quiz was not that easy, but the amount of scoring that we got is reflective of the high quality of training that is being provided at all centers. So I'll now ask Shaunak to announce the top 6 candidates that we had finalized yesterday, and we'll ask them to please occupy the front row, middle seats.
Perfect. Thank you, Siddharth. So welcome to the final mains rounds of the quiz. I'm just going to call the 6 of you in no particular order. So starting with Dr. Ishraul Haq, please come down to the first row. Congratulations for being selected for the top 6 contestants for the quiz mains. Next up, we have Dr. Lakshmi MR. Please come up to the first row as well, Lakshmi. Dr. Prudvi. Dr. Prudvi, please come up to the first row, the 3rd contestant for today. Dr. Nidhish Chandra. Come up, Nidhish. Dr. Sanjay Prithviraj. Yeah. Well, I'll Dr. Sanjay, come up. Hi. And finally, we have Dr. Augustine Jones. So guys, before we begin, before I hand over the mic to Siddharth for the rules on the first round, could you just introduce yourselves one by one? Could you hand over the floor mic to them, please?
Good afternoon. I am Dr. Israrul. I am from IPGMR SS Camp, Kolkata, 2nd year resident.
Hi sir, I am Dr. Augustine Jose. I'm Dr. Augustine Jose. I'm a 3rd year resident of DM in Chipma, Pondicherry.
Good afternoon everyone. I am Dr. Lakshmi, 3rd year resident at SDPGI Lucknow.
I think the mic is not working. Yeah.
Hello.
Yeah.
I am Dr. Prudvi. I am a final year resident at Amrita Institute, Kochi.
Good afternoon. I am Nidhish Chandra. I am 3rd year resident at KGMU Lucknow.
Sanjay from KGMC Lucknow.
Perfect. Thank you so much and welcome to the finals, guys. I'll be handing over the mic to Siddharth now. There's going to be a bunch of rules, so keep your eyes on the screen, make sure you understand the rules, and then we're going to begin. Siddharth, over to you.
So we have an interesting set planned today, so keeping the time limitation at hand, so we've tried to make the maximum use of the time that has been allotted to us, and we've tried to vary around with the set of rounds that we are usually used to, and I hope everybody in the audience, not just the participants, have a lovely time after having racked our minds with such difficult cases over the last 2 days. So this will have, so participants, please, want all of your attention. So we have 3 rounds, but we will be shortlisting 3 out of you after the first 2 rounds itself. So all of you would be participating in the first 2 rounds, and after that we'll be shortlisting the top 3 who will then participate in the final round. So as we can understand, so in order to have the maximum utility out of the 40 minutes allotted, so in the first round there'll be 6 questions and all 6 of you would be answering all 6 questions. Understood? So, and the scoring would depend upon how many of you get it correct. So first is the clinical round. The second would be the rapid fire, that will be individualistic. And then we'll shortlist the top 3 and then we'll go to the Jeopardy. And if we've heard about the ACR Knowledge Bowl, I think everybody would be familiar with what is Jeopardy. So are things clear? So coming to the first round, So that's the clinical round. Please go through the rules very carefully. As I've said, there'll be 6 questions, and all of them will have subparts, either 2 or 4. And all of you have papers. Please write your names on all the chits of paper. And there'll be, for every question, you'll write your option numbers or answers in the paper sheet. Don't have to mumble, don't have to announce. We'll collect the sheets from you. There'll be 1 minute per question. Both the parts would be displayed together, and all parts inclusive, there'll be a 1 minute timer. And the scoring will depend upon how many of you get it correct. So if all of you are very skilled, then you get just +5 for every part. But if one of you is smarter than the others, there's +30 to be obtained for every part. So as you can understand, so this is a very, very high scoring round. And if one of you is smarter than the others, then there's a high possibility to diverge even at this stage. And there are no negatives. So important to remember, no negatives. So even if you want to make a guess, make a guess. Understood? So as soon as I display the question, write it on the sheet, and our fellow quiz masters will collect the sheet from you, and then we'll announce you the part-wise scores as they come by. All clear? So we'll start. We'll start? We are ready? So in order to facilitate and reduce the time, we'll be ranking you 1 to 6. So Isarul, you will be 1. Augustine, you will be 2, 3, 4, 5, and 6. That's correct?
Yeah.
So shall we start?
Write your serial number as well when you write the answers. So we'll be cross-checking.
So best of luck to everyone, and the top 3 have awards to win, and there are audience goodies as well. So maybe Amrita, we'll have the audience goodies here for the questions. So there are audience questions at the end of each round, and if the questions are not answered by the participants, they'll be open to the audience, and there are some chocolates and hampers for that as well. So I think with that background, let's start. Question number 1. So this is a 35-year-old lady who had presented with a 1-year history of insidious onset, gradually progressive shortness of breath, and small joint polyarthralgia. There were bibasal velcro crackles on examination. CT images as shown. 2-part question: what is the CT diagnosis, and what are you likely to find on the autoantibody testing? Whoever is done, we can collect. So whoever is done, please, you can submit. Otherwise, there's some time if you want to think, we can. So all of you have, Isarul, have you submitted? Everyone has submitted? So, what is the CT diagnosis? So yes, this is lymphocytic interstitial pneumonia, LIP pattern, and most commonly associated with Sjogren's. So the antibody we're looking for is Rho. So did everyone get it correct?
So part 1, everyone gets part 1 correct.
So very nice. So
you get, however, only 5 points for that.
Yes.
Everyone got it correct across the board.
That's the entire premise. So +5 to everyone for part 1.
And part 2 as well. Everyone got it correct.
So very, very, very nice. So which we expect from our final years. So +10 to all the participants. We move to question number 2. So this is a 24-year-old male presented with symptoms of hoarseness of voice and respiratory discomfort for the last 3 months. CT findings are as shown, part A, part B. And I'll give you a hint. The arrows, as they are supposed to do, they'll guide you. The questions are, what does the CT show, and what is your diagnosis?
I think we can collect the sheets now.
We have all 6.
We have 4. We need 2 more.
10 more seconds in case. So what does the CD show? Sorry? Tracheal? So what have they written?
So
the
show
exact
answers,
answer,
there's going to be controversies
so the
now.
precise answer for this that we were looking for is tracheobronchial chondritis.
Write your name or serial
Tracheobronchial
number, please.
chondritis.
So we have two correct answers.
Tracheobronchial chondritis.
Tracheal chondritis, tracheal plus bronchial chondritis. But there are other answers like tracheitis, which I do not think we can accept. Tracheal stenosis, and subglottic stenosis. So we have only two correct answers for part 1, coming from Augustine and Nidhish.
So just to justify, so as I said, the arrows will guide you. So you see there are multiple arrows. So it is not just subglottic stenosis, it is just not tracheal stenosis. And why chondritis is important is in part A, you see that only the anterior 2/3 of the trachea is thickened. That means that this is chondritis. Whereas if in disease pathologies like GPA, you will get circumferential tracheal thickening. So this was tracheobronchial chondritis. And what is the diagnosis? So the tracheobronchial chondritis, people got the diagnosis?
Yes, so in the diagnosis, there are 4 right answers. So part 2, people have written relapsing polychondritis.
Okay.
Written GPA, so they are out.
Okay.
So part 1, only Augustine and Nidhish are going to get 25 marks each.
Okay.
But in part 2, we also have Lakshmi, who has written relapsing polychondritis, and Dr. Pushti, who has also written relapsing polychondritis. So 15 marks to each of these 4 participants for part 2.
Okay.
Yeah.
Plus 15 to 4 of
4
them
people,
for part 2
and
plus
Nidhish
20.
and Augustine also get plus 25.
Five
So
for
this
part
is
1.
how the rounds get very highly scored.
So now it's clear how we differentiate GPA from RP. So that's why it was, so if I had given any other clue, all of you would have picked it up. If I had given a red ear, everybody would have said that. But picking it up just on CT for isolated involvements is very, very important because you may not get those classical external manifestations every single time.
Please write your names or serial numbers at least, guys, so that there's no confusion whatsoever.
So this I expect to be easy, but the challenging part is you have to get it all correct for you to get a mark. So this is a simple match pair. So you have 4 eye findings on the left, 4 diagnoses on the right. So when you write the answer, just match the alphabet with the number. So whether it's A1 or B2, that's what we want on your slips.
I think we can start taking the answer sheets, right? Two more.
So we have all of them?
Yep. Answers, please.
So this was fairly simple. So A is nodular scleritis, we get in RA. So B is a representation of how a slit lamp image looks. So this is anterior uveitis, cells being shown in the anterior chamber, Angst pond. C was posterior uveitis with retinitis, Behçet's, and D is the conjunctival staining for Sjogren's. So I believe all of them must have gotten it correct.
3 people have gotten all the 4 correct.
Oh, that's a surprise.
So the points will go to Dr. Prushti is getting it across the board. Prithvi, sorry, Dr. Lakshmi and Dr. Nidhish. So Nidhish, Lakshmi and Prithvi have gotten all 4 options
So where
correct.
were the errors, if I may know? I anticipated.
Others have gotten 2 correct, 2 wrong, just like we thought.
So it wasn't as easy as I thought.
Yeah. So 3 of you are going to get 20 marks each. The remaining 3, 0 for this question.
So we will get a divergence after this round. Yeah. But don't worry, there's scope for more. Next question, question 4. So we have a 30-year-old female present with generalized pain and fatigue for last 1 year. Read this carefully. And there was painful swelling of the small joints of the hand for 6 months. This bilateral MCP squeeze test was positive. There were fibromyalgia tender points, and the LFTs were found to be deranged. So some biopsy was done for this patient, which clinched the diagnosis. You have the histopath with you. We just want to know, very basically, which tissue is this a biopsy of? And if you were to do an ANA for this patient, what pattern would you expect on immunofluorescence? Read it carefully.
Submission time.
We have all 6?
No, we have 4. 2 more remaining. Right.
So what is this? So all of you got it correct? All of them got it correct?
Right. Nope. One is wrong already.
Okay.
3 correct so far.
Correct. Correct. So 5 got it
5
correct.
got it correct. So this is minus salivary gland biopsy.
Only Lakshmi got this one wrong.
So what did you
all
think
the
it was?
5 members get this correct.
What did
They
you
are
think
going
it
to
was?
get plus 10 each. For
Between?
each of them. So plus 20. to the
Liver,
rest.
no? So that's why I had put in LFTs were deranged. This was a last minute entry. I wanted to confuse. So I thought people will say it's liver. That's why the LFT derangement came in. Last moment. And what ANA pattern would you expect? So if you're getting the diagnosis, so we will expect that you'll know the ANA pattern as well. So ANA pattern, everyone got it correct?
Yeah, yeah. Everyone has
pattern,
got
everyone.
both pattern parts correct, except since she chose liver, she went for nuclear only. So
that's how
why she
one
missed it.
mistake leads to
Leads the
another
other one.
spiraling down.
So 20 points to the rest of you 5. 10 plus 10 for 2 parts.
Right, so plus 20 for rest of them. So next, again read this very carefully. A 25-year-old man from Punjab presented with on and off abdominal pain for last 3 months with development of skin lesions as shown. On probing, he had also noticed an hand crawling sensation over his feet and legs lately. Labs showed, I won't read it out, labs are as shown. And evaluation of the elevated transaminases showed HBsAg positivity. Read it carefully. So what is the likely diagnosis and how will you confirm it?
I think we can start collecting.
5 more seconds.
5 seconds more, all right.
I think we can collect.
Yeah, start.
We have all? We have all 6?
4. We have 4. 2 more.
I think time to give in.
Submit, please.
I can see from your faces it was not very straightforward. Do we have how many correct? So what is the diagnosis?
Any guesses before we show it?
How many have entered PAN?
3 correct and 3 have gone for the other way.
3 have gone for PAN.
Yep.
So that's what we had anticipated.
So we have Sanjay with the correct answer to both parts, Nidhish with the correct answer to both parts, as well as Augustine with the correct answer to both parts. So the 3 of them will be getting 20, 20, 40 marks each.
40 each.
Both parts correct, 3 members. 0 to the rest of them.
So the point of making this question as a quiz master was precisely this. I wanted people to precisely confuse with PAN. And if 50%, if I've managed to confuse half of the final years from the best institutes, I think I've done a good job as a quiz master. So why is it not PAN? So the morphology of the skin lesions looks like medium vessel vasculitis. HPV is associated with PAN. That's the default thing that comes up. There is some neuropathy as well. But look at the labs. You have RF positivity, you have a low C4, and you have a deranged creatinine. You have a deranged creatinine. That's where your antennas should go up. And although HCV is more commonly associated than Hep B with cryo, but Hep B can cause cryo. So if you looked at all the things closely, you would have gotten it. So last round, and I think this is all of our favorite question for this round. So this is trivia, and I think quizzes are incomplete without trivia. So 2 scientists in 1964 recognized an autoantibody in patients with RA that stained keratohyalin granules surrounding the nucleus in cells of human buccal mucosa, which they called X. The assay for X was difficult to standardize and thus did not find its way into routine clinical practice. Subsequently, a second research group demonstrated that RA sera recognized antigens in the stratified squamous layer of esophageal epithelium. They named these antibodies Y. They also had subsequent iterations for this assay, which utilized other forms of stratified squamous epithelium, including the human skin. And just like X, the assay for Y also did not find its way into routine practice. However, when people started identifying the target antigen for these antibodies, they found out that IgG from RA sera affinity purified against a 40 kilodalton protein, which we are naming as Z, was reactive in both tests for X and Y, demonstrating that both these autoantibodies were targeted against this protein Z. And further research along these lines culminated into the development of an assay, A, for the diagnosis of RA. So now with this premise, I want you to spend 30 seconds on this. I want names of X, Y, Z, and A.
There are 5 marks for each part, 10 marks for each part for a total. Every part is one answer, right? One full answer.
Yeah, so each
5
part,
marks each, starting.
So there's a maximum scope of 120 if somebody is very smart.
Each part is one complete answer, like they had 2 in the other ones. So take your time, answer.
Plus 120 up for grabs. We'll give you 15 more seconds for this, I think. Or maybe 20. Ready? I need some time.
10 more seconds, fine, 10 more seconds.
We'll give you a discount on this one. Because this is a lengthy question, so we are giving you time. But final 10 seconds now. If you know it now. Otherwise, you don't. Please submit.
Yeah, submit.
So anybody confident about what they've written? Confident? Anybody confident about what they've written? No. Yes. Yes. And last? Nice. So that's actually quite impressive. How many got correct?
So there's only Sanjay who has gotten almost all correct, because for Y he has not written anti-keratinocyte antibody.
What has he written?
But keratin. But the rest
I think we can give him. We'll give him that.
So he got perinuclear factor, filaggrin, anti-CCP, and wrote keratin. So all 4 correct. But before we announce the weightedness of the points, there are other controversies as well.
Yes.
So we
anti-CCP must have been answered by. So
board.
X is anti-perinuclear factor. Y was an anti-keratinocyte antibody. Z was filaggrin or citrulinated filaggrin. And A is anti-CCP. So this is the discovery of anti-CCP assays, how it evolved, how was the research that panned it out. So what are the
Sanjay deserves plus 30 for X at least. No one else has gotten perinuclear factor right. We are
fine.
100%
So plus 30 for X.
So for first answer, plus 30 only to Sanjay.
Fine.
Now, coming to the next one. No one else has gotten keratin either except Sanjay. So I think
we'll give it to him.
30 to
Yeah,
him
we'll give it
as
to
well
him.
for part 2.
Yes.
So we have...
What is it?
Isharul has written flagellin and not filaggrin. So I don't think that will work. It's a completely different protein.
So it just tells me he has
again,
read it
Sanjay
somewhere,
gets
but he
another
does not
30.
know. Oh, very nice.
Yeah.
Anti-CCP, I think you would have in many.
No, vimentin, citrinated vimentin. No one else has written filaggrin for Z. No.
So filaggrin is actually filament aggregating protein, filaggrin.
It's only Sanjay. But for part 4, we have 4 correct answers. 5 correct answers. So Isharul, Sanjay, Prithvi, Augustine, and Lakshmi, all of them have gotten ACCP. Nidish missed it by rheumatoid factor. So 10 points to everyone for part 4. But of course, 30, 30, 30. So 90 extra marks goes to Sanjay for his wonderful performance in this round. Well done.
So plus 100 to Sanjay in this round.
Yes.
In this question.
Last.
So basically, the history in rheumatology is very, very fascinating. and it all becomes trivia. If you look at how steroids were discovered, compound X, etc., it's beautiful. And all of these assays, how they've really come into being, it's very fascinating, because what they have done 6 decades back is what we are doing today for newer diseases, but fast, streamlining it very fast. Now, instead of taking many decades, we are doing it in many years. So I think it was, that brings us to the end of round 1. And I think we really had a very nice round. So a round of applause for everyone. And before we hand over to Shaunak and Amrita for the scores of round 1, we have an audience question. So I think fairly easy. 48-year-old lady, Sjogren's syndrome, arthritis, ILD, Zika, paratodomegaly. Given rituximab for ILD, no adverse effects on day 1, patient went home. Comes back 5 days later with this rash, right knee swelling, has low serum C3, C4 levels, low serum albumin, some microscopic hematuria. What is the diagnosis? Herein. Because of? And what do you see in the labs? No, you get your prize. I'm just trying, because this is an educative thing, so. What does that suggest? That it's an immune complex driven hypersensitivity, that is type 3 hypersensitivity. So I think you'll get your whatever award is there later. Huh?
Are there chocolates? I think they were.
So we'll give it to you later. So we'll hand over for the scores for round 1. Huh? Yeah. And we would like to thank our volunteers for this exercise. So the way we had designed this round, collecting the chits and organizing it, so I would like to thank our volunteers for their help in this one. And I'll hand over to Amrita for the scores of round 1 and then round 2.
So at the end of round 1, and especially based on the last question, things have swung around. So we have Isharul with 40, we have Lakshmi with 55, Prithvi with 75, and then up close we have Augustine with 120, we have Nidhish with 130, but as you all saw Sanjay's performance, he has shot up to 170 at the end of round 1. But this is still everyone's game, so that's how we have arranged the rounds. Over to Amrita. We need a timer for 45 seconds each set now. Okay, thank you.
So round 2 is one of our favorites, the rapid fire round. Each of you will get 5 questions, 45 seconds to answer, plus 10, minus 5, and 0 if you pass. So simple, straightforward. So we'll start with Dr. Israel. Mic for him. Let me know when you're ready.
Yeah.
Okay. Start the timer. What is the first E in Selena Sledai?
Pass.
True or false? In dry eye evaluation, lissamine green is used for corneal staining.
False.
Which type of abnormal amyloid protein is deposited in meninges in patients with sporadic cerebral amyloid angiopathy?
Pass.
What test would you do in a patient with familial PAN, which is young onset and multiple relapses?
Data 2.
Bilateral salivary gland enlargement, infiltration with CD8 lymphocytes, Zika, HIV. What condition am I talking about? We could revisit your past questions if you want.
Sjogren.
Right. So the answers, the Selena Sledai, the first E stands for estrogen. Safety of estrogen in lupus patients. So in dry eye evaluation, lissamine green is used for conjunctival staining and fluorescent staining is used for cornea. A beta amyloid is deposited in the meninges in patients with cerebral amyloid angiopathy. And this is well known, DADA2 or ADA2 deficiency for familial PAN. And the last one, we expected diffuse infiltrative lymphocytosis syndrome.
So you get 2 correct and 1 incorrect. So 15 plus 15 plus 10 minus 5. So
Right.
lissamine green was correct, DAR2 was correct, but in short you said Sjogren.
Right. So we'll move to Dr. Augustine now. Timer. What is A in IMAX? True or false? DAS 48 joint count includes temporal mandibular joints. In RIM trial, name an antibody that predicted a better response to rituximab.
MI2.
What was the first immune checkpoint inhibitor to be approved for the treatment of melanoma?
Ipilimumab.
What genetic test should be advised for certain Asian populations before initiating allopurinol?
B5701.
Right. So we are out of time.
Again, similarly, 2 right, 1 incorrect. It's HLA B5801. Really sorry, very close, but you also get 15 at the end of this round.
Added question, where is B5701? Huh? Back away. So that's why. So B57, B58 come together. That's where you must have confused from.
So the answers. So this is International Myositis Assessment for Clinical Studies. DAS 48 does not include TMJ. RIM trial, the presence of Me2 or Jo1 predicted a better response to rituximab. Ipilimumab was the first checkpoint inhibitor to be approved for melanoma, and as discussed, HLA B5801 before starting allopurinol. So we'll move on to Dr. Lakshmi.
Just check it that.
So Dr. Lakshmi, what is V in SAVI?
Vasculopathy.
True or false? Nephrogenic systemic fibrosis usually spares the face.
True.
Name one pivotal trial of romosozumab in osteoporosis.
Us.
Name the humanized monoclonal antibody which blocks A and F subtypes of IL-17.
Bimekizumab.
MSC associated with rapidly progressive ILD, skin ulcers without clinically evident myositis.
MDF5.
Good. So the...
Wait, do you want to come back to it? You have 15 seconds left.
Right.
Question, ask question.
No, I don't know.
So the answers, sting-associated vasculopathy of infancy, nephrogenic systemic fibrosis usually spares the face, hands and feet. We have 4 pivotal trials of romosozumab, frame, arch, bridge structure. Bimekizumab blocks both the subunits of IL-17, and MDA5 is the myositis-specific antibody with RPILD, skin ulcers and CADM.
So, Lakshmi, you got 4 questions right. You did not attempt the last one, so 40 marks to you. So, well done.
Right. Dr. Prithvi, the first one, what is HN in HN RNA?
Pass.
Name the trial in APS which used difference in endogenous thrombin potential as a primary outcome measure.
Next question.
Femister triad is a classical set of radiographic features of which disease? Name a new drug which has been recently approved by FDA as an add-on therapy for ANCA vasculitis.
Avacopan.
The DETECT algorithm for screening of PAH in scleroderma does not include right atrial area. True or false?
False.
You want to revisit any others? The first one? Second one? Right. So,
So, Prithvi, you have 2 correct answers, no negatives, so 20 marks.
So HNRNA stands for heterogeneous nuclear RNA. The RAPS trial, instead of using clinical events as an outcome measure, used the endogenous thrombin potential or the degree of anticoagulation as its primary outcome measure. Tuberculosis has the classic Femister triad. Avacopan was a newly added FDA-approved agent for ANCA vasculitis, and DETECT algorithm includes the right atrial area in its algorithm. We'll move on to the next one. Dr. Nitish. So what is O in SAPHO?
Prostatitis.
What is the most common antibody associated with primary membranous nephropathy?
PLAR2.
The landmark trial by Chan et al. Led to the use of which medication for lupus nephritis?
MMF.
Which caspase is involved in NLRP3 inflazome?
Pass.
True or false? ACR 2019 guidelines for OA conditionally recommend for the use of glucosamine in hip and knee osteoarthritis. You have 12 seconds more.
False. Fourth one, caspase 1.
Caspase 1. Well done. Right. So, SAPHO, the O stands for osteitis, as most of us are aware. Anti-PLAR2 antibody is the most common antibody with membranous nephropathy. Mycophenolate was the drug established by Chan et al. As an effective induction agent for lupus nephritis. Caspase 1 in NLRP3 inflammasome. And the ACR guidelines strongly recommend against the use of glucosamine for hip and knee osteoarthritis.
So you got all 5 correct. Perfect rapid fire.
Right, so the last, Dr. Sanjay. What is S in Vexus?
Syndrome.
The recent trials of fenebrutinib and evobrutinib have failed to meet the primary endpoints in SLE trials. What signaling molecule do these drugs target? B cell signaling molecule.
BTK.
Corticosteroid with highest glucocorticoid potency.
Dexamethasone.
Genetic mutation with FMF.
FEV1, MEFV.
True or false? Lupus pernio is usually seen on the chest.
False.
You want to revisit? He's already answered all? Okay. So S stands for somatic and not syndrome. BTK
that was our prediction.
So BTK was the right answer. Dexamethasone has the highest potency. MEFE is the gene with FMF. And lupus pernio is usually seen on the nose and the ears. So with that, we conclude round 2. So before we have the scores of round 1 and 2 from the quiz masters, we'll have one more audience question. So this is a 50-year-old gentleman with progressively increasing skin lesions and joint pains. Identify the diagnosis. Dr. Harsh? The reason for the answer? The mic, please.
In the X-ray, I think in the second digit, we can see a subchondral cyst, and the rash seems of more of lupus pernio.
Right.
Rash. So, and patient also has skin lesions. The clinical profile suggests of sarcoidosis.
So well done. This is a case of sarcoidosis, a bone and skin involvement, typical of lupus pernio. So chronic progressive sarcoidosis involves the bone, and typically these patients have lupus pernio-like lesions. So with that we conclude round 1 and 2. We'll have the scores in which we eliminate 2 of you, and the final 4 go on to the last round. Final three.
So we did have some fluctuations after round 2 as well. So after round 2, as I said, we'll select our top 3. So we already know Sanjay would be there because he did a good rapid fire as well. So we have Sanjay, who's leading at the moment at 205. Then we have Nitish, who is at second with 180, close behind, because of your perfect rapid fire that helped you. And in the third position, we have Augustine at 135. So for the next round, you 3 will be participating, and the other 3 will be an active participant in the audience. So maybe you can take your seats a row behind you. Well done, all of you. It was really an amazing participation, although it was just a 2-round thing. So I'll hand it over to Shaunak to explain you the next round, which is the final round, and which will decide our final positions. Still, if you would see how the quiz has been designed, still Sanjay can be toppled over very easily. So Shaunak, over to you.
So welcome to the last round of the finals today. We have a Desi Jeopardy round. You get to choose how many points you want to play for, standard Jeopardy rules. However, Higher the plus points, you expect a higher difficulty of the questions, and there are negative points as well. For example, if you choose the most difficult question from one of the 3 subheadings, you get to play for 60 marks, but you tend to lose minus 20 as well if you get it wrong. So it's either plus or minus. You don't get to just select 60 at the first round and then have luck on your side, okay? So choose wisely, guys, and I'm going to open up the grid now. So these are the 3 headings: metabolic bone diseases, primary immunodeficiency disorders, myopathies. 3 questions on each topic. The basket sets are divided into 20-mark questions, 40-mark questions, and 60. In order to maintain fairness, we are going to give the person who is in 3rd place now the first choice, then in 2nd place, and then first, and we are going to continue with that. So, Siddharth, could you just tell me who is there in 3rd place?
3rd is Augustine.
So, Augustine, you have the pick first. Choose one of these baskets, and we are going to start with the Desi Jeopardy.
So Augustine is expected. He will choose a 60, right? But which 60 will be the question?
PID for 20, 40 or 60? 40. Perfect.
So Augustine is playing it safe.
So we are going for the 40-mark question for PID. Here's your question. 45-year-old female, photo of her tongue, of her radiograph, and immunoglobulin levels. What is the diagnosis?
So we'll give you 30 seconds.
Yeah. It's either plus or minus. Silence won't get you a 0.
Hyper IgE.
That's your answer, hyper IgE.
Can you justify?
No, not really.
So it was a guess. All right, that's okay. However, sadly, that's the wrong answer. Anyone in the audience first before we announce? Go ahead, please. Excellent. Why? Stand up. So thymoma, pan-hypogammaglobulinemia, and oral candidiasis. So it's thymoma with gamma globulin deficiency. Good syndrome. Well done. Excellent. We'll have the chocolate sent over to you somehow. Excellent. So this was a 40-mark question.
So I have a question.
Yeah.
Why is there thrush here? Akash, you also raise your hand. No, why is there thrush? Hey, so this is pan-hypogammaglobulinemia, right? So do we expect thrush classically? So what does that suggest? So these patients, although it is classically labeled as thymoma with pan-hypogammaglobulinemia, there is defect in cell-mediated immunity as well in these patients. So the most common opportunistic infections in these patients are, you get a lot of CMV retinitis, you get a lot of thrush, you may also get TB. There are patients of good syndrome floating around in our setup as well, and they come with TB, CMV, and all of those infections. So even though it is pan-hypogammaglobulinemia, but if we do the cell lymphocyte functional analysis, you do a lymphocyte subset, we'll get a T-cell defect there as well. So Augustine gets minus 10.
10. Minus 10 to Augustine for a wrong answer for choosing 40 marks. No, 9. You fight to the death. So down to the first question. Who is in 2nd place?
Second is
Nidhish. So 2nd question choice to Nidhish. Select your basket. We are done with primary immunodeficiency disorder 40. So anything other than that. PID 20. Perfect. Autosomal recessive hyper IgE syndrome is caused by a mutation in which gene? Answer? We are going to give it to him. He got it right. So answer is DOC8. So you get 20 marks for the correct answer to the PID 20 marks question.
the amount of time you took, I am sure you were debating between Stat 3 and DOC8, no? The guess worked.
So we are done with PID for 20 and 40. Over to Sanjay. Your choice. PID 60. We are getting done with the PID questions first. Excellent. So
Sanjay is T20.
plus 60 or minus 20. That's the risk. 4-month-old infant presented with a history of failure to thrive and recurrent pneumonia. Oral cavity examination showed oral thrush, bilateral coarse crackles on chest wall on auscultation. You can see anemia with raised TLCs, platelet count of 1.8 lakhs. So you did a flow cytometry. You have the flow cyto images on the right. So what is the gene that is likely to be mutated in this infant? We are going to give you a couple of seconds to work this out. What is the likely gene mutated in this baby? I think we are running out of time.
10 more seconds.
Yeah.
NK negative, T negative, B negative, SCID. It is SCID actually.
Gene.
So, one.
Well done till now. So
it is B negative, NK negative, T positive. CD3, ADA2 deficiency maybe. I think it is ADA2.
very close, but no cookie. So
ADA.
Where you went wrong is you said it's B negative. Look at the top side. Sorry, you said NK negative. So it's CD1656 positive. So it's T negative, B negative, NK positive. So either we take RAG or Artemis. Any of them would be right answers. Almost worked out. Well done, well played, Sanjay. But sorry, -20 for this one. Next, back to Augustine. So next choice. We are done with PIDs. So myopathy topics or metabolic bone diseases? 60 MBD. Excellent. Here's your question. So 30-year-old lady, early loss of teeth, as you can see, hip groin pains. This is the X-ray of her pelvis. Her lab reports are also attached, so have a look at them carefully. What is the condition?
$20 seconds.
Five more seconds and we close this. Look at the labs.
Hyperphosphatemic.
Sorry?
Say it.
Say it.
You worked out something, so.
Hyperphosphatemic rickets.
Hyperphosphatemic rickets.
Familiar
Okay, we're going to close it there.
Let him say your final answer fast. We don't have time. No working out. Just say it.
Hypocalciuric hypercalcemia.
So, okay, we are going to close that there. Anyone in the audience with the right answer? Please, yes. No, not Sjogren's with osteomalacia. Yes. Please. Excellent. So, the lab reports alkaline phosphatase is low. We have been discussing. So, all of these questions basically, luckily, have been discussed over the 2 days with cases as well. So, alk phos going low, atypical femur fractures, other fractures, loss of teeth. It's hypophosphatasia. Anyone to know any blood tests to diagnose this? Anyone with answers? So sometimes you do check for pyridoxal phosphate levels in the blood or PPI going up or urinary PPI excretion as well. So moving on. So I'm sad to say you get -20 for this, Augustine, but well tried. Next question. Nidhish, choose your topic.
Difficult call.
Choose, yeah.
Go with myopathy 40.
Myopathy 40, all right. Here's your question for 40 marks, myopathy. So the IMAX and Printo groups, study groups, have designated certain outcome measures to be used as course set measures in clinical trials to assess patients with inflammatory myositis. What is the pediatric alternative to the MMT-8 score that has been validated for children with juvenile dermatomyositis?
CMOS.
Excellent, excellent, well done. Can you tell me the full form of that?
Childhood myositis assessment score.
Scale. I'll take that. Amazing. So 40 marks to Nidhish for this. Well played. You got this absolutely correct. It's the CMAS, Childhood Myositis Assessment Scale. Next, Sanjay. Next topic.
Difficult call.
Myopathy is 20.
Myopathy 20. 7-year-old girl with muscle and joint pains for 1 year, had this non-healing ulcer as you can see on the photo. There's also an X-ray of her lower limbs and an MRI with stir sequence image on the right side. I need the autoantibody you'd expect in her case.
An XP2.
Excellent. So 20 marks to Sanjay for the perfectly correct answer. Severe calcinosis, juvenile dermatomyositis, so NXP2 would be the antibody. Back to Augustine.
Last chance.
So what have we got left?
So you are out of myopathies 20 and 40, you're completely done with PID. So either you can choose myopathy 60 or you can choose metabolic bone disease 40 or 20. So MBD 60 has been out as well.
Myopathy 60.
Myopathy 60. So, question for you, myopathies, the toughest one of the lot, 13-year-old boy brought to the ER with sudden onset weakness of all his limbs along with reddish colored urine passage. The critical reports urgently done revealed elevated CPK level above 1000. Urine analysis also revealed myoglobinuria. Blood glucose was 52 milligram per DL. He was managed with IV fluid, IV dextrose drips and soon recovered. Follow-up done after 4 weeks revealed that lab parameters had normalized. CPK levels were normal, but 4 weeks after that, so 2 months from the initial episode, while playing football with his friends, he comes back to the emergency again. This time, similar emergency management is given. Also, a 4-arm ischemic test was carried out. There was a rise in both lactate and ammonia. Ammonia rose even higher at 6 minutes and 10 minutes. What disease am I talking about here? Take 20 seconds to figure this out. I know it's a long question for 60 marks. Your time starts now.
So McArdle's. Excuse me, sir. McArdle's.
Is that your final answer?
Yeah.
Fine. So well tried. Any reasoning behind that?
Not with the interpretation, not the lab.
Any reasoning? Anything why you chose? Clearly, you're expecting a metabolic myopathy, of course.
Episodic,
Any reason why you chose McArdle's? Before I say the answer, anyone from the audience would like a guess? No, it's not. No, it's not. Yes, please. Not mitochondrial, not mitochondrial. Guesses? Which one? Excellent. So this is carnitine palmitoyl transferase. But whether you say one or two, I would have taken either answer. So the reason it's not McArdle or glycogen storage disorder is glucose going down, episodes of starvation, exercise precipitating this, and usually questions with McArdle's would expect a sort of second wind phenomenon as well. So myoglobinuria is common to all of these. CPK rise in the worsening period is common. Intercritical period CPK goes absolutely normal, fatty acid storage disorder. Severe starvation exercise, worsening the attack, myoglobinuria, CPK going up, low sugar levels, and this can keep happening. But well tried, although I'm really sorry to say, minus 20. Done, time, perfect. Last 2 questions and then we end. So, Nidhish, options of MBD 20 or 40?
20.
20. So look at this X-ray, 45-year-old woman with diabetes, increasing joint pains in hands, plain X-rays are shown. Ultrasound, power Doppler, ultrasound revealed no synovitis. What blood test would you order to confirm your suspected diagnosis?
Serum ferritin.
Excellent. So the diagnosis is?
Hemochromatosis.
Great. Why?
Hook-like osteophytes.
Perfect. So hemochromatosis, hook-like osteophytes are seen. Ferritin is the right answer. And finally, Sanjay, you're left with only one 40-mark question from metabolic bone disease. Here's the last question of our quiz today. 52-year-old woman, ESRD due to diabetes, was on dialysis, peritoneal dialysis, presented with joint pains of her hands and these skin lesions. I want you to tell me the bone pathology. So identify the bone pathology marked by the arrow.
Adenoid bone disease, I guess.
What's your answer?
Adenoid bone disease.
Okay, so I'm sorry, that's the wrong answer here. Anyone with the right answer, and then we close. Yes, please. Great. So this is the brown tumor, osteitis fibrosa cystica or brown tumor. It's high bone turnover disease, and that is calciphylaxis, which can happen in any renal dystrophy. So with that, we come to the end of this.
Minus 10.
Minus 10.
Minus 10 for Sanjay.
With that, we come to the end of this round. So I would just ask for the marks tally so that we can announce the winner. But well played, guys. This has been a lot of fun. Amazingly done.
So we'll announce the winners in the valedictory. So we'll not reveal the winners now. Thank you everyone for your active participation. I hope you had a lovely time.
While they are trying to do it, we also let them forget.
I'll be announcing the winners of the oral presentation. So rheumatoid arthritis category, Dr. Nandita Golagotta from NIMS. SLE category, we have Dr. Harsh Jain. Pediatric, Israrul Haq. Myositis, Sri Harsha, Kim's Hospital. SP and crystal category, we have Dr. Augustine Jose. Vasculitis, we have from PD Hinduja, Dr. Ashish Agarwal. And in the miscellaneous category, we have Siddharth Jain from All India Institute, New Delhi. So these are the 7. We are giving only one best prize for the for the oral category. Now moving on to the rapid fire presentation. The first prize goes to Dr. Vimal from KIMS for presenting Fabry disease mimicking CNS vasculitis. The second place is Dr. Jagan for presentation of Candle syndrome. The third place goes to Dr. Arjun Kumar for presenting novel clinical presentation of Icaros related disorder. So congratulations to all the oral winners. Coming to poster presentation, in rheumatoid arthritis category, we have Dr. Gunasri from KIMS. SLE, Dr. Sri Lekha from NIMS. Pediatric category, Dr. Anirudh from St. John's, Bangalore. SPA is Dr. Ashish from Army Hospital. Myositis, we have Dr. Tejasvi from Max Saket, Delhi for neuromyositis. Then in the vasculitis category, Dr. Usha from, for presenting midline necrotizing lesion. And because vasculitis, we had a large number of presentations. There were more than 35 posters. So we have given a second prize also, which goes to Dr. Pragya from Sir Gangaram Hospital, New Delhi. And miscellaneous, the first prize goes to Dr. Anil Kumar Sahu from SCB Cuttack for presenting a case of adult onset asthma with periocular xanthogranuloma. And again, in miscellaneous, we also have given a second prize. Second prize actually is tied between two people, that is Dr. Sapan Pandya and Dr. Prakashini from Bhubaneswar. But I have not given prize to Dr. Sapan. So I was telling him you can compete with a younger person. But anyway, we have to commend him, you know, for presenting his case. And this just, Dr. Sharan and I were just telling that probably in this conference, age is no limit. So even faculty can also come forward and present their cases boldly like Dr. Sapan has done.
Yeah, I want to say something, Dr. Sapan. This is a this is a platform where the younger students compete with their teachers. So utilize this. So I got a call from Dr. Ranjan Gupta, Dr. Sharath, if my case is selected, can I present? I said, come on. No, teachers and students compete in this platform. It's the right platform. If you have a good case to showcase, this is the platform for you. Thank you.
And in the image category, this is the quiz, sir. Can you tell the quiz? This is the quiz.
What is your
image?
Next image, image competition.
Like Yojana ma'am was telling, images is very difficult to choose. So in addition to top 3, we have also given 4 other jury's choice prizes. So the number 1 is basically goes to Dr. Rajat Ranka for chronic facial ulcer in anti-MDA5 dermatomyositis. Second is Lucio phenomena, Dr. Mohit Kumar Reddy. Third is Dr. Usha Holla for presenting Langerhans cell histiocytosis. She's from Bangalore, Manipal Hospital. And another prize, and the consolation prize, that is jury's choice, Dr. Israrul for presenting calcinosis of the left thigh. And the second consolation is ear pathology, Dr. Hiren Kalyani. And the third one is basically Dr. Sachi Hardy from JSS Medical College for presenting juvenile MDA5 dermatomyositis. So 3 images, consolation, and 3 prizes with cash prize award. So thank you all. Image is this, sir. That is for the quiz. Image I have told, sir. So this is a score sheet which Shaunak and Siddharth has given. So first quiz winner is Nidish.
With a score of 260.
Score of 260. Second is Sanjay, 195. Where is Sanjay? Congrats. And third one is Augustine Jose with marks of 85.
Congratulations to all. Yes, sir. We're going to, vote of thanks, we're going to mention that. Because I'll stay back for not more than 2 minutes. Because actually, officially, should be done like a ceremony in the prize presentation. Because the lack of time, just to be, she has read all the winners. Sorry for that. We haven't got time to take pictures with the mementos and the certificates. But you can collect the certificates from here on this table. Quickly, vote of thanks. As I told you earlier, this is the first time in rheumatology meetings, conferences. Go back to the first slide. This conference is endorsed by the national boards and also the National Medical Commission, and also we're done in association with IRA National Chapter, Hyderabad Chapter, and also Indian Pediatric Association. Next slide. And I thank all the dignitaries at the time of inauguration. They were there, Dr. Minu Bajpayee, Dr. Bhaskar Rao, our President, Dr. Chandrasekhara, Scientific Committee Chairman, Dr. Moli Taba, and Dr. Raj Kiran, Joint Organizing Secretary. I thank all I'm not reading the names because to save the time. I thank all the chairpersons, panelists, debaters. You have all done a wonderful job. Thank you all. Next slide. All the presenters, without you, the conference wouldn't happen. I thank all the people who have sent their abstracts for this conference. So I thank all the presenters. They're basically actually they are the winners because these are all top 4 in each category. Thank you all again. Congratulations. And in the background, we have a lot of judges and abstract reviewers. You can see their names here. Abstract reviewers, image reviewers, poster judges. They've done a lot of background work to select the top winners in each category. Thank you. Next. And this organizing committee, I thanks all the patrons and the organizing committee members for supporting this event. Thanks. Next. And special thanks to Moli Taba. Always, all the time, she's available to me. Okay. For the past 1 week only, I have sleepless nights. Probably for the past 2 months, she hadn't got a good sleep at all because she was doing all the, directorship work background. All the time, she was available when I had a query. Thanks to your team, Dr. Moli, Dr. Bharat Kumar Singh, Chengappa, Midhun, Ranjan Gupta, and Dr. Sakir Ahmad. Thanks, all the scientific committee team. Thank you very much. Next. I also thank Fani Kumar and other reception committee members. Thank you. Next. And I thank my team of doctors, Dr. Sriharsha, he's a consultant now, and Dr. Ruby, Srilekha, Vimal, Gunasri, and Mohit for supporting me all the time. Next. And also I support my team, especially my right hand, Mr. Naveen. Come here. He's always there for me, for anything. So for the success, most of the credit goes to him along with the scientific chair. And also Janvi, please stand. Where are you? Okay, she is there in the cabin. She's actually making PowerPoint now also. Thanks, Dr. Janvi, and other team members in my department. Thank you all once again. Next. And special thanks to our CMD, Dr. Bhaskar Rao, Dr. Abhinay, CEO, Dr. Sambit, Medical Director, Bhavkant Reddy's crew, and the accounts department, and Srinivas, you have seen the souvenir. The souvenir is prepared. Of course, we gave all the material, but you can see the design of the souvenir. It came up very well. The hard work is done by Dr. Srinivas. He's one of our scientists in KFRC. Give a big hand to him. And branding team, purchase team, and F&B, they provided good food and good ID support, and electronic media, and also the photographers, housekeeping department, and also all the rest of the delegates and the faculty, and also all the rest, departmental. Some of the departments I couldn't mention because I don't remember. I have taken their help, but I forgot to mention in this slide. I thank you all once again. Anything else? And this is the last but not the least. I thank from bottom of my heart all the former people. Can you all please stand up who are there? Please stand up. Give them a big hand. We don't see any former sponsored lectures or not even former brands here. The biggest support is IPCA, followed by the next best is Hetero. The other people are a bit small players, but without their help, it couldn't have happened. I thank all the former guys. Thank you very much. Next slide. Okay, this is for the next conference. I see you all again in 2026, January 3rd and 4th. Maybe the conference hall could be here or somewhere else. It all depends on the number of delegates we're going to have. Thank you all. And if you have anything to say, feel free to say. Thank you very much. Thank you. Dr. Sapan want to say something. I also request Dr. Pratibha Lakshmi. She is our Telangana Medical Council, academic department chairman.
So with your permission, before I say about the conference, I'd like to congratulate our undergraduates who come all the way from Ahmedabad, 4 of them. Pranshu, Stuti, Kalp, and Alesh. So they have MBBS, under MBBS people, they have posters here. They've come with posters. For the conference, Sharat, the 3 things that I want to say, the format, and I said that in the media. I've attended quite a few conferences, and URK sir knows we've been on the first benches. I don't have any doubts this is the best format that I've seen in any conference in the world. And such kind of audience participation, we have separate 8 minutes for the audience. So that's number 1. The second is the plethora of cases, and I think Jyoti summarized it very well. I mean, look at the images. All of them are worth going to the ACR image competition, and I think we should. Yeah. So I think we should take this up. I don't know if the IRA will do it, but I think Sharath himself can do the image bank thing, you know, the IRA once had planned. So I think that's the other thing, the plethora of cases that we've had. And Jyoti said it's like the textbook of rheumatology being revised over the last 2 days. And for it to India to showcase the kind of cases we have. So that was the second. Yeah, that's what. Better actually. And the last is the hospitality, of course. Thank you for all of that. The 3 suggestions I would have, because it's always good to have suggestions. One is the rapporteur, of course. I think we can wrap up the rapporteur and have something else, some kind of a smaller summary, because by that time people had. The second thing I told you, I think the tea break should be the students and faculty together, because students might want to interact. We have a separate area. Maybe this hall arrangement doesn't allow that, but maybe we can have them together. And the last is wine and dine should be with our own, as you had earlier planned, our own people showing their talent in the form of singing or anything. So the lastly, I would say for people who have not come, मंजिल तो मिल ही जाएगी, भटक कर ही सही, गुमराह तो वो है जो घर से निकले ही नहीं. Thank you.
Dr. Pratibha Lakshmi from NIMS. She is our Telangana Medical Council CPD chairman. On behalf of TMC, she would like to share her feelings about this conference.
Good afternoon, everyone. First of all, I would like to thank Sharath sir for giving me this opportunity. I am the CPD committee chairman of Telangana State Medical Council. You all must have received the CPD credit hours, and there you can see Dr. Pratibha Lakshmi, my signature. So this is what Telangana State Medical Council or National Medical Council wants the doctors to continue their professional development with. Previously, it was continuing medical education, which was like giving lectures here. But it has been changed to continuing professional development so that there will be some interactive sessions. And this is the best conference I have attended till date. Just in the last two days, almost all of the rheumatology was discussed, and there was great discussions about every case. There was a lot of debates also, which were very productive and very useful to the students. And that is the reason on behalf of NMC, we want all the doctors to continue their professional development by attending these conferences regularly. And that is the reason we have made a rule that you have to have 30 credit hours in every 5 years so for your renewal of your registration. So thank you, sir, for giving me this opportunity. I hope you will all continue to join conferences like this and continue this learning process. Thank you.
So quickly, anyone wants to have something? Few seconds each.
Thank you, Dr. Sharath, for organizing such a nice meet. I have been to all 3 editions. What I can say, this is one of the formats which allows the younger and upcoming rheumatologist to put their points, their cases, and through you, we are learning a lot. So I can say so many cases that I saw in this edition, the last edition. Me and Dr. Ashok Kumar, we were going together last time, and we were saying, I don't know whether we will be able to diagnose them or we have missed so many. So that tells us through your eyes we are learning more. Probably we would have gone through our textbook not learning anything, but when you present this type of cases, you show us the truth about it's not so easy, in rheumatology. There are a lot of new cases and new challenges, and we all need to update, upgrade on a continuous basis. Thank you, Dr. Sharath, for such a fantastic platform.
Thank you very much. I'll see you all in 2026, next CRC. Thank you. Yeah, please join us for lunch. It's available. Faculty for the left side and delegates. Faculty on your left side. Sorry. Faculty on your right side and delegates for the left side. So, faculty, you had to, yeah. Khan, you had. I request faculty to go to this side. All the faculty, the lunch will be served like yesterday, the same place.